we see a huge amount of people coming with that diagnosis. What's interesting in Origin now is that 75% of those in the HYPE clinic, the clinic for personality disorders, are on stimulant medication. And for many of them, the BPD is no longer there. And one of my little, not digs, but sort of plugs is to say, I think everybody, before getting a diagnosis of BPD, should have ADHD ruled out. I'm not saying BPD doesn't exist, far from it. But, you know, it's hard convincing hardcore BPD people that, but Andrew Channon's coming around. I'm really trying to get him on that.
I have a couple of questions, if that is okay. I see patients who have had brain injuries during their developmental years. I've seen a patient who had severe TBI at the age of 18 months, another patient at the age of 9, and both of them kind of developed symptoms which would meet the criteria for ADHD. Now, there's this notion about secondary ADHD post TBI. So what is your take on that? Is there a causation relationship? And second, use of stimulants in patients with TBI, with the risk of triggering, or my fear of triggering, seizures or psychosis.
Yeah.
Thank you.
So on the first one, certainly people with traumatic brain injury can get ADHD. Doesn't have an etiological kind of condition on it, but I think these are secondary to the brain injury. On the treatment, I've treated quite a few people with quite severe TBI with no problems at all and great success. And so we've looked at the interaction between ADHD medicines and epilepsy, and even in those with ongoing epilepsy, they don't seem to have a big impact on seizure frequency, seizure threshold. So I don't worry about that. The risk for psychosis is actually pretty small. And what many people don't realize is that at therapeutic doses, the ADHD medications actually are more like antipsychotics than they are like stimulants at supratherapeutic levels. So the evidence is that risk is very low. But for those patients, you're going to be following them up very closely, and you tend to see things happen very quickly, and they also go away pretty quickly.
Thank you.
Thank you very much. I think we probably do need to move on. There may be some time at the end of the session to take more questions from Professor Coghill. But I'd now like to introduce Professor Valsa Eapen from Sydney, who's going to speak to us about Tourette syndrome. Thank you, Valsa.
Thank you very much indeed, Eileen. I'm having big FOMO, fear of missing out, because for the last 4 of these meetings that happens in the off year of the INA meetings, I've been there, and unfortunately this time that's not the case, but I'm still pleased that it has got this hybrid option for me to be able to join. So I'm going to consider Tourette's a little bit like what Dave was saying before about how these things kind of come in as a package, and why we need to be thinking about the various neurodevelopmental conditions that share a lot of genetic neuronal circuitry and other commonalities. No conflicts as such, but would like to acknowledge funding from NHMRC, ARC, and the Australian government. So firstly, I see some trainees in a room there, which I understand from Krish is from one of the medical schools, probably in Manipal. So I'm going to kind of go a little bit of a basic introduction to Tourette syndrome, which may bore the people who are senior faculty there, but I'm going to do it for their sake. And in order to make a diagnosis of Tourette syndrome, you just need to have multiple motor tics, 1 or more vocal tic, which has been there for more than a year, and the onset is before 18 years. So in a way, it's very much a neurological symptom that we are diagnosing, right? Although in essence, Tourette's is not just tics, and you're going to hear more about that. But in terms of the core diagnostic criteria, it's about tics. It's a movement disorder at the core of it. And ICD-11 has moved Tourette syndrome, as you know, to the neurological disorder section, although it's cross-referenced in the neurodevelopmental. But as we know, it's way more than just a movement disorder. So here is Gilles de la Tourette, after whom it's the eponymous, famous for the condition being after. The fan who described his Itard in 1825 described a French noblewoman, Marquise de Dampierre, and Georges de la Tourette included that case and then collected 8 more cases and then published a 9-case series. 90s to the 1960s, you would get, case reports in the literature. From 1970s and the 80s, cohort studies started to appear. The prevalence rate started to go up. 0.5 per thousand was the standard quoted prevalence figure in the 80s. But at the moment, we are kind of sitting at 1%, particularly in childhood, and most severe cases persisting into adult life, about 0.1%. Male to female ratio, 3 to 4 male to 1 female. But if I just did this or I did something, let's say, how do you know it's a tic, whether it's a stereotypy, it's a mannerism, it's something else? What would make a tic? First and foremost, a premonitory sensation. So if I did this as a habit or a mannerism or for some other reason or another movement disorder, there is no premonitory sensation. But typically in tics, you get an urge to do it. It could be either at the site of the tic in the form of a stretch or a tension or a tightness, or it could be in your brain, in your mind, saying that I have to do it. And often that urge followed by the tic, and once you do the tic, that relieves the premonitory. So that's very much a characteristic feature that you can look for. If that is present, then that would add weight to the tic being the case. Another characteristic feature is the waxing and waning course. At times, it's kind of really significantly there. It's almost a spot diagnosis, and then you go through a period of quiet times when hardly any of those tics are there. And you don't see that in any other movement disorders or in mannerisms or stereotypies. One type of tic getting replaced by another is, again, another characteristic feature. Because if you have a Parkinsonian tremor or a Huntington's chorea, then, of course, it stays there in one site. But here you'll have a blink, a twitch, a jerk. It goes from one side to another. Again, that is something that should tell you that you are dealing with a tic disorder. Another feature is the voluntary suppression. You can voluntarily suppress tics for brief periods of time based on the severity, of course. It could be seconds, minutes, sometimes the whole school hours. Teachers and others would say, I haven't seen anything. But the moment mom and dad comes, you jump on the back of the car or you get back home, it kind of gets back. That's because usually when you suppress it for a period of time, if you're able to, based on the severity, of course, how long you can do that, there is usually a rebound. And that again tells you that it is a tic. And the last one often lands them in a lot of trouble, suggestibility, because if you see one or if you hear about it, you will have to do it. And that echopraxia, or mimicking other people's tics, or you yourself when you hear about tics, doing it, again, lands them in a lot of trouble. And I've seen teachers they probably do something, a facial something, and then this young person sitting there with Tourette has to exactly mimic that. And of course, they are going to get into trouble for that. Stress and anxiety can make the tics worse. Again, for that reason, it's often labeled as, oh, that's something that they do when they are stressed, and the neurobiological condition is lost. When it is a tic, they are exactly the ones that lands them in trouble. If you don't know that it can wax and wane, if you don't know that stress and anxiety can make it worse, if you don't know that you can voluntarily suppress for brief periods of time, but don't expect them to continue doing it forever. So if you don't know those things, then these characteristic features are the ones that gets misunderstood. I'm going to show you a little bit of a clip, again, for the trainees' purposes, so that you know the variety of things that you might come across.
It feels weird because I'm in control of everything else. Why aren't I in control of that? Why can't I stop myself from doing that?
Like I have to go like that every single second. I just feel like kind of funny inside. I say like, why can't I stop doing this? Why can't I stop doing this?
I had a like a really loud screeching noise. All the kids would like tell me to stop and just keep staring at me. Stop it, and I would say, I can't.
Certain things trigger tics, and like, let's say reading letters, I guess. Like, every time you come to the letter P, you'd have to jump, like, on one foot, like that.
I'm doing it so much that it drains my energy, and I can't handle it, and I just get tired. It's also embarrassing.
You feel like a marked man, you know? Like, people would already know you when they don't.
The hardest thing is probably you can't make friends as easily as someone else who doesn't have Tourette's.
People stare. But you know what? You gotta just, like, let them stare.
So as you have seen there, the wide variety, and especially I want to point the attention to the young person who said every time you get to the letter P, you had to do that jumping and the dancing and a bit of a movement. And if you aren't having tics as a possibility, he's going to be not getting the diagnosis, right? They are not going to pick it up as a tic disorder. So it's a very complex thing, the complex tics, which can be very much misunderstood. And often they go from pillar to post, a lot of punishments and trouble before they get diagnosed. Some of the associated features, coprolalia.
Sorry, Walter.
I just wondered if we could pause a bit because it looks as if the video is running alongside your talk, so that will need to be turned off.
Okay, so you know what's happening.
There was an echo. Yeah.
Like a kid.
I think Valsa maybe got two microphones on.
No, don't. Is that stop now?
And now there's an echo, so maybe you have got two microphones on.
I'll stop share and then come back. I'll just go to the next slide and see whether I can pick it up from there.
Is there an IT person who could help correct the echo?
Is that finished? Is it gone now?
No, you still got an echo, I'm afraid.
Okay, all right. Okay, so I'll stop share and then come back.
Okay, can you just try speaking, Rosary?
Is that okay now?
No, it's
Oh gosh.
okay. Can we log out?
Could you delete the video from your presentation?
Oh, okay, sure.
No, I think
No?
it's just the microphone issues what we are facing now, because we can hear Professor Eileen very clearly, and I think we are very clear from here. So we'll just, can we just, Professor Valsa, can you just stop the sharing and start the resharing again? I think. Yeah. Or can you just log out and rejoin using the same link? I think that's going to fix the problem. That's what.
All right. Okay.
You have to just
All
use
right.
the same link. Yeah.
Yeah, will do. Sorry about this. I don't know.
Oops. So meanwhile, if somebody want to put the questions, we can put the questions on the paper. So when Professor Valsa is back, we can ask her. You joined? Yeah. Yeah. Can you try speaking, Professor Valsa? No, you are on mute. You have to unmute. No. Yeah.
Can you hear me?
Yeah. Clear.
Okay. All right. Okay. I'll just see whether I can. Sorry about this. So I hope I'm okay now without the echo.
Yes, you're fine.
Great. Yeah. So, so the clinical heterogeneity that we have in the kind of the varied phenotypes that you can get, obsessive compulsive behaviors to ADHD to all of the others, also might be kind of a sign of genetic heterogeneity. But can we find homogeneous subgroups is the question. And we know when you've got genetic loading, there is an younger age of onset. More often in the male sex, when you see prepubertal onset of obsessive compulsive disorders, you should be thinking about the possibility of tics. And clinical symptoms may also give us the clue if it is due to the Tourette family of obsessive compulsive behaviors or a primary OCD. In Tourette's, you get symptoms like evening up, like if you do something here, you have to do it there to make it even, forced touching, arithmomania, or counting compulsions. Whereas in obsessive compulsive disorder, you see a lot more of the dirt germ contamination fears. There is a cognitive component to it. There is a rumination or a thought process, and there is significant distress or anxiety when you don't do it, which is not the case in the tic, which it just happens, and or they just kind of do it to get it just right. Doesn't have that cognitive component of why they are doing it, or they have to do it in a particular way. If you see those kind of symmetry, evening up, forced touching, just right compulsions, doing it to get it just right, then again, the Tourettic disorder family should be thought about. In terms of genetic underpinning, when we looked at complex segregation analysis of first-degree relatives, one of the things that came out was that Tourette genes may express itself through an OCD, OCB phenotype in female members of the family, while male members of the family may have more of the tics and the ADHD. So there may be a sex-dependent difference in the way the putative genes may be expressing itself. So it's one end, there is the genetic underpinning, and the other end, there is the clinical manifestations of the phenotypes that we see in clinics. Is there something in between, as like an endophenotype, that we can look into? So when we looked at the neuronal circuitry that underpins the tic genesis and expression, of course, we all know about the corticostriatal-paldo-thalamo-cortical circuitry. But within that, the tic-Tourette part may be more linked to the sensory motor loop, the putamen and the sensory motor cortex, whereas the OCD may be more linked to the orbitofrontal cortex and the caudate nucleus. But can you tell the difference? So in this study, we looked at neuroimaging in primary OCD versus those who had various phenotypes within the tic-Tourette context. So the proband had Tourette syndrome, maybe a first-degree relative had just obsessive compulsive behaviors or disorder, another may have had just the tic. So regardless of what phenotype the family members had, if you were coming from the tic family, then we found hypoperfusion. Whereas typically in OCD and also in our primary OCD cohort, what we found was hyperperfusion and hypermetabolism. But that may be indicative of that distress and the anxiety, whereas the hypoperfusion and the lack of anxiety seem to go together with the tic family of symptoms. So if we then look at what the neuronal substrates are, of course, any movement disorder, we come back to the basic ganglia structures. And facial tics may be a failure of inhibition of the mini circuits involving the ventromedian area of the caudate and the putamen. And that's because if you remember your homunculus and the anatomy, that's the area of the brain that receives the topographical projection from the orofacial region of the primary motor premotor cortex. If you're talking about coprolalia or involuntary swearing, the pre-postrolatic language areas and the insula comes in. Impulse dyscontrol ADHD, the dorsolateral prefrontal cortex comes in. Obsessive compulsive behaviors, the basic ganglia limbic mini circuitry comes in, and autism, of course, the social brain network, which I'll come to. In this review, is linked to the event. None of them are specific for any of these conditions, but the way in which they operate and regulate and the same goes for neurochemical involvement. Definitely any movement disorder start with dopamine, and we use dopamine blocking drugs to treat. We also include the noradrenergic system because clonidine, which is synaptic alpha adrenergic drugs, in particular as the first line, he brings in the serotonin, have synergistic or inverse relationship with each other.
Recording in progress.
Group A beta hemolytic infection, get composite A or tics. And in about 10 to 30% of cases that we see in clinics, you will get a trigger by a streptococcal infection. But that doesn't necessarily mean antibodies formed against the bacterial antigen cross-reacts with the basic ganglia antigen to produce anti-nuclear antibodies. And in a person, it can unmask or it can trigger the OCD, tic, ADHD type of symptoms. And we say it may not be of primary etiology because when you look at the family members, the first degree relatives of those who are presenting following a streptococcal infection, you get higher rates of ADHD, OCD, tics, and the related neurodevelopmental phenotypes. So then the next question that often comes is the movement disorders a bit like myoclonus, or is it a type of epilepsy? Is there any relationship with it because of the jerky movements? Myoclonic tics and myoclonic epilepsy, is there a relationship? The answer is no. There is no specific EEG abnormalities, and there is no increase in the occurrence of epilepsy. But what you find in EMG studies is that if I'm moving my hand as a willed movement because I want to move, there's a lot of back and forth that happens very, very quickly, though, not in a conscious awareness, but from the part of the muscles that should help me move and the part of the brain that receives this topographical projection about, is it safe to move? How much should I move? Am I going to hit someone? All of those things happen very, very quickly. And that willed movement or the volition or the preparedness of the movement is picked up as an action potential called Bereshev potential, which shows that this is a willed movement. But if you're doing it as a tic, then that Bereshev potential is missing, which means that those kind of higher cortical back and forth about that willed volitional movement is missing. And the movements seem to be released almost from the premotor or subcortical regions. So if you then look at the neural correlates of those tics, just before the tic, during that premonitory sensation time, areas like that, the insula, anterior cingulate, and the supplementary motor area get activated. Then as the tics emerge, you will see the cortical structures, the cerebellum, coming into action. And probably what happens is that in those with Tourette syndrome, there is a deficit in pre-pulse inhibition. So you can show it in electrophysiological experiments. So when you have a pulse, you get a startle response. But if you give a pre-pulse, prepare them, and then give a pulse, you don't jump as much. But those with the pre-pulse inhibition deficit, they will keep jumping. No matter how prepared you are or how much you know that you shouldn't jump, it just happens. And that pre-pulse inhibition is probably situated within the premonitory urge-related areas of the anterior cingulate, the supplementary motor area, etc. For example, if you stimulate supplementary motor area, you get a premonitory sensation or urge to move, just like you would get before the tic. So we looked at how would that differentiate from physiological urges. So in this series of studies that I'm going to present, which is, for example, Jade Suki's PhD work in collaboration with Deakin University. So the first column, as you're seeing, it's the whole genesis expression, which is the corticostriatal-thalamo-cortical circuitry. But in the second column, premonitory sensation, predominantly the insula, supplementary motor area, and the putamen. And then once you go into the tic suppression period, it's the inferior frontal gyrus, pre-supplementary motor area, and the subthalamic nucleus. So we looked at that Tourette tic network of structures that are involved against the physiological urge network. So in this study, we looked at activation likelihood estimation and identified what's overlapping between 4 physiological urges. The green is blinking, blue is micturition, red is swallowing, and yellow is coughing. And what we found was that all 4 behaviors localized to the right insular cortex and the inferior frontal gyrus. So it seems like that physiological urge and that premonitory urge that happens in tics seem to have a lot of overlap in the structures and in the phenomenology. But as you can see here, spatial convergence between the tic urge network and the physiological ones. The light blue is the micturition. The light blue is the Tourette network. The micturition is the dark blue. Cough is the yellow. Red is the swallowing, and the green is the blinking. In the first axial brain slice, you can see the overlap in the right insular cortex between Tourette's, micturition, and coughing. Second, that coronal slice is showing the overlap in anterior cingulate cortex between Tourette, micturition, coughing, and swallowing. And the third one, that's the axial slice showing overlap in the left thalamus between Tourette, micturition, swallowing, and coughing. So a lot of overlap. And the 2 main areas are the insula and the cingulate cortex. And they almost form the limbic, sensory, and the motor areas for that urge for action, regardless of whether it's a physiological urge or it is the pathological urge as it happens in Tourette's. But the difference is that in physiological urge, that urge transmits to the part of the body, like if it's micturition or cough or whatever, to do the right action. But in tics Tourette's, because of the pre-pulse inhibition deficit, you've got a leaky gate. So normally all of these neurophysiological stuff is kept behind the gate because of that very strong pre-pulse inhibition and that sensory motor gating working very well. But when that gate is not working very well, that premonitory urge creeps out, leaks out into the conscious awareness. So you feel that premonitory urge, and then the sensory motor cortex completes the loop with a motor action. So that spread from that original urge areas to recruiting more of the motor cortical structures, that is what distinguishes the tic phenomenon from physiological urges. And that urge tic relief cycle can be of benefit to us in treatment. And that's why habit reversal training has been developed to counter that premonitory urge where you do the tick, and then you have got the relief, and it gets consolidated in a vicious cycle. But through comprehensive behavioral intervention for tics, for example, what you're really doing is that interrupting that vicious cycle. So if I have got a tic to move my jaw forward, in the CBIT, I'm taught to become aware of that premonitory urge. And then I have to do a competing response. So if my urge is to move my jaw forward, I would contract my back muscles of the neck so that I literally prevent myself from moving the jaw forward. So you're interrupting that urge followed by the completion of that motor action, and that's overcoming the short circuit. But literally what you're doing is strengthening the inhibitory circuitry. So even if you have got the pre-pulse inhibition, even if you feel the urge, you are literally preventing yourself from doing the action. And when maturation happens, maturation of the brain happens, normally there is an opportunity for the compensatory inhibitory circuitry to come alive and become much more strong. And that's why usually tics get better as they grow older. And maybe by these behavioral methods of treatment like habit reversal training, you are giving a helping hand to that in enhancement of the inhibitory circuitry so that you are not completing the circuitry. So can we differentiate if it is coming from a Tourette story or coming from an OCD? As I said before, if you're responding to an obsessional thought with a catastrophic anxiety or worry that I'm contaminated, if I don't wash or clean, something bad is going to happen, or I'm going to sick. So there is that significant cognitive component and the anxiety distress component. That's what sets OCD apart. But ASD also can have compulsive behaviors like lining up behaviors or restricted repetitive behaviors. There, the motivation for the behavior is not an urge to do or a cognitive element or an obsessional thought. But here it is just being cognitively rigid, being stuck, being inflexible, wanting things to be the same. So the closest explanation you would get for why they are doing it is that cognitive rigidity. He likes it that way or cannot do it any other way. Whereas in Tourette's, it's the urge, and in OCD, it is the cognitive component and the distress. And the same applies for socially inappropriate behaviors. Something called NOSI, which is the non-obscene socially inappropriate behaviors, which is like a kind of a milder version of coprolalia. So you're not blurting out an obscene word, but you may be calling out something like she's fat. All on a sudden, when you see somebody who is a little bit plus size, by the time you've kind of said it and realized it, the damage is done. Whereas in autism spectrum disorder also, you get socially inappropriate behaviors. But I have a young person who mom would say, I cannot take him out to the shopping malls. He has got Tourette syndrome because every time he sees somebody who is a little bit plus size, he will just shout out this, she's fat. Another mom who said about the young person with autism, she would introduce someone to her. And she'd say, hello, this is so-and-so. And if again, this person is a little bit plus size, you would go, she is fat. And mom would say, shh, don't say that. It's rude. Don't say that. And she would go, isn't she fat? Am I not telling the truth? So you get the difference. So one is that, don't know what's socially appropriate. The other one is, yes, but you kind of, it's an impulse disinhibition, if you like. So in a Tourette OCD versus primary OCD, being preceded by somatosensory urge, premonitory sensation, or need to do things just right is the characteristic feature that you're looking for, with no cognitive component and no anxiety. I'll give you another example. If you do forced touching as part of the tics, you just do it. You just touch here and there. Maybe there's an urge and it feels better when you've done it. But if you do forced touching, like I have to do it times, because if I don't do it, something bad will happen, the sky will fall. If there is a catastrophic anxiety related to it, there's a cognitive thought before it, that forced touching is more like OCD. When you get somebody to say back something in exactly the same way. That's what sometimes the OCD patients will ask you to do. And if there is a slight change in tone or a slight change in how you said it, they will ask you to do it again and do it again and do it again. So here is a very specific cognitive obsessional component to it. They are looking for something very specific. And if they don't get it exactly the same way, they are distressed or they feel that something is not right and they cannot move on. And that's not the case in Tourette's. They would just kind of call out saying, what's that? They are not even expecting an answer to it, but it's just something that comes out. So if you ask a little bit more around the phenomenology of why they are doing it and what's precipitating it, what happens after it, etc., you will be able to kind of find out the difference. So here is an example of how you may differentiate. So the questions you might ask is, what's the reason for doing it? What happens if you don't do it? What would you be thinking at that time? How would you be feeling at that time? If the answer is it's more about that urge and this one relieves it and that's why I do it, you're going down the complex tick pathway. But if you get an answer that there is a thought, there is an internal rule that you have to apply rigidly, or there is a consequence, fear of consequence or a catastrophe happening, you're going down the obsessive compulsive disorder. The next set of questions to ask is, how long can you stop it for? How would you feel if you couldn't do it? Again, I'm trying to pick out that distress anxiety versus just do it and it's gone. The next set of questions would be, how much do you be thinking about it before you do it? That's that planning, that cognitive thought or the obsessional rumination that goes before. And if there is no planning, it just comes out, that's the answer you get, then again, you're going in the complex tick side. So here is a bit of differentiation between the tics and the stereotypy. That's another one that commonly people would ask. How would you differentiate a tic from a repetitive stereotypic behavior in an ASD type of situation? And again, this one in BMJ, where we did this table, it's free to access. You can check it out. The differentiating feature, again, one is very quick, rapid, whereas the stereotypic repetitive movement is more rhythmic, coordinated, purposeful, and slow. There is the waxing and waning. Sometimes it's too much there and not there in the case of tics, whereas in a stereotypy, it pretty much stays the same, doesn't change with stress or anxiety, it doesn't change with age. All of those things will help you to differentiate the tics from the stereotypies. But how common are these other associated conditions to a primarily a movement disorder? The answer is only 13.5% in this cohort that we looked at from the National Tourette Clinic had pure tics Tourette syndrome. The rest of them had a whole heap of other associated conditions. And the only difference that we found between those who had the pure tic Tourette's, which is only the tic symptoms, only 13.5%, was that there was no family history of OCD. So it looks like the additional genes or the environmental, perinatal, immunological influences may be having a lot of play when you're bringing along the OCD. It could be from either side of the family. It may be totally independent OCD gene that's also there. But in terms of the Tourette's itself, it's from the Nature Reviews disease primer that we did on the genetics of Tourette syndrome. The risk is basically a cumulative burden of hundreds of small effect size risk variants. And none of them are specific for Tourette's or for ADHD or for autism. These are all neurodevelopmental genes. But that alone may not be sufficient for the symptoms to manifest. It may be that additional perinatal or immune or environmental triggers like the pandas is necessary in some cases, or it may be sufficient if the genetic loading is high. That alone can result in the symptomatology. So if the area of the brain that's just the striatal part that's affected, that you get the tics only. The ADHD brings in the dorsolateral prefrontal cortex, as I said before, OCD, the limbic circuitry, the ASD, the social brain network. And if you have got a whole heap of comorbidities, then that's the whole extent of the corticostriatal pallidothalamo-cortical circuitry being involved. And the site and extent of the circuitry involvement might dictate what clinical symptoms are predominant in a particular patient. And there may be differentiation of involvement of additional circuitry, as I said, particularly when OCD is at play. And Katz et al. Found a distinct endophenotype in fMRI, which was kind of called an intermediate one. It was neither primary OCD nor fitting with the primary Tourette. And there has been a couple of other studies also that talked about the neuronal networks, just like David Cohill was saying earlier. This is a Sito et al. Study that came out this year showing very distinct symptom-specific network changes. And Shui et al. Found that in OCD, there is more of a connectivity issue in the caudate fusiform putamen, whereas when the OCD improved, that normalized the cerebellar frontal connectivity. So it looks like the connectivity may be an important aspect in OCD, whereas in tic symptoms, the improvement has been correlated with strengthening of the motor inhibition networks. And in this study, we looked at a cohort who received comprehensive behavioral intervention for tics to see whether very good data on improvement clinically, both the parent-reported symptoms, the clinician-reported symptoms. But when we looked at the neurophysiological results, there was an increase in the cortical silent period to motor evoked potential ratio. So when that ratio is increased, that shows that there was an improvement in the cortical inhibitory actions. And that motor inhibition deficiency seems to be the key issue in Tourette's, whereas in OCD, it has been shown more of changes in the short latency afferent inhibition. And again, the idea there is that reduced short latency afferent inhibition might be leading to a deficient sort of sensory motor integration, which in turn may impair the ability to suppress intrusive thoughts. And Tourette type of OCD, there is no cognition, as I was trying to say before. So more of that behavioral methods of treatment, like the ERP, and the kids would say, I don't have a cognition to work on. And so they sometimes struggle. Similarly, for pharmacological treatment, when tics are at play along with OCD, maybe you need an augmentation with a neuroleptic because that is an indication of the dopamine circuitry being involved. But there was a meta-analysis which showed that just having tics doesn't mean that SSRIs won't work. But if you're having those very specific Tourette type OCD features that I mentioned earlier, then that might call for a dopamine blocker to be added on earlier in the treatment rather than later, along with your SSRI, when you've got those features being present. So genetic risk arises from cumulative burden of hundreds of small effect sizes. Additional non-genetic factors are particularly critical, not only for whether, but when, how, and what type of clinical expression would be coming out. And this is a review that we have just published last month, where we looked at the genetic underpinning in terms of heterogeneity versus homogeneity. What we found was that a higher burden of disease, earlier age of onset, prepubertal, more severe and persistent form, and specific obsessive compulsive behaviors. In Tourette's, there is about 20% of genetic susceptibility from rare variants, whereas OCD, all of the susceptibility is coming from common variants. So this is again from the Nature Reviews Disease Primer article, where commonly distributed genetic variants, when they collect enough numbers of small risk variants, you go beyond the first threshold, you get provisional tic disorder, which is mild tics. 1 to 2% will then go into chronic tic disorder, and then 1% will go into both motor and vocal, and 0.1% will persist. So in terms of the neurodevelopmental underpinnings, here is an example of the number of different genes that have been directly implicated. Neurexin, contact-associated protein 2, leucine repeats 8. But if you look at the comorbidities there, ADHD, OCD, mental retardation, speech delay, mental retardation, speech delay, OCD, ADHD, ASD. The phenotypes may be so varied. What's common with all of those neurodevelopment genes is that they all have a role to play in neuronal synaptic genesis, neurogenesis, axonal guidance, dendritic branching, neural circuitry formation. So whether it is an axonal guidance, dendritic branching, the neuronal network, the scaffolding protein, it's a glue in terms of the repeat cellular glue type genes, whether it's a neuronal migration that's affected, it doesn't really matter what part of the circuitry is impacted. There may be a commonality of a lot of genes that coming together, resulting in a network being impacted. And so that also gives us for intervention. And when you've got deep brain stimulation, you are actually putting the pacemaker for aberrant oscillations that are present because of the thalamocortical dysrhythmia. That's because some of that GABAergic interneurons, there is a substantial loss of them in postmortem studies in the striatum when compared to globus pallidus. So same number was produced, but they ended up in the wrong place. And the same for transcranial direct current stimulation as well. So what you're currently seeing is that neuronal stimulation going overdrive versus the balance with the inhibition circuitry coming into play. And how can we enhance that inhibitory circuitry is probably the way in which, whether it's neurochemically, through medication, or through behavioral methods of treatment, by breaking the circuitry and the kind of the cycles that go on and on in loops, the effect should be the better maturation of the brain in terms of ability to hold it and not produce the symptoms. So genes code for specific molecules, they then relate to neuronal cellular formation, that then directs the neuronal circuitry formation, then the neuronal system formation. Whether it's a hardware problem or a software problem, the computer is not working. Similarly, the phenotypes that we see come from a variety of pathogenesis, and the final pathway of expression that we see in clinical symptoms may not be easy to decipher while going backwards, but we can get a lot of clues from the phenomenology and also from what we have learned from the neuroimaging and also the genetic underpinning. So I would like you to leave you with the information about the next INA conference, which is in South Africa. The call for abstracts and the registration are now open. That's from 26 to 30 November. And I hope many of you will be kind of thinking about and putting things in the diary for those dates. Thank you very much.
Thank you very much, Valsa, for an illuminating account of Tourette syndrome. We're 20 minutes over time for this session, and I'm conscious that there are lunchtime symposia going on. So maybe we have time for one more question. Any questions from the floor?
Yeah, please.
Good afternoon, ma'am. Thank you for the wonderful session. I just have two doubts, ma'am. One is like clinically, how do we differentiate a functional tic from this developmental tic? That is one question. And second is, what is the role of tetrabenazine as a molecule in tic disorder? Thank you.
Okay, so both those questions will take a lot of time. Would it be okay? I mean, I don't want you to hold you from because functional tic versus this is going to take a little time. Do you want me to kind of communicate to you if you give me your email address? Is that a better way to manage this?
Probably, yes. I think that's probably a better way. Yes. Yeah,
Vivek will be able to give my email address, or I had it in the end as well. So I'll please give me an email.
I will pass on.
Yeah, because that's a big topic in itself, differentiating.
Was there a second part to the question? The previous question was it two parts? Tetrabenazine.
Oh, yeah.
Yes.
Yeah. So, I mean, the Japanese use a lot of that. And there is evidence that tetrabenazine can be useful. And one of the reasons why we haven't caught on to it, there was a new molecule that was recently trialed. I was part of that trial, but again, didn't get the response that we were looking for. So the reason why tetrabenazine has not picked up is it has got a honeymoon effect, because it's to do with the sensitivity of the dopamine receptors itself. So if you can either increase the sensitivity or block it. So you can work it out in two different ways. But the receptor sensitivity gets the tolerance pretty quickly. So you find that after a honeymoon effect, after a little bit of benefits, it kind of really doesn't continue to have the type of response that you would be looking for or that you would get with other medications. So hasn't quite picked up. But Japanese use quite a bit of that, I'm told. Yeah.
All right, I think we need to finish there to allow the other lunchtime symposia to start. And I'd just like to thank the two speakers for these very illuminating talks on these very important neurodevelopmental disorders. Thank you.
And thanks to you, Professor Eileen, joining us at 6 o'clock in the morning.
It's okay.
Take care. Bye.
Thank you, Professor David Kogel, for that comprehensive overview on ADHD, and Professor Valsama Ipan for your presentation on Tourette syndrome. Professor David Kogel is visiting India for the first time, and we are honored to have him present at Neurofrontiers 2025. Your decision to join us in person for this conference is greatly appreciated. We thank Professor Aileen Joyce for chairing the session online and Professor Valsama Ipan for presenting virtually. We hope to host you in person at a future event. I now request Mr. Vivek Mishra to felicitate Professor David Kogel.
Aileen and Valsa, you'll have to come here to pick up these things.
I
You
would
can
now
keep
like
it.
to I would now like to brief about the handcrafted gifts. These handcrafted bookends are made with Burma teak and embellished with traditional Marapachi wooden dolls, symbolical protectors in South Indian culture. Marapachis hold a special place in the Golu festival and are often gifted as part of the bridal trousseau, believed to bless the home with protection, prosperity, and good fortune.
Wow, very, very fun. It is my first time in India. It's one of the places that I wanted to come for so long. So thank you so much for inviting me, and it's my pleasure. Thank you.
Thank you, sir.
So thank you all. So moving on. So the next is the Global Neuropsychiatry Group INA lunch symposium. So where I request people to grab their lunch, come back, and while Dr. Praveen will talk about his experience and data in autism and psychopharmacology of autism. So just get the lunch and we start the talk by 2 o'clock. 10 minutes.
Things everywhere.
I'll take it. Yeah, yeah. Okay, so hope everyone have got their lunch sorted. Can we have our slides? Okay, so just to introduce Dr. Praveen Kumar Jakati, currently working as a head of department in consultant child and adolescent psychiatry in the Institute of Neuroscience, Kolkata. Area of interest is in autism, ADHD, bullying and its effect, dissociative somatoform disorders. In this, Dr. Jagati have published several articles in national and international journals, and international fellow of American Psychiatric Association. So we'd love to hear the Indian prospect or transcultural perspective in the management of the pharmacotherapy in autism. Dr. Praveen.
Yes. This one is right now. It's coming.
Yes.
So, good afternoon, everyone. First of all, I would like to thank Dr. Krishnamurthy sir and Dr. Vivek for inviting me for this wonderful CME program. So I will be trying to focus mostly on pharmacological aspects of management of autism. So before going into pharmacology, I will be just giving a brief outline about ASD. So autism is a brain-based disorder with a developmental onset. So it is noted across the cultures. It's more prevalent in males. Generally, onset is before 3 years, but sometimes roughly one third of children with autism have phenomena called developmental regression. So where children will develop normally up to age of 18 months, 20 months, then they start losing the skills. Comorbid conditions are very common. So if we, I think so. If we see from diagnostic criteria, like in DSM-5 now, it is a common umbrella term called autism spectrum disorder, and 3 symptoms are now like clubbed into 2 domains, basically social communication impairment and restrictive repetitive behaviors. And onset can be any time during the developmental period. Now, what is very important is this prevalence. Now the prevalence of autism is, as per recent CDC statistics, is 1 in 31 children are diagnosed with autism. And that's a very huge number. So, as I said, like 1 in 31 8-year-old children are diagnosed with autism. Now, why so much of rise in prevalence? Is it because are we diagnosing autism more? Or is it actually there is a true increase in incidence of autism cases? Now, this is an Indian study which found that overall prevalence of autism now it is 1 in 89 children. That means it is globally the prevalence is going up. Now, what are the some explanations for this? Is it because one explanation being diagnostic expansion? That means like because now our diagnostic system, so all different like even autism, PDD, NOS, all are clubbed under one criteria, and from severe autism to very mild autism comes under autism spectrum disorder. Diagnostic inclusion now children with tuberous sclerosis, Fragile X syndrome with ID, with autism, they are also clubbed under autism category. Diagnostic substitution. Now, 1/4 of increase in autism ASD diagnosis correlates with gradual elimination of term called mental retardation or ID. And diagnostic awareness, routine child health surveillance and periodic developmental screening has increased. And diagnostic coupling, that means like when therapy or service is contingent on a diagnostic label. Now, but one Swedish population study indicated that prevalence of autism had remained same for cases with moderate to severe symptom, but increased for those with milder symptoms. And roughly one third of children with autism, they develop phenomena called developmental regression, where around 18 to 20 months, they start losing the skills. This was one of the study we published on developmental regression in children with autism based on parental reports. Now, appropriate assessment is the starting point of treatment for autism. That's a very important thing. Now, when we say appropriate assessment, so it includes proper history taking, clinical interview, direct observation of the child, that is very important. And the diagnosis is confirmed by like other scales like mainly ADOS and ADIR, but in our Indian context we use mostly isha and incline dt for confirmation of diagnosis. And in selected cases, like investigations like EEG imaging are recommended, and when there is a syndromic AST, we go for a genetic testing. So sometimes other disorders may mimic as autism. We have to keep in mind, like especially inborn errors of metabolism may rarely present with autism symptoms. So careful evaluation of history, physical examination, and so like we routinely do serum amino acid and urine organic acid to just exclude these causes. And sometimes even other disorders like Landau-Kleffner can present with a regression in children, with language regression in children. So what are the, when it comes to treatment, like pharmacotherapy is on the bottom list, So speech language therapy, occupation therapy, educational programming, behavioral therapy, these are the main interventions, and family interventions. Now pharmacotherapy is on the bottom list. So there is also on there is a lot of talk on early intervention. Why this is important is because development of brain is experience dependent. At birth brain has developed to a point where environmental cues mediated by senses play a major role in determining how genes are expressed. So if there is little stimulation, they fail to develop fully. If there is no stimulation, new connections will not develop. So what is important is first 2 to 3 years language stimulation is very important. Now these days I think the language stimulation has reduced significantly. So there are a lot of cases now, autism children present with increased screen use, autism like symptoms. Language stimulation has a major role in early part. So so first 3 to 4 years are called critical period of brain development. And so it is very important to start early intervention. Now this study showed that children who participated in early intervention by 3.5 years of age had significantly better outcome compared to children who started intervention after the age of 5 years. And what is most important is, if you diagnose autism at the age of 2 years, chances of comorbid intellectual disability is 8%. But if you diagnose autism at age of 3 years, chance of comorbid intellectual disability goes up to 24%. So that means there is a great need to detect autism early and start early intervention. So there are some predictive factors. Earlier you start intervention, outcomes are better, and longer duration of intervention will also have a better outcome. So what are the some factors which will predict, like, yeah, these are the children with autism who are going to get better if you start early intervention, or if they get evidence-based intervention. One, children with a better IQ, they are likely to get better if you start interventions early. And children who develop language before 5 years, they are likely to get better if they get evidence-based interventions. So whenever child comes with behavior issues, so we have to think from first medical causes. Like sometimes children who have difficulty in communicating, behavior is the only way of communication. So if they have, say, pain or some infection, so they can present with behavioral issues. So the behavior issues can be related to absence of communication. It's related to sensory issues. So we have to look for, is there any environmental change, recent environmental change? So these are the things we need to look in. So when it comes to psychopharmacology in ASD, it is mainly to deal with reduction of associated behavior issues and treat the comorbid psychiatric disorder. Now, despite this evidence base, it remains the case that still there is no medication that has shown efficacy for treating core impairments in ASD. But since last 2 months, there is one new medication which is making a lot of buzz, that is called leucovorin calcium. I'll be just touching on towards the end of my presentation about leucovorin calcium for the core symptom of autism. Now, what are the target symptoms? We have one is aggression, second is self-injury, and third severe tantrums, motor hyperactivity, repetitive behaviors, mood disorders, comorbid mood disorders. So these are the common targets for pharmacological treatment. And this was a systematic review which showed that still although many children with ASD are currently treated with medical intervention, strikingly little evidence exists to support benefit for most of the treatment. And risperidone and aripiprazole have shown benefit for challenging and repetitive behaviors. So this article showed that like for evidence for treating aggression, the risperidone has got established evidence and haloperidol has got established evidence for treating aggression. But for other molecules, there is very insufficient evidence. And when it comes to treating hyperactivity, it is same. Although there's a lot of talk about ESD and ADSD, so medications still effective are aripiprazole, risperidone, and haloperidol compared to atomoxetine and stimulants. Repetitive behaviors also, SSRIs have got very mixed evidence in children with autism for treating repetitive behavior. Still, antipsychotics are the mainstay of treatment. Now, when it comes to aggression, aggression is a very significant problem, especially in adolescent population with ASD. Now, risperidone and aripiprazole have the best evidence for reducing irritability and aggression. So, one of the landmark study in autism field is RUP study. This is called Research Units of Pediatric Psychopharmacology. Like we have MTS study for ADSD. So, this is the research. This the RUP study is the strong, very important study. So, this was conducted across 5 centers in US, and this was the study which showed that like in children between ages 5 to 17 years, risperidone at an average dose of 1.8 mg produced a significant improvement. So this was published in initially in New England Journal of Medicine. There was significant reduction in irritability compared to placebo risperidone. So and 75% of children showed much improved to very much improved. So actually, this and the side effects which they were noted was only increased appetite, drowsiness, and weight gain. These are the things which they saw in children with autism. Now, whether risperidone is safe in children with preschool children, yes. Luby and colleagues, they did a RCT in 24 children, preschool children, that is 2.5 to 6 years, and they found that at doses of 0.5 to 1.5 mg in between this dose, risperidone is safe for preschool children. So the preschool children tolerated low-dose risperidone well with no serious adverse effects observed over a 6-month period. And weight gain, hypersalivation were only most common side effects reported. So there was one study which compared risperidone versus haloperidol for children with ASD, and risperidone was found to be more effective compared to haloperidol for treatment of behavioral symptoms, impulsivity in children with ASD. So this study showed that if you combine risperidone with parent training, then a need for risperidone dosage will be less. So this study showed that medication plus therapy showed parent training showed modest additional benefit over medication alone. So at the end point, the average dose of risperidone was higher for medication group compared to combined group. So like we have in MTS study, but in MTS study, so medications are alone itself are able to are effective for treating core symptoms of ADHD. So like if you see there is a effect size of risperidone for managing behavior issues, it's a very significant effect size. You can see that almost it's like 1.3, 1.2 in most studies. That means so this made FDA to approve risperidone in 2006 for treating aggression, deliberate self-injury, temper tantrums for ages 5 to 16 years, and maximum recommended dose was 3 mg per kg for children with autism. Now then came the aripiprazole, and this study showed that aripiprazole definitely reduces the irritability in children with autism, and most common side effects were sedation, drooling, and tremor. And these were the different items on which, so some common side effects with aripiprazole were like vomiting, somnolence, EPS events. So, aripiprazole was also approved in 2009 between 6 to 17 years for treating irritability in children with autism. Dosage recommended was between 5 to 15 mg per day. And then there came, this is the BART trial, like head-to-head comparison of risperidone versus aripiprazole for treating irritability in children with autism. And this was a BART trial, and it showed that almost both risperidone and aripiprazole were equally effective in most of the domains, but there was slight trend for more improvement in risperidone group at all assessment points, but the difference compared to aripiprazole reached statistical significance only at week 3 and week 6. So risperidone had got a small advantage over aripiprazole with respect to efficacy in treating. So, but mean weight gain in aripiprazole group was recommend atypical antipsychotic like risperidone and aripiprazole for treating behavioral issues in children with autism. So, what is this study showed that treatment benefit generally you give up to 6 to 12 months. Then, but very important is efforts to reduce and possibly discontinue such treatment at the end of this period should be strongly considered. So olanzapine, there is very less evidence for treating behavior issues in AST. Qutapin, very less evidence. Ziprasidone, also there is no control studies. And what about clozapine? So clozapine also only case reports. There is it can lower seizure threshold. So generally not much studies on in AST. And what are the things we need to monitor? Sedation, Parkinsonism, TD, we need to monitor every 6 months. Hyperglycemia and hyperlipidemia, we need to monitor. So now comes to what about AEDs? Valproate, is it effective for children treating aggression in children with autism? For children, but another study found that maybe higher doses of valproate are effective for treating irritability in children, especially adolescent population, for treating aggression. But as a overall, in general, response rates with anticonvulsants for severe disruptive behaviors are lower with two most studied atypical antisense compared to risperidone and aripiprazole. So risperidone and aripiprazole have got more evidence compared to AED for treating irritability and aggression. What about lithium? Lithium utility. So there is some evidence for lithium, especially in adolescent and adult population as a mood stabilizer, and there are in some particular genetic conditions like shankopathies where shank gene mutations, lithium has been found to be effective in treating mood and aggression in such patients. So now then there was this study called high dose propranolol was also given was also found to be effective for treating challenging behaviors in children with autism, and it can be safely given in children and adolescents with minimal adverse cardiovascular effects. So there is also now we talk about the self-injurious behavior because very significantly and very difficult to manage. So naltrexone is one treatment. There are mixed studies, but I have found in my clinical experience very low dose 12.5 to 25 mg is very effective for treating specifically only self-injurious behavior. Naltrexone doesn't help other behaviors like irritability and core symptoms, but if you specifically target only self-injurious behaviors, it is helpful. So now comes what AST and ADHD. How to manage a child with a AST and ADHD? Now we have diagnosed comorbid diagnosis, whether stimulants work with social impairments as ADHD symptoms as a second features of AST. Now, the presence of ADHD symptoms, absence of sensory triggers, that is very important. Always first course is we have to look for anxiety and disorder, treat them before managing. Now, this autism group, they are doing an excellent
Recording in progress.
Setting gonfacin in worldwide. So methylphenidate should be a second line option in such case. But if you have a child with autism but IQ is normal or high functioning autism, or we can say PDD, NOA function to tolerate better. So stimulants. So you can ADHD children with if you have a child with with AQ level is normal or in the near normal range, so we can try with methylphenidate in treating ADHD. But if child's IQ level is low or mild to moderate ID with an autism and you want to treat hyperactivity, better go for a clonidine or gonfacin. Now, what transition associated anxiety in children with autism? Yeah, so buspirone, there are some trial, and metrazapine, some trials, but still there is not much evidence. Now let's go to whether yes, bipolar and psychosis, does it exist in children with autism? Yes. How? So classical bipolar disorder is most easily recognized in high functioning verbal individuals with ASD. But as the IQ decreases, the diagnostic confidence decreases. So in low functioning group, you can diagnose by only alternating aggressive behavior with a loss of weight, decreased communication and sleep disturbance. For sleep, only melatonin has got evidence. Yeah, I'll just so what about core symptoms? So this is the one molecule I just wanted to highlight because there are no other molecules which have been shown to be effective. Now, folinic acid is a one new molecule. Just I think 2 months back, Trump and I think in US they have thought about approving an folinic acid for a particular subset of ASD population with cerebral folate deficiency. They found that in this study, Richard Frey group, they found that 38 children with ASD randomized to 12 weeks of folinic acid, maximum dose 2 mg per kg body weight. They found that there is an improvement in communication specifically. You can see that in speech domain they found an improvement. So behavior issues like aggression, hyperactivity, there was the initial worsening, but after that so this study now, so all over the world, I think the studies are being done on leucovorin calcium to test its efficacy for improving core domain, that is speech improvement. So apart from that, this meta-analysis also found that it has definitely helpful in with respect to improving communication for children with autism. I think we need a lot of replication in studies with respect to leucovorin calcium for treating autism. So there was a lot of talk about oxytocin, and they found it is not effective compared to placebo. And there was arbaclofen, which was not found effective. Vanilla study was done, vasopressin for treating core symptom, that it was not effective. So only so conclusion, I'll just yeah. So RTMS, I think there is still evidence is evolving. Yeah, so this is, I just want to show what we are doing in our with our government in our state, West Bengal. So we have started it was a project was started 2 years back where we started where we developed one screening instrument for children with autism, like at each Anganwadi level. So those Anganwadi workers, we developed one new instrument, and that's being now it's in process, I think. Thank you. I'll just show one last video. Because this is in recently on Disability Day, the government has made one video. I'll just show what we are doing the work. Please. That's the last video I'll show.
Identification of autism spectrum disorder amongst the beneficiaries who come to the ICDS centers. Of course, it was a challenge because this is not part of the ICDS mandate, but this was an innovative attempt.
দরকার, কি রকম চাইল্ড অন্যের সঙ্গে ইন্টারঅ্যাক্ট করছে, কি করে রেসপন্স করছে, এটা খুব ইম্পর্টেন্ট।
এই প্রশিক্ষণের মাধ্যমে আমরা বুঝতে পেরেছি যে কিভাবে কোনো বাচ্চার মধ্যে এএসডি হওয়ার সম্ভাবনা থাকে। এর পরবর্তীকালে প্রজেক্ট স্তরে আমরা সমস্ত অঙ্গনওয়াড়ি কর্মীদের প্রশিক্ষণের ব্যবস্থা করেছিলাম।
আমরা যখন সার্ভে করতে যেতাম, কিছু কিছু ক্ষেত্রে আমাদের অনেক প্রতিকূলতার সম্মুখীন হতে হতো। যেমন বাবা মায়েরা আমাদের সার্ভে কোশ্চেনের সঠিক উত্তর দিতেন না, কিন্তু তাদের বারবার বোঝানোর পর, বাচ্চার বাবা মায়েদের কনফিডেন্সে আনার পর তারা এখন আমাদের সঠিক উত্তর দেন।
ইনক্লুসিভ জায়গাটাকে নিয়ে আসা হচ্ছে এবং সেই জায়গাটিতে তাদের অপারেশনাল থেরাপি, তাদের কমিউনিকেশন স্পিচ থেরাপি, ক্লিনিক্যাল সাইকোলজিস্ট, তাদের বিহেভিয়ারাল থেরাপি সম্পূর্ণ বিনামূল্যে করা হচ্ছে।
डॉक्टरको परामर्श अनुसार चाहिँ हामीले नानीको होम भिजिट गऱ्यौँ र त्यहाँ आँगनबाडी वर्कर, सुपरभाइजर, म स्वयं त्यहाँ होम भिजिट गऱ्यौँ। आमाहरूलाई हामीले भन्यो स्पेस थेरापीहरू के गर्नुपर्ने त्योहरू गर्यो र हामी जति पनि अब नानीलाई चाहिँ अब स्वाभाविक जीवनमा अब
মেয়েটাও একটু একটু করে সুস্থ হচ্ছে, হাতে ধরে ধরে একটু একটু করে হাঁটছে কিংবা কথা বলতে চেষ্টা করছে। সেন্টারেও নিয়ে যাচ্ছি, সেইখানেও বাচ্চাদের সাথে খেলাধুলো করছে, অঙ্গনওয়াড়ি দিদির সাথেও কথাবার্তা বলছে, জিজ্ঞাসা করে যে শ্রী কি করছো কি না, খাবার খাচ্ছ কি না।
These children should not be lost. They should continue to be mainstream. We will take this forward with counseling of the parents that you cannot leave a child at this stage, so that we continue to mainstream, we do not exclude.
I must thank Professor Epan because she came to Kolkata and for a CME. On that CME, our Honorable Minister for Women and Child Development, she came and that's how we started the project 2 years back. Yeah, thank you.
And later in the lunch also talking about the cultural perspective for West Bengal. The next symposium, participants from England, India, and Australia, all talking about their perspectives on psychedelics and the transcultural approach in neuromodulation. So, I think the speakers are online. Yeah. Dr. Liliana is there. I would like to invite Lindo from UK and Dr. Mughal Sadi. Dr. Mughal Sadi is from consultant psychiatrist at Buddhi Clinic. Yeah. Yeah. Richant is there.
Yes, hi. Can you hear me okay?
Yeah.
Awesome.
We'll just await for Dr. Liliana. I think she will be joining us.
Yeah, sure thing.
Yeah. Dr. Murad, is Dr. Liliana joining us?
I thought she would be, yes.
Yeah, she
Shall I
said
give her a
yeah.
quick text? Yeah, I thought she was. Let me text her.
Yeah. You can see. Okay. So, meanwhile, when Dr. Liliana is joining, I will request Dr. Mughal to introduce the first speaker, Dr. Chirant Bhagwan.
So, so good afternoon for today's session. So I'm introducing Dr. Chirant Bhagwan, who will be presenting on psychedelics in functional neurological deficits. So he's currently working at Austin Health, and his experience in consultation lies in psychiatry, neuropsychiatry, palliative care, crisis psychiatry, so and recovery-oriented care and academic psychiatry and psychedelic treatments. So nine esteemed publications to his name. So welcome, doctor. Can you begin the presentation?
Sure thing. I'll share my screen. One moment. Okay. Are you seeing my PowerPoint slides?
Yes, sir.
Yeah,
Hi guys.
cool.
Just to say, Lily's on her way. She just got held up. So, I think we can probably just start, Chinra.
Yeah, no worries. I'm happy for her to chime in when she comes, or yeah, whatever works for her. Thank you all for having me. My name is Chiran. Thank you for the introduction as well. I'm a consultation liaison and neuropsychiatrist working across Austin Health and Epworth Healthcare in Melbourne, Australia. And I'm also a PhD candidate with the University of Melbourne, exploring psilocybin, motor function, and functional neurological disorder. And it is my absolute pleasure to discuss some of the advances in the field of psychedelics as they apply to FND. I'll begin with an overview of FND, focusing on pathophysiological mechanisms, the need for new treatments, and where psychedelics might fit in. I'll then describe our psilocybin-assisted physiotherapy study in motor FND, and I will include some preliminary clinical results and neuroimaging findings. And then I'll also introduce another parallel fMRI study of psilocybin in FND that we are collaborating with some British colleagues on, before concluding with some future directions. So starting with the condition, FND presents with neurological symptoms such as weakness or seizures that are considered inconsistent or incompatible with organic or other neurological disease. And it's thought to arise from altered communication between the brain and the body. It is a really common and disabling condition, posing a substantial burden on individuals, families, carers, and the healthcare systems. A number of pathophysiological models have been developed with some support from neuroscientific and behavioral evidence. This includes, in particular, the aberrant emotion processing pathways and connections between emotion processing pathways and sensory motor pathways. And this has been supported by imaging studies showing increased limbic activations and increased functional connectivity between limbic and motor regions. Attentional networks may be altered, and we see that in impaired aspects of awareness with dissociative states and functional seizures, and distractibility, especially with motor FND, such as symptoms worsening with attention or pathological bodily focus, or improving with distraction. And impaired agency is reflected by a mismatch between intended and realized motor function, and reduced interoceptive accuracy. So perceptual accuracy of how we perceive and interpret bodily signals may be altered, and that can contribute to somatic symptoms as well. And the list goes on. Ultimately, these findings converge upon the prominent Bayesian predictive processing framework, which I'll elaborate on here. So if one can imagine, in normal healthy individuals, prior expectations or beliefs may be adaptive to sensory feedback. However, in FND, prior expectations of, let's say, abnormal movements may become overly rigid and precise, possibly reinforced by these mechanisms we discussed earlier, like abnormal emotion processing or attention. And these rigid priors resist bottom-up sensory motor inputs and feedback. And this leads to minimal shifts in these priors, maintaining a disconnect with normal neurological functions and feedback, and contributing to somatic symptoms. But despite some of these advances in our knowledge and understanding, unfortunately, treatments remain very lacking in number and efficacy. There are no effective pharmacotherapies, and psychology has shown modest benefits, especially for functional seizures, and expert consensus recommends physiotherapy as part of a multidisciplinary approach for motor FND. However, these two plots reflect perhaps the two most prominent phase 3 studies in FND. This top plot is from the CODES study, which compared CBT and functional seizures to standard care. And the bottom plot is the Physio for FMD study, testing FND-specific physiotherapy to treatment as usual in motor FND. And both these specialized interventions did not outperform standard care for the primary outcome in these large, adequately powered phase 3 studies, really underscoring, and this was at the 12-month mark for both studies, so underscoring the poor long-term prognostic outcomes for many of these individuals. So clearly, novel, mechanistically informed treatment approaches are needed. So where do psychedelics fit in? Classic psychedelics, such as psilocybin, which Morad will go into in much more detail, so I won't spend too long on this slide and mechanisms, but classic psychedelics act primarily through serotonin 2A receptor agonism, producing widespread effects on brain activity. This includes, in some studies, reduced limbic reactivity, an increase in brain entropy, and bottom-up directed information transfer, and modulation of macroscopic cortical network connectivity, as we can see here. Consolidating these various effects and findings, the rebus and the anarchic brain model proposes that psychedelics exert acute neuroplastic effects by inducing this high entropy state, and thereby relaxing high-level priors, increasing the influence of sensory feedback, and facilitating new learning, including the revision of dysfunctional neural pathways if paired with the right or suitable therapy. So drawing upon these mechanisms, there is a strong theoretical basis for psychedelics combined with therapy for motor or for FND more broadly. And I've got an example of motor FND here, but knowing that these principles could be applied across other FND subtypes. So for example, psychedelics through reducing limbic reactivity may help stabilize interactions between emotion and motor systems. The increased entropy and connectivity changes may help rebalance attentional networks and systems. And so this is depicted here with this example of psychedelic-assisted physiotherapy for motor FND. In this example, right arm weakness may be driven by overly precise, fixed expectations or priors exerting top-down influence, and possibly via these high-level attentional networks and emotion processing circuits, exerting this influence over lower order regions such as the primary motor cortex or M1. And this is demonstrated by these thicker arrows, and it renders the brain and body resistant to bottom-up sensory feedback. However, following psychedelics, these top-down priors are relaxed, as shown by these thinner arrows, enabling greater sensitivity to bottom-up inputs, such as proprioceptive feedback via physiotherapy, as shown by this thicker arrow, leading to a revision of these priors and more effective movement retraining and relearning during the physiotherapy. And so has this concept of psychedelics in FND been explored before? A systematic review identified 9 studies with 26 participants, but all published between 1954 to 1967. Most studies used low-dose psychedelics with active psychotherapy during the acute drug effects. And so this is termed psycholytic therapy, instead of as opposed to more modern high-dose psychedelic therapy approaches used nowadays. And I'll come back to that in a moment. And while some benefit was observed, it was certainly no universal cure when used in this way. And while most people tolerated this intervention well, there were some reports of acute exacerbations of functional symptoms during dosing. And most studies actually didn't report safety all that well. So it's not something we're that confident that we know a lot about. Also noting the limitations due to variable methodology and poor study quality, especially given the nature of these older studies. Our colleagues in the UK recently collected this survey of over 1,000 FND patients to better understand perceptions and use of psychoactive substances for their FND, like psilocybin for their symptoms. In terms of their interest in potentially doing something like this, there was certainly a spectrum of responses, but more people willing than unwilling to take part in clinical trials with psychedelics. And importantly, many people felt that if the intervention was safe, well supported, and grounded in science, they would consider it. For those who had taken psychedelics for their symptoms, there was only 10 participants out of this over 1,000 participant survey. We can glean some insights from this. There was some improvement, but certainly not across the board, and some people did not experience substantial improvement. In terms of side effects, 8 out of 10 didn't experience any sort of notable psychological side effects, but physical side effects were experienced in half of these individuals. So what we can conclude from these earlier studies of psychedelics in the 50s and 60s, and these reports of people self-medicating with psychedelics for their FND, is that psychedelics alone, or within the treatment frameworks applied in the exclusively psychological models, have not been universally effective in FND. But as I mentioned earlier, if paired with suitable therapy, there is potential to increase this therapeutic reach. Therefore, given that physiotherapy is now an established treatment for motor FND, so people with abnormal movements, we specifically looked at this subset of FND to see if existing gold standard physiotherapy approaches could be augmented with psychedelics to improve treatment outcomes. Based on what we know about psychedelic science and previous approaches, 2 potential treatment models exist. The first is a similar model which was used in the 50s and 60s, that psycholytic model, which used low to moderate psychedelic doses with psychotherapeutic work taking place during the acute drug effects. Here, an analogous approach would be to engage patients in movement tasks of physiotherapy during the acute psychedelic effects, taking advantage of acute changes in brain dynamics and neuroplasticity, emphasizing an early critical learning period. The second model is the modern psychedelic therapy approach, which uses higher doses, producing more profound psychoactive effects and a more profound psychedelic experience. And in studies of depression and anxiety, psychotherapy is often delivered in the weeks afterwards to take advantage of a prolonged or sustained window of neuroplasticity, the duration of which may be dependent on this high dose and the intensity of these acute psychoactive effects. But given the practical challenges of administering physiotherapy during the acute psychedelic effects in a clinical cohort, this alternative model bypasses this issue by providing this higher psychedelic dose alone, not worrying about providing active therapy at the time, and instead relying and emphasizing on the physiotherapy in the subsequent weeks instead of psychotherapy and the depression and anxiety studies. But again, it's not known whether this extended window of neuroplasticity will support movement retraining like it does with learning new beliefs and emotions in psychotherapy. So ultimately, the optimal psilocybin dose to use and when to apply the adjunctive physiotherapy for this motor FND subset is still unclear and in need of further exploration. Moreover, there have been no dedicated studies of the effects of psychedelics on motor function in healthy participants, let alone in a clinical cohort, to see if an intervention is even feasible or safe. So based on this rationale and some of the evidence gaps, we adopted a 2-stage approach. Dr. Alexander Bryson, a neurologist, and I are co-leading this research with Professor Richard Kanan, who's a world authority on FND, serving as our primary investigator. First, we established the feasibility of combining psilocybin with movement tasks in healthy participants to identify a maximum tolerable dose that we can give to people while still engaging them in meaningful physiotherapy before testing this in FND. So in the forthcoming slides, I'm delighted to present some of the preliminary results across these two studies. But please, I would request no photos or screenshots of these findings at this stage, just to respect the formal process of peer review and publication to follow, and to acknowledge that these are preliminary only for now. In the first study, 13 healthy participants took 3 doses of psilocybin ranging from 5 to 20 milligrams with randomization and blinding to the order of dosing. And they completed a battery of movement tasks during the acute drug effects and with psychiatric support provided throughout. A few of the motor outcomes are shown here. The box and block tests assess motor speed and dexterity, and the digit symbol substitution test assesses motor speed along with visuoperceptual and attentional functions. Now, for these first 3 measures, the lower the score, the greater the impairment. In contrast to the ruler drop test, which assesses reaction time, where higher scores indicate greater impairment. These are statistical models demonstrating mean difference in score compared to baseline. And the baseline is depicted by the gray horizontal line at 0 on these 4 plots. And as you can hopefully appreciate, there were actually no statistically significant impairments at doses between 5 to 15 milligrams shown in the blue, green, and yellow. However, at 20 milligrams, shown in red, during peak effects at 1.5 and 3 hours post-dose, we begin to see statistically significant impairments on these first 3 measures. After the peak effects, there are also some possible improvements occurring at 5 to 10 milligrams, so at the lower doses, just on these 2 measures. I should also note from a qualitative experience and being there with the participants during the study, there was one participant particularly that was completely unable to do any movement tasks during the peak effects at 20 milligrams due to profound movement impairment. So overall, this demonstrated that 15 milligrams was the maximum feasible dose at which participants could meaningfully engage in movement tasks. And this informed the dose for our subsequent pilot study in FND. And so here we recruited 24 participants with refractory motor FND, so people that have already tried gold standard physio as well as psychiatric input. 12 were allocated to a low to moderate psilocybin dose of 15 milligrams, which was informed by our previous dose finding study in healthy participants, combined with physiotherapy during the acute drug effects. And 12 received a standard high dose of 25 milligrams alone. All participants received FND-specific physiotherapy in the days pre and post-dosing, and psychiatric support was provided throughout. This design allowed us to compare those 2 theoretical treatment models I was discussing earlier. And just for context for the upcoming slides, end of treatment refers to the completion of the final physiotherapy session. And we conducted a battery of measures at baseline and at end of treatment, including fMRI. And participants also completed outcome measures and follow-up visits at 1 week and 1 month post-treatment with the physiotherapist and myself as the psychiatrist. Of the 24 participants recruited and enrolled, all were randomized in a 1-to-1 ratio to one of the 2 treatment arms, but one of the 12 participants allocated to the 15 milligram group had to withdraw just prior to starting treatment the day prior due to personal reasons, which left 11 who completed this arm or this intervention, and 12 who completed the 25 milligram intervention. And here we go. So let's take a look at some of the important preliminary findings. So this is one of our primary efficacy outcomes, the Simplified Functional Movement Disorder Rating Scale, which is a clinician-rated assessment of functional movement severity. On the scale, higher scores indicate greater symptoms and illness severity. And on the left here, we have mean values with standard error bars. 25 milligram arm is shown in red and 15 milligram arm is shown in blue. And as you can hopefully see, both groups show meaningful improvement at all follow-up time points compared to baseline, with particularly strong gains here for the 15 milligram group. The box plot on the right helps visualize the distribution further, showing medians, relevant ranges, and individual values. And this reflects that not all participants achieve substantial improvements. In particular, one participant in the 25 milligram group here in red showed improvement at end of treatment, but then started to return back to baseline severity at follow-up time points. But for nearly all others, we see meaningful and consistent improvement. And again, favoring the 15 milligram arm shown in blue. In fact, I guess I wanted to highlight here that several participants, in fact, all participants, but two at these time points scored 0 on their SFMDRS, which indicates nil severity or limited symptoms on this measure. So perfect score. This is another primary efficacy outcome, the participant graded impression of improvement. And this is a change score only, so no baseline here. But a score of 4 indicates no change, and that's depicted here by the black dotted line. Scores lower from 3 down to 1 indicate improvement, whereas scores 5 and higher indicate worsening. And as you can see, there are, again, occasional reports of worsening noted. But in contrast, nearly everyone else reported improvement across all time points in both dose groups, but with the pattern again possibly favoring that 15 milligram group. And we're still working with our statisticians on deciding around formal inferential statistical analyses, and so watch this space. But overall, for these individuals with very complex needs and significant disability, and who have already been refractory to gold standard treatments, we have seen some really encouraging and meaningful outcomes. As mentioned earlier, we acquired fMRI before and after treatment. We examine within and between network connectivity across 7 canonical resting state networks at follow-up compared to baseline. Increases in connectivity at follow-up are shown in red and decreases in blue. A single asterisk refers to values that were at an uncorrected p-value of less than 0.05, and two asterisks indicate results that survived correction for multiple comparisons. And at a group level here, we observed significant reductions in connectivity, and with additional trends showing decreased connectivity between the dorsal attention network with the limbic and visual networks. These decreases that met that uncorrected threshold of a p-value of less than 0.05 are just illustrated here on the right. So recalling our earlier discussion where increased connectivity between networks involved in emotion, motor control, and attention have been consistently reported in motor FND. Therefore, these reductions in connectivity following treatment are intriguing to say the least, as they may indicate that this intervention is potentially directly correcting or uncoupling these pathological interactions between emotion, attention, and sensory motor function. Dividing the sample by the 2 treatment groups, we lose our statistical power and no findings survive correction for multiple comparison. But I suppose there's still some interesting trends. This 15 milligram group, which again showed the greatest clinical benefit in our previous slides, also appears to be the group showing the trends consistent with driving those relevant mechanistic changes that we saw previously, i.e. the changes in the networks involving limbic, attentional, and somatomotor function. We're still finalizing our analyses of safety, secondary outcomes of motor and neuropsychiatric symptoms, quality of life, qualitative interviews, and exploratory mechanistic studies of sensory motor performance, and the Bayesian belief updating fMRI tasks, so watch this space again. And we're not the only study doing something like this. So we're also collaborating and involved in another study led by Dr. Matt Butler and his colleagues at King's College in the UK. And so thank you, Matt, for these slides. And so they've been working with FND participants, all subtypes and not just motor, utilizing psilocybin with a particular focus on fMRI and mechanistic changes. This is the SciFun study, a brain imaging investigation of 25 milligrams psilocybin, so a high dose, with psychological support by way of 3 therapy sessions pre-dosing, 3 therapy sessions post-dosing, and participants will undergo 2 fMRI scans, 1 before dosing at baseline and 1 week after their dose, to capture both resting state and task-based responses. And so this will hopefully allow us to link symptom change to neural mechanisms in a more dedicated way and complement these results. In addition to fMRI, there are a number of other clinical and mechanistic outcomes relevant to FND that are being collected, such as symptom improvement, feasibility, and measures of dissociation, interoception, and agency. We're also interested in what mediates improvement, and so this will include further exploratory mediators as relevant to the psychedelic and FND literature, and so things like expectancy, connectedness, psychedelic preparedness, and a dosing experience in the altered conscious states, and FND-related variables such as trauma and illness perceptions. And so identifying mediators is important because it will help us understand potentially why some participants improve more than others, to help us sort of guide future targeted interventions. Recruitment for the study. Hi, Lily. Got a hand up? Is it?
Yes, sorry to interrupt. We need to start to wrap up.
Oh, yes. Yeah, yep, sure thing. No worries. I'll wrap up shortly. Cool. So in short, the study is still ongoing. Recruitment is going well. There's been 16 that have been recruited so far. It's been largely tolerable, and there's been some who have responded quite dramatically and some who haven't responded much at all. And so there's possibly something going on there, which we're hopeful that the mechanistic studies that the study really lends on quite prominently will help to sort of unpack and for us to develop much more clearer insights. So just to sort of conclude with what we've discussed today and potentially some future directions, considering the significant need and evidence gaps, I think these studies are really encouraging. It shows that psychedelics and movement and physiotherapy can be well tolerated in participants. Psychedelic-assisted physiotherapy is potentially effective in motor FND, and this intervention actually modulates some of those pathological links and mechanistic drivers of FND. And so these findings have supported a confirmatory, larger, adequately powered RCT, which my professor is leading. And so if you know of any people around Australia, please send us referrals. And together with the other motor function study and the SciFun study, I think this holds a lot of potential for other neuropsychiatric disorders associated with motor dysfunction if we can combine physiotherapy, such as acquired brain injury, Parkinson's disease, and other neurodegenerative disorders, developing modifiable mechanisms for other FND subtypes and for psychedelic treatment there, as well as for other functional disorders such as chronic fatigue, pain, functional gut disorders due to the overlapping pathophysiological mechanisms. Thank you so much for this opportunity. I'll stay around for after Murad's talk for questions.
So, thank you, Dr. Chiran. That was a very insightful presentation. So we have Dr. Liliana Galindo, who has joined us, who's the affiliate assistant professor of psychiatry from University of Cambridge. Pleased to request you to take over the session, ma'am.
Thank you very much for welcoming, and many apologies for all the difficulties. Thank you very much for this talk, that it was fascinating, and I definitely have many questions. And I have to say, it's beautiful to see how this new area is really evolving.
So I deliver psilocybin, and we're interest really is in the clinical applications of psychedelics, and also in the not just the mechanisms but the subjective experience of psychedelics. I think for me the thing that is consistently fascinating for me and for a lot of people that are working in the field is the subjective qualitative aspect, the phenomenology of what the psychedelic experience is like. So this is something I'm going to go a little bit more into. So my talk is going to be more of an overview of a little bit about psychedelics. I'm going to try and share my screen now. I think we should be all right. We should be all right. Can you see it? Yeah. So I can't really see the Zoom, but Lily, I have to depend on you to tell me if you can see the screen.
I cannot see the screen, but now I can see it. Perfect.
No, I can see it. Okay, great. I'm definitely gonna need you to stop me, because I may well run over. So we'll see where we go. Okay, so I always like to start with names and terms, okay? Because I think we can say things but mean very, very different things. So I'm going to start with what the word psychedelic is and what I'm referring to when I talk about this. So just a little kind of interesting anecdote, I think, about where the name even came from. So these are a couple of gentlemen that are quite prominent in the history of psychedelic therapy. So on the left, or on the screen's left, is Aldous Huxley, the famous British writer. And on the right is Humphrey Osmond. He's a Canadian psychiatrist who used to do a lot of work with psychedelics. Now, Aldous Huxley drank some mescaline in the presence of Humphrey Osmond, and he was completely fascinated and overwhelmed by the effect of the experience. He felt like he was walking the earth for the first time. He was looking at flowers thinking, wow, I've never seen flowers before. This is so amazing. This is crazy. He kind of lost his sense of self. He was looking at the chair in front of him. He was saying, where do I end and where does the chair begin? So he was having this experience of this non-dual awareness that we sometimes hear about in meditative states, this lack of separation between subject and object. And basically, he was so fascinated that he went and wrote a whole book about it. And this book is called The Doors of Perception. And this is where the band, The Doors, if you guys know them, got their name from. So he was so fascinated. He went back to Britain, and then he was writing to Humphrey Osmond. He was saying, look, we need to give these substances a name. So what should we call them? And then he wrote him a poem, and he said, to make this mundane world sublime, take 0.5 gram of phanerothine. So Humphrey Osmond kind of looked at this and he was like, oh, wait, maybe I have something a bit better. And he wrote back and he said, to fathom hell or soar angelic, you'll need a pinch of psychedelic. And this is where this name came from. And if you look at both terms, phanerothine and psychedelic, you'll find that they kind of say the same thing. It's bringing to the surface something that is repressed. It's bringing to consciousness something that isn't available in everyday waking consciousness. And for me, this is one of the more interesting bits about psychedelics, and I'll talk a bit further about it, but this is where the name came from. With time, these words changed, and we expanded them to talk about a lot of different drugs. So sometimes we include things like MDMA or MDA, or the 2C series, 2CB, 2CE, 2CI, the phenethylamines, or sometimes we use the word psychedelic to talk about dissociative anesthetics. And importantly, what I'm going to be saying of the word psychedelic today, what I mean are the 5-HT2A receptor agonists. So psilocybin, LSD, DMT, what we sometimes call classical psychedelics. So this is what I mean when I say that word. So these have a few things in common. So they're believed to exert their function, or at least their psychoactive function, via 5-HT2A agonism. And we know this because the intensity of the experience increases with the increase in 5-HT2A receptor bonding, and we can block it when we block the 5-HT2A receptor with ketanserin. So when we put in ketanserin, we stop the effect. The paradigm here is an interplay between drug effect and mindset and the environment. So it's not the drug on its own. It never is the drug on its own. It's usually the drug and environmental context. Like, for example, what Shiranth was talking about, you can, depending on the dose, the interaction can differ. So you can use a bit of a lower dose and introduce an intervention, or a bit of a higher dose and encourage the participant to pay attention to their inner experience. And this is what we're going to be talking about a bit later as well. There are two main types of use, but I think this is expanding. So this kind of dichotomy of macro, large doses, really significant experiences, and micro subperceptual doses, that is expanding now into mini and midi doses as well. So kind of middle doses, and being able to manipulate the experience in that way as well. But this is something that is changing over time, and I believe will change more as we go forward in the field. They have some really significant subjective effects. So again, these are dose dependent. They affect the perception, the emotions, the cognition, and then the mystical experience, which we'll come to a bit later. But basically, what they tend to do is that they disrupt the normal day-to-day waking consciousness. So they disorganize the way the brain works and put it in a state of higher entropy, where the normal mechanisms of interpreting reality or interpreting a person's place in reality changes. So people's how do I go about this? So for lack of a better word, it's kind of like swimming in a consciousness soup, basically. The bits that usually tell you the difference between who you are and the environment around you tend to change. So bits of the brain that don't talk to each other so much, they start talking to each other a bit more. And the integrative mechanism, the associative aspects, the deeper associative aspects, they tend to be decoupled, which will come to a bit later as well. Yeah, actually, I think I'm going to cover this a bit later, so I don't have to spend too much time on it. But what I want to say is the subjective effects seem to play an important role in the mechanism of how it might work. And it is done in a fashion of preparation, dosing, and integration. So usually, before somebody starts to come into the experience, they would meet with a therapist, or they would meet with somebody who has some experience in the use of such substances. Usually, they're a qualified therapist. And a couple of things happen. The first thing is that they build rapport with the therapist so that they can trust them when they're in this state of vulnerability and altered consciousness. Two, they know a little bit about this person's history, so they understand what might come up when we disrupt this normal state of consciousness. For example, sometimes for people, they can get memories coming up from the past. Sometimes they can get images of fears, for example, coming up. There's all sorts of different things, and it's important to understand how to interact with them when somebody is in the experience. This is why preparation is so crucial. And another thing that happens is they agree on how they want to be supported during the experience. So, is it okay if I hold your hand, for example, or is it okay if I put my hand on your shoulder? Because sometimes people, when they're in this altered state, they start to fear what is going on, and their mind starts to give them all sorts of suggestions as to why they're fearing. So sometimes they can say, "Oh God, well, am I going mad?" Or did I do the right thing by coming into this clinical trial? And if not well prepared, this narrative can take over the rest of the session. So it's really important that preparation is done well. And it reduces the chances of negative effects quite significantly. The dosing itself also needs to be held with a lot of care. So usually it's done in a clinical setting that is quite comfortable and with dim lighting. And usually people are encouraged to wear eye masks and headphones, so they direct all of their attention into the unfolding inner experience, rather than to be distracted by the sensory experience in itself. And then we have the third aspect, which what we call integration, which is basically a chance for people to come back, because usually they find it very hard to engage and to speak during the experience. So and also when they start to talk about it, they are distracted from it. So they're encouraged to pay attention and then to tell us about it the day after. And this integration helps people make sense of the wide range of experiences they've had, and try and see, okay, well, is there anything I've learned here that I can take forward in my day-to-day life? And this is kind of a picture of what the room might look like. So, dim lighting, headphones, eye mask, and, they're not always holding hands, but sometimes people actually do need that touch, because they can feel quite lost in their mind, and having a touch of somebody else can be quite grounding and can bring them back to the room, whereas sometimes that can be quite anxiety-inducing. So the paradigm is similar for most psychedelics. Most psychedelics we work with within the clinic, the paradigm is similar. The psychedelics themselves, they differ phenomenologically. They all seem to do this, to have this mystical experience, which we're going to talk about a bit later, in high doses. But as you can see, they differ in potency. So for example, here you can have a quite strong experience on 150 micrograms of LSD versus needing 25 milligrams of psilocybin, for example. And they also differ a lot in the timings. So for example, you have here psilocybin usually takes an hour to take effect and stays for 4 to 6 hours, whereas 5-MeO DMT usually takes about 1 to 2 minutes time to max effect and lasts about 15 to 20 minutes. So there's quite a significant difference in them. This is important because within clinical practice, there is now a clash between efficacy and practicality. So if you have something that stays for 10 to 14 hours, how are you going to deliver it in the clinic? And this is bringing attention to a lot of shorter acting psychedelics like 5-MeO DMT, for example, as something that might be beneficial. But this is still in the earlier stages. Usually I would go into each substance and what they are. I'll give you a quick overview. But just for the interest of time, I won't go in too much. So the first one up there is psilocybin. This is broken down to psilocin in the liver, and this is kind of one of the most popular ones. The one that's really quite far forward currently in the research. LSD shortly after. So this is the ergot fungus. This is where LSD was originally extracted from. DMT, dimethyltryptamine. So this is famous for this ayahuasca drink. So it's usually mixed with an MeO inhibitor because both DMT and 5-MeO DMT are metabolized by monoamine oxidase. So in order for this to be administered orally, it needs to be paired with an MeO inhibitor. But usually they are administered either via an IV bolus or sometimes also vaporized or intranasally in the modern trials. Now, in terms of therapeutic use, the interesting thing about them is that they tend to be transdiagnostic. So Sharon told us about functional neurological disorder, and there's currently interest in a countless number of indications. The modern research started in around 2011. I mean, there was a little bit of research with DMT in 1990s, but the modern research looking at clinical utility started in about 2011, looking at cancer patients, people who had a few months to live, and or you know, they were stage 4, I think, cancer, and they were having trouble coming to terms with their death, and they were having trouble with depression that wasn't really responding to the antidepressants. And interestingly, other than their depression improving with the psilocybin dose, the interaction with death or people's notion towards death seems to have changed, and their acceptability of this changed. And this is a really interesting kind of proxy effect that can sometimes happen, that people can feel like they feel differently about their life, their death, and their relationships, which is really quite remarkable for something that happens within only a few hours. And then there was the big trial, the small trial in London Imperial College, that then opened the door for focus on treatment-resistant depression. And then the Compass trial, so Compass Pathways was one of the larger companies. They then put together the largest RCT to date, which was about, it was what, how many people? It was like over 250 people. I think it was 266, something like that. And they showed that the 25 milligrams, so the highest dose, so it was 1, 10, or 25, had quite a significant difference. It was about a 6-point difference from placebo. 6-point difference from placebo at week 3. So it was a clinically and statistically significant difference. And this was one dose, and the follow-up was for 12 weeks. So what we find here is that the altered state that is there for a short period of time is utilized for lasting change, sustained change that long outlasts the psychoactive effect of the drug. And then a lot of other studies came about. So this is one that was also psilocybin versus niacin, and you'll see here that there was a mean between group difference of 12.3 on the MADRS. They compared it to escitalopram, and they found that it was non-inferior to escitalopram. And then, there were some systematic reviews that came about that brought it forward as more favorable than the comparator. But we need to take all of these studies with a big pinch of salt, because there's a lot of bias in psychedelic trials. So there's a massive expectancy bias because of all the hype that is going on. There is a massive selection bias because they tend to cater to a specific group of people, even if they've not tried psychedelics before. The people that are interested in this kind of treatment tend to be slightly, they may have different characteristics, but initially, at least, it looks like it's a promising avenue. And certainly in the clinic, what we are seeing is that for some people, this is great. They have one experience and it really changes how they look at themselves and their illness. But then for others, really, it doesn't do the same. And we're finding this in the clinic as well. So this is the same systematic review. So high response, high remission, but no difference in tolerability. But again, we need to take everything today with a big pinch of salt because we're in the early stages. Within alcoholism, for example, again, psilocybin versus diphenhydramine. So diphenhydramine was used so that the blinding, they try to maintain blinding, but it's quite difficult to blind with these trials. And again, you found that people who had the psilocybin under this with therapeutic support had lower heavy drinking days than the ones that had the diphenhydramine control. But just for clarity, about 95% of people guessed that they had the psilocybin, so the blinding was not effective at all. Again, another interesting bit is that it's not just limited to therapeutic value. So this was a trial that was looking at meditators, experienced meditators, that went on a 5-day retreat, and half of them got psilocybin and half of them got a placebo on day 4. And you will see here that the measures of meditation depth was quite a lot higher in the psilocybin group, and the overall mindfulness was quite higher in the placebo, in the psilocybin group, after people finished the retreat. And there does seem to be this relationship between meditation and psilocybin, and people can report similar sorts of experiences. Very experienced meditators, for example, especially those with having the loss of self and having this non-dual awareness. So there may be quite a synergistic effect here. And again, as it is transdiagnostic, the interest is in many different things. So psilocybin with treatment-resistant depression is probably the farthest ahead. But then we have also psilocybin and LSD for GAD. We have psilocybin for OCD. There's an interest of psilocin in major depressive disorder. And then you have all sorts of other disorders. PTSD is probably the next big one that's going to be coming up. So there's going to be a lot of interest in this moving forward. Now we come to the mechanisms, which in my mind was really the most interesting bit. So as I said, they work on 5-HT2A receptors. And interestingly, so there seems to be a selective component to this. So if we stimulate the 5-HT2A receptor by something like lizuride, you don't get the psychedelic effect. So there seems to be a downstream effect that is specific to psychedelics that work on the 5-HT2A receptors here. And this is, of course, a picture that we all like, as you saw that Shirat had it as well. So this is a nice picture because it shows that each few dots represent a different area of the brain. And usually you will see that within the network, so there's a lot of interplay within the network. This is under the placebo. But under psilocybin, you will find that the connectivity between the networks increases significantly. So you get this overactive sensory cortex. So the sensory parts of the brain start to be overactive, but then the associative parts is hypoconnected. So phenomenologically, this can sometimes present as something that we call the mystical experience. So this is what Aldous Huxley talked about in the beginning. We try to measure this strange, ineffable thing by this mystical experience subscale, and it has these certain criteria. So one of them is a sense of unity. So people can feel like they are one with the universe around them, or that they feel like connected to something that's much larger than what they are. There's a noetic quality, so they feel like they know what they are feeling is true. Now, this sometimes can be a double-edged sword, because sometimes people can have experiences in the trip that they put a lot of onus on, but they don't necessarily have a lot of weight. Like, for example, sometimes people have memories, but they're not sure if they're real or not. And this noetic quality, I think, can be a double-edged sword. This is why preparation is important to say, we need to take things with a bit of a pinch of salt that come up. A sense of sacredness, there's a sense of something that is really profound that is happening, a state of positive affect, and ineffability. People can't really describe it. Anything you try to describe is an abstraction. So as much as I try today, it's difficult to really put it into words. And this poses an issue with informed consent, because this is also a big debate within the field of, well, how can you consent somebody when you can't really describe it very well? So this is really interesting question as well. Then you get this sense of ego loss, and by ego here, I don't mean pride. I mean so in this my reading of the subscale is a loss of a sense of self. So the sense of an entity that has this agency can be lost, and for a lot of people, this can be the first time they experience themselves in such a different way, and it can give them a really different perspective on themselves and their lives. And then a time and spacelessness. So Aldous Huxley called it the perpetual present, which I thought was a really nice way of describing it. And because of this, there's a psychological aspect to it. Like, for example, it can work quite well with ACT, because ACT is all about building a distance from your feelings and from your thoughts, and being able to see yourself as a larger entity within which yourself is a context, within which yourself exists. So self being a dynamic context rather than the content itself. So, for example, if somebody identifies with their sense of self as an addict, they might be able to see this from a bit of a farther lens of the addiction being something that is a process happening within them rather than them being the addict. This is the Rebus model, which Sharon talked about. So just before I move on to the next point, this is, I think, people working within this field, or at least people I speak to, and the patients, this experience plays a massive role in the outcome. And we see this in the clinical trials, because, for example, we see that there's a strong correlation between this mystical experience and outcomes. And when we dig even deeper, there's certain aspects of this mystical experience, like this feeling of boundlessness or unity, they seem to be correlated with improvement in depression. And this can make sense, because people, when they are depressed, they usually feel quite isolated and they feel quite disconnected. So this sense of unity can be helpful. And then the qualitative measures, confirm that as well. So people feel more connected. They feel like they have a more acceptance of their emotions and their thoughts. But then if we look a bit deeper, and this is opening a whole new world of inquiry, is, for example, we find that 5-HT2A agonism leads to an increase in glutamate and dopamine. So, maybe that's helping as well. And this might be actually independent of 5-HT2A agonism, because in preclinical trials, you find that there is an antidepressant effect, or at least mice or rats return to their hedonic activities, even when you block 5-HT2A. So this puts this whole paradigm into question. So this is really quite interesting to look into. Inflammation as well. There's some early evidence that psychedelics might reduce inflammation. This is quite early as well. What is a little bit more established is neuroplasticity. There does seem to be a clear neuroplastic effect, especially when you drip LSD or DMT on neurons in vitro. They seem to grow dendrites and they form new synapses, but also just grow dendrites, not form new synapses. And there was also a trial a couple of years ago, I think, that showed that they're positive allosteric modulators of the TrkB receptors. So they make the TrkB receptors very receptive to the BDNF, but with a very high potency as well. So this might explain why, when we have something in such a short period of time, it might create an effect that long outlasts the acute effect. I'm not going to go too much into the social reward bit. It was it was a preclinical trial, but I think the idea is that there may be an effect where there is the brain is more receptive to learning, and this is what psychedelics might do. I am kind of quickly recognizing that we don't have that much left. So, Lily, I might ask you how long I've got left now so that I can kind of focus.
We should start to grab, so maybe just 2-3 minutes, really.
2-3 minutes. Okay. If we're going for 2-3 minutes, then I think what I will do is, I think I've talked a lot about patient views anyways. People feel that they connect with different parts of themselves. I think what I want to focus on yeah, okay. I'm just going to skip all the way forward. Okay, I'm going to talk very quickly about safety and then very quickly about the state of play. So hopefully we should do this in 2-3 minutes. Okay, safety-wise, physically, physiologically, they're quite safe. HPPD is something that is recognized. I mean, all I want to say here basically is that I think it's overrepresented in the DSM. We are learning about this in case reports. We don't see that much of it in clinical trials, really. But it can be really quite enduring and distressing, especially if it's HPPD type 2. So if you have somebody with HPPD in the clinic, some of the things that might help are clonazepam, clonidine, lamotrigine, or then SSRIs for depression. They're not quite prone to abuse, but they can be abused, something we call spiritual bypassing. People get attached to the actual experience rather than using it to look further inwards and to feel their emotions. And then we have these dysphoric or challenging experience. I think this is quite important because for some people, this can be quite distressing and it can lead to a worsening in the clinical picture after the experience is there. And also it's important to keep in mind that some of the things that come up for people, some of the memories that come up are not always true. So it's really important to prepare people in the beginning that some of the things you will see might not be exactly true or might not have happened. You think of it as like a waking dream. In terms of the current state of play, basically it's a race to patent right now. After the US drug regulators rejected MDMA for PTSD, Compass Pathway seems to be the next in line to go to the FDA. So we might see this within 9-12 months time. We might see it. Different countries are looking at different ways of putting it forward, like using it for compassionate use or within specific circumstances. And then also because of this effect on neuroplasticity, because of the effect on potential effect on inflammation, there's focus on one non-psychedelics like zalsupindol, for example, which doesn't have any psychedelic effect at all, or really short-acting psychedelics like bretisilocin, which is kind of only a couple of hours. Public opinion sways significantly, as it always has done with psychedelics in general. And just some questions moving forwards. Basically, important to read all clinical trials with a big pinch of salt because there's significant bias there. It's not very clear that RCTs might be the best way forwards because this is a contextual, a complex intervention. So it needs the extra pharmacological factors there. This is a big question, psychotherapy, and what does the word psychotherapy mean? I mean, we know that people need to be well supported through it, but does actual psychotherapy help? People working with it tend to think it does, but I think there's a debate about that. And then how this can be rolled out and whether it can be cost effective. 2-3 minutes? Did I do it?
Perfect. Thank you very much. And thank you for the talk. You have such a great skill to explain a big amount of information in such a clear way. And the most important, you were able to transmit how, well, the big potential of this field. So thank you very much.
Great. Thanks, Lily.
Perfect. So now we are going to continue with our next speaker. You're here, yes. Should I say professor or doctor? How would you prefer to be introduced, please?
Anything is fine. Urvaksh is fine. Urvaksh Mehta.
Would you prefer to maybe introduce yourself or?
Yes, certainly.
Thank you.
I will do that honor. That's fine. So Professor Urvaksh Mehta is a professor of psychiatry at NIMHANS. It is the biggest institution in India focused on the National Institute of Mental Health and Neurosciences. It's in Bangalore. So Professor Mehta is the pioneer figure in use of the non-invasive brain stimulation in range of psychiatric conditions, including use of accelerated TMS in conditions like depression. He have cumulative 18 years of experience, 100 plus publications, recipient of prestigious Wellcome Trust and DBT Alliance Early Career Fellowship, Exceptional Fellow Fund Award, and several more Young Investigator Awards. So Professor Mehta will be talking about the tertiary care setup of neuromodulation in a dialogue. Professor Mehta.
Thank you very much, Vivek, and the entire team at Neurokrish. Thank you very much for having me speak to you all on a topic that is close to heart and also close to work, both. I will talk mostly from a perspective of TMS, but I will try to cover the broader domain of neuromodulation that we are going to discuss today. So we'll start with understanding what is neuromodulation, and then try to understand from a clinical sense what is the scope that exists with neuromodulation therapies. What is the clinical landscape where neuromodulation therapies can be used? Focusing on some aspects of mechanisms, how does neuromodulation therapy work, with an emphasis on neuroplasticity. We'll also contrast common neuromodulation approaches, basic principles, indications, and potential future directions. The field is fast growing, and it is very exciting to be in this field currently because of the potential and the rate at which the field is moving. So we'll touch upon some aspects of possible future applications and the direction in which the field is headed. So to put it in very simple terms, neuromodulation is using or applying external energy to adaptively modulate brain circuits in the quest for symptom resolution. It can be done in an invasive way or a non-invasive method. Invasive neuromodulation is typically done through neurosurgical procedures. Vagus nerve stimulation, deep brain stimulation are two common examples of invasive stimulation, where the impact can have longer lasting clinical changes. And there is also non-invasive neuromodulation, which typically has short lasting, but sometimes can also have longer lasting clinical impact. The energy modality used to modulate the brain circuits can be electrical, magnetic. Most commonly, it is these two. And then there are other modalities which are newer. There can be acoustic, thermal, optical, even combining these together. At a broader sense, neuromodulation can be any therapy. Even pharmacotherapy is, in a way, neuromodulation because it acts at neurotransmitter level and makes changes. But for the sake of defining the field, it is typically restricted to non-pharmacological methods of treatment. The mechanisms can be broadly classified as convulsive or non-convulsive. And as I said, the focus is typically on how to adaptively modulate, so enhance or suppress the neuroplasticity in an adaptive way, which is going to help people recover from their difficulties. We'll now move to what scope neuromodulation holds. The whole idea of applying external energy to modulate brain circuitry can be predicated on the fact that you can use neuroscience to inform where neuromodulation in the brain can be delivered and in what form it can be delivered. to have either an excitation or suppression of that particular brain circuitry. So it holds promise because it can help us translate what we see in neuroscience research to clinical bedside practice. So that is what it is predicated upon. The corollary of this would be that since it is neuroscience informed, the treatment outcomes should be better, the efficacy should be greater, the speed of response should be better, side effects should be lesser, tolerability should be good than conventional available treatments. So that is the corollary with which the burden of expectation is tied along to neuromodulation therapies. Now, in reality, clinical application is in 2 or 3 broad areas. We will discuss that in a little more detail, but it is primarily for difficult to treat symptoms in neuropsychiatry, resistant disorders. But that doesn't stop it from being used as a first-line treatment also. We will come to the clinical applications in a bit. There are also pragmatic challenges. It is always a good practice to ask ourselves when we are sitting in our clinics, when we are sitting in our outpatient departments, how often do we think to ourselves that, oh, this patient would benefit with TMS, or I think I'll use TACS or TDCS. It is more intuitive and more common to use ECT, and that is something which we are all attuned to. But the newer neuromodulation techniques is sometimes there in textbooks, and it seldom translates into actual clinical practice. That is tied to pragmatic challenges and the feasibility with respect to the infrastructure needed, the training needed, and also the strength of clinical utility that has been demonstrated through research work across the world. So continuing with that thought, the clinical space or the landscape where we use neuromodulation can be broadly categorized into these 3 categories: difficult to treat clinical states, speed to improve or hasten the speed of response, and as alternatives to conventional treatment. Difficult to treat symptom states can be of 2 kinds. One is where you need to act very soon. There is acute care like severe suicidal behavior or a very severe aggression. And typically what is used here is electroconvulsive therapy. The other category is of difficult to treat states is persistent symptoms, where despite conventional treatment, there is insufficient response. And that is where the role of TMS can be seen, especially in early non-response, first, second line non-response. That is a common indication, especially depression, OCD. These are common indications for the use of TMS in the clinic. In both these difficult to treat states, these treatments, neuromodulation treatments, are used as add-ons or adjunctive treatments to pharmacology. So it is not as a substitute, but as an adjunct to pharmacotherapy. We also can acute care also refers to speed of response, but there are non-acute cases where speed of response does matter. And it matters for all patients who are suffering. We want to minimize the duration of suffering, and therefore the speed at which you can derive clinical response becomes all the more important. And it reduces the disability, it improves the quality of life. So there is definite merit in ECT improving the speed of response. But ECT is not something that you would use in moderate depression. So then the scope or the clinical space where neuromodulation can step in is there is now emerging evidence that if you combine TMS with starting of the SSRI, then the typical time that is required for the response to begin in terms, say, for example, in depression, that is shortened if we combine TMS with SSRI. So in acute, non-acute care where you want to improve speed of response, typical scenarios which we encounter in the clinic are students who are going to have to face exams, and we want them to overcome depression soon. Someone who's going to get married, so someone is going to apply for a job and has their interview scheduled very soon. Someone who has a travel coming very soon and they want to get better before that for an important assignment. So these are typical clinical scenarios where we combine SSRIs with TMS, and we do see that in the clinic that the response rates are faster. And this is backed up by meta-analyses which have looked at the speed with which depression symptoms improve when the combination of SSRIs and TMS is used. The third category where the clinical landscape of neuromodulation has grown over the past few years is as an alternative to conventional treatment. And this is something which is not completely, the potential is not completely tapped into, especially in general hospital psychiatry, where there are medical comorbidities and you have the risk of drug-drug interactions, and you would not want to prescribe psychotropic medications. So that is one example for this, and we encounter that even at a tertiary care center is elderly depressed, having been initiated on SSRIs, then go on and develop SSRI-induced hyponatremia, and then go into delirium. And on different SSRIs, they go through similar cycles, and that then leads the treating team to consult for neuromodulation therapies as standalone treatments, because the person does not tolerate SSRIs or antidepressants. Another example is if someone has been posted for ECT for severe depression and suicidal risk, heart disease, and severe mitral stenosis with a past history of cerebrovascular accident. Because of the mitral stenosis, there was an embolus which got stuck in the MCA territory and caused CVA. So in fact, this patient had post-stroke depression in the background of RST and mitral stenosis. The risk with anesthesia was perceived as very high. In that individual, the RST and the mitral stenosis was so pronounced that the anesthetist feared that giving anesthesia can, and the ECT can dislodge the new clots which are there in the heart or the peripheral vessels, and which can then get stuck in the cerebral circulation or even the coronary circulation. So ECT was contraindicated in this particular individual. We waited on medications and there was insufficient response, and then we tried TMS, and she started showing response within about the third week of TMS. So these are clinical examples where, especially in the context of general hospital psychiatry, where TMS can play an important role as an alternative to standard treatment. That is not to say that TMS in any way is a replacement for ECT. ECT and TMS head-to-head comparison studies definitely show that ECT is a clear winner in improving depression. But in certain medical contexts, it can also work as an alternative to ECT. A similar scenario can be physiological states like pregnancy. Now, first trimester of pregnancy, you wouldn't want to use psychotropic medications, or for that matter, any trimester of pregnancy. So, and if the facilities for engaging in therapy are not sufficient, or the patient doesn't want to engage in psychotherapy, then TMS becomes a good option, a good alternative. In theory, the magnetic field that TMS generates is going to induce action potentials in the superficial cortex, about 2 to 2.5 centimeters depth. So it is very unlikely that a strong magnetic signal will travel down to the developing fetus and cause disruptions. And this theoretical knowledge, which was known for long now, has been also corroborated through actual real life scenarios where pregnant women who receive TMS and who don't receive TMS have been followed up right up to 36 to 48 months post delivery. And there is no major disruption during the delivery or in the development of the child. So that makes it a feasible or a viable option to be considered in pregnant states also. Of course, the last option is personal choice. We do have patients who come and they don't take any pharmacology. They don't engage in psychotherapy. Most of them have recurrent depression, and when they have a depressive episode, they come, take a course of TMS, get better, go back and continue with their lives. And when they have experienced another episode, they come back for the next round of TMS. So there's no maintenance TMS. It's only during the acute course, and that's their choice of treatment. So these are the various clinical avenues where neuromodulation is typically used at our center. The mechanisms, as I said, it is primarily harnessing neuroplasticity. It can be conceptualized at multiple scales, synaptic, neuronal, cortical levels. Cortical plasticity is conceptualized as an intrinsic attribute of the nervous system that enables its ongoing adaptive modification in response to several environmental stimuli. Neuromodulation harnesses long-term potentiation and long-term depression like plastic effects. So it can either increase or decrease the underlying brain network activity. So these are typical plasticity protocols through which are used in neuromodulation. There are some which increase cortical excitability, like high-frequency TMS, intermittent theta burst, anodal TDCS, PAS. Let's not get into PAS, which is paired associative stimulus, which is combining electrical and magnetic stimulation. And there are others which reduce cortical excitability, like low frequency TMS, continuous theta burst, cathodal TDCS, and so on. It is good to compare and contrast different neuromodulation treatments. So these are the three most common neuromodulation therapies that we use at NIMHANS, and even globally, these are the three most commonly used neuromodulation treatments. We have electroconvulsive therapy, which is typically administered at 800 to 900 milliampere currents, which are administered for a few seconds to induce seizure. The mechanism of action is typically induction of a seizure by mass depolarization of multiple neurons, which generally originate within the diencephalon and then spread. There is a cortical spreading depolarization mechanism, which so there is an initial excitation, and then there is a spreading wave of depolarization or inhibition that spreads. So that is central to the mechanism of ECT. TMS also uses a very strong electrical current, but this current is passed alternatingly through copper coil, and this induces a magnetic field. The magnetic field doesn't have any resistance through the skull. It passes straight into the brain, and in the brain, it gets converted into an induced electrical current. So in typical sense, magnetism is only a bridge to take the energy from the coil into the brain, and the stimulation that happens is still electrical stimulation inside the brain. It can be focal, so that is a strong utility of TMS, where you can target specific brain networks, not very diffuse like ECT. So it induces focal neuronal depolarization, and depending on the rate of stimulation and the intertrain interval, you can see a range of inhibition or excitation of the underlying cortical activity. TDCS or TES, transcranial electrical stimulation, is a very weak 1 to 2 milliampere unidirectional electrical current, which flows inwards under the anode and outwards under the cathode. And this typically shifts the resting membrane potential to a state which can be predisposed to better depolarizing or hyperpolarizing. So under the anode, the neuronal tissue changes happen in such a way that it is likely to be activated, and under the cathode, it is likely to be suppressed. So that principle is used. So it does not cause action potentials. It only changes the resting membrane potential. Similarly, the indications and side effects vary for these three conditions. Severe, we have discussed the indications. The adverse effects are primarily cognitive and anesthesia related in ECT. It can be local discomfort and very rare seizures in TMS, and local discomfort and scalp burns in TES. Most of the durability is short term for all these, unless you use it as maintenance. But sometimes one session or one round of treatment with these modalities can tip off the person into maintaining long-term recovery with support from psychological and pharmacological treatments. So with this, we spend the rest of the time talking about possible future directions. There are very many directions in which the field is transforming. There is deeper penetration or deep TMS. There is the issue of tackling state dependency. So you induce particular states and then maximize the output. There is combining MRI with TMS. So you use neural circuit informed or neuroscience informed neuromodulation. And you can combine neuromodulation with other behavioral interventions. And so you can combine TMS with cognitive training, or TDCS and cognitive behavioral therapy. And so you can use multi-component therapies as well. So certain disorders like OCD have their neural substrates which are not accessible on the superficial cortex, and you typically have to target deeper regions. Like the anterior cingulate is relevant in OCD, and you need a deeper coil. So this is how deeper coil, deep TMS coil is. It is like a helmet, and it has a coil array which penetrates broad and deep. It is not like a gamma ray or a gamma knife which goes only deep and targets. It is very broad stimulation, and it goes deep as well. So this is typically used in the treatment of OCD. They are called H coils. H coils are also used in the treatment of substance dependence, especially nicotine dependence. That is another indication where deep coils target the insula and bring about improvement in smoking rates. The second aspect, other than death, is utilizing state dependency. So it is now understood that it is not as clear as chalk and cheese that a particular protocol will induce excitation and another protocol will induce suppression. So the direction of change also depends on the brain state. So if the brain state is variable, the output can be variable. So if you are able to induce a particular brain state and then apply neuromodulation, you are likely to get more consistent output. So typically it is done in OCD studies. There is symptom provocation done. So the obsessive symptoms are triggered, and in that state of anxiety, the neuromodulation is given, and that is likely to have a better impact. There are very many ways in which you can determine states. It could, states could be behavioral, states could also be physiological. So you can, now there are ways of pairing EEG. So you understand brain rhythms and target neuromodulation in sync with a particular phase of EEG signal. So this is called a closed loop system, where in real time you can tap or predict the phase of the EEG signal and then give in the peak or the trough of the EEG wave. So these are likely to improve the neuroplastic effects, which are again state informed. The third aspect is neuroscience informed. This is again being applied in various conditions across neurology and psychiatry. A typical example is where what we understand currently about the biology of depression is that the subgenual cingulate is hyperactive and the DLPFC is hypoactive. Its inhibitory tone over the anterior cingulate is lost. So that is measured using anticorrelations in the fMRI signal between these two regions. And the part of the DLPFC which is most opposite and not in sync with anterior cingulate, that is the part which is stimulated. And that is found to have better clinical response than placing the coil anywhere in the DLPFC. So you must understand that the DLPFC is a fairly big part of the brain, and you could place the coil in any space of the DLPFC. And this is one way of precisely locating that part of the DLPFC which is anti-correlated to the anterior cingulate, subgenual cingulate, and then delivering TMS there. So that is thought to have better effects. So this is an example of the visuals of how the bold signals from the DLPFC and the subgenual cingulate are anticorrelated, and the site within the DLPFC with the most anticorrelation is chosen for treatment. This is recently tested. This has been this line of work has occurred over a period of a few decades, but this is something which was recently demonstrated not just by using neuro imaging guided TMS, but also delivering very high number of pulses or accelerated protocols. So 10 sessions of TMS in a day over 5 days, which resulted in improvement in clinical scores of depression. And this is also now patented and also approved by the FDA for standard use in resistant depression. So in summary, there are other examples of similar neuroscience informed. The same thing can be applied to negative symptoms where cerebellar prefrontal connectivity, in cognitive syndromes where hippocampal and parietal connectivity are used. So it is a growing field, and although there is tremendous promise, this will translate into clinical practice if we find replicability and strong effect sizes of benefits. So in summary, I would conclude that plasticity is the cornerstone on which neuromodulation therapies have clinical impact. There are nuanced differences across different neuromodulation therapies in terms of their mechanisms, their clinical landscapes, and their safety profiles. It is neuromodulation therapies are predicated on consistent scientific information on the neurobiology of disease states, and hence it holds promise to improve our treatment response and rates. It is critical to define the scope and clinical landscape where we are going to apply neuromodulation. And deep neuromodulation, state-dependent neuromodulation, neuroscience or neurocircuit targeted neuromodulation are certain examples of where the field is headed in the future. I will stop here and I'll be happy to answer questions.
Thank you for the wonderful presentation, Dr. Urvaksh. Now the session is open for questions, please.
Lily, do we have anything online?
One patient with resistant depression and also suicidal ideation, 30 sessions of RTMS was not given, but still there was not any improvement. Can you just explain?
Yes, ma'am. So the response rates in typically in depression TMS is used when there is 1 or 2 line drug failure, and the response rates are about 40%. 40% of patients do show response. 60% of the patients still do not show response. So then we may have to use other augmentation strategies. Or even consider ECT, especially if the patient is suicidal.
If I can ask, with the psychedelics, the dose-related response, what do you attribute that to? Because the RCT that you described, Dr. Bhagavan, was obviously a double-blind RCT, so the patient did not know what dose they were on, I presume. So what do we attribute the lower dose being more effective than the higher dose?
Actually, I should have clarified. It was not double blind. It was randomized, so people couldn't select, or we as the clinicians couldn't select which participant got which dose. But it wasn't blinded, and the main reason why was because of that lower dose of 15 milligram. We engaged the participants with active physiotherapy during the low dose, whereas in the higher dose, the physiotherapists didn't come in at all. So would have been no point blinding, because either they would have had the physio there or not, and they would have been able to tell. So we decided not to go with a blinding option, so it was open label in that respect. So our current formulation of why we think the lower dose actually had the more benefit, which was certainly a surprise to me, given that most other people would think that there's dose-dependent improvement or therapeutic benefits, is I guess part of that theoretical model was because we were applying physiotherapy right at that time of the acute drug effects, when there are those acute neuroplastic effects, is that the most optimal time for therapy and intervention? That early critical learning period that's often talked about, where there's quite acute changes in brain dynamics, and really getting in with the physiotherapy then and there. And so that's why we think that might have potentially had the better outcomes for that group compared to the high dose that didn't necessarily get physio at that time, but got more sort of emphasis on physio afterwards, where we still think there's a window of plasticity, but maybe the study is showing the value of the importance of getting in early with the therapy.
If I can ask another question, Dr. Murad, I have an interest in mystical experiences. And if you look back at mystical experiences historically, mystical experiences actually have good psychiatric outcomes, although they start off with pathos and what one would consider a very significant breakdown. So people become mute, almost catatonic or atonic for prolonged periods of time. We've had Indian saints who were in caves for 7 years and then came out and they were enlightened, and then they were on a roll for the rest of their lives. So is the psychedelic the equivalent of having a natural mystical experience? Is that what is happening? Is that why people get better and then stay better?
I think that is the hope, but I think that's probably a bit optimistic, because the naturally occurring mystical experience, I mean, again, this is an opinion based on my understanding. The natural mystical experience seems like there is a lot of work that is associated with them, and this is a process that is prolonged, and it is natural, and it brings with it some time. If you're saying something like 7 years or something like that,
and things breaking down, I think the psychedelic experience is very much accelerated. So it can give people a hint of that. And sometimes they come out and they feel great and they change their lives. But sometimes if they don't act on things that they've learned and they don't change things, the brain goes back into its old patterns. So for some people, it can be like that. But for a lot of people, if they're not following up with things, this experience can fade with time. Whereas my understanding is that the natural ones probably have this organic way of people having to work through it for longer periods of time. Am I understanding this correctly?
Yes, and I think many of the natural ones also involve epileptic seizures, which obviously is not a component of having a psychedelic treatment.
Yeah, no. I think it's one of the things that would worry us a lot. But it's certainly an incredibly interesting part of the treatment because you really see somebody going into the experience and coming out saying, I just see things very differently now, and it's a remarkable thing to happen within such short space of time, especially people who are close to death. I think there's such an underexplored area that there's a massive trial in Europe right now called SciPal that is exploring just that, people with terminal illness, because it's because of this potential to change perspective significantly with people don't have a lot of time.
Thank you.
So I would like to just ask one question to Professor Mehta. That, see, usually when we talk about the number of TMS sessions we can give, and it says for depression it is 36, which is the FDA-approved guidelines, or for OCD it's 25 sessions. So what is the limit? Can the patient, when take the first course of therapy, had a relapse maybe 1 year down the line, or like the symptoms started to reappear, can we again stimulate with the same number of sessions, or we just look as a maintenance sessions and do 10 sessions and see how is it going on?
Yeah, maintenance therapies are not very well studied in neuromodulation. As I said, typically the effects are short lasting. We see the effects to last for about 4 to 6 months. That is an optimistic estimate. Having said that, if there is a relapse, we generally go through. It depends on the clinical response. We go through the whole protocol as we had done in the first session. We don't give 36 sessions. Generally, people don't. We see that especially for depression, they start showing response by beginning of the second week or end of first week. You can see some changes, and in the majority, there are a few who respond at third week or fourth week, but in the majority, it is by the beginning of the second week, and by about 18 to 20 sessions, our average number of sessions is 18. It is not 36. So by design or by whatever mechanism, that is what we are able to deliver. Most often, if patients see that they are doing fine after about and 3 or 4 more TMS sessions have not brought any further change, they themselves would request for the PMS to be stopped. So that also brings into question the practicalities and the challenges of coming into the hospital receiving TMS. So there are various factors which go into that in determining the number of sessions.
Yeah, thank you. So as a whole, if I ask every speaker in this session that what if there is a combination of the brain stimulation, neuromodulation from the outside and the inside using the psychedelics as the TMS goes for depression, how will that scenario looks like?
Super mystical experience, I guess.
Yeah.
So I have a question for Dr. Morad. Dr. Morad, what are your thoughts about with all these ketamine clinics coming up? Now that's becoming a thing. So what are your thoughts about handling a patient, or rather a person who doesn't fit under any psychiatric disorder category, who walks in and wishes to have a psychedelic experience, what are the medical and ethical implications, like views on it?
See, this is why I guess I started in the beginning by differentiating them. I kind of view ketamine slightly differently. I think ketamine is a bit of a different beast, really. It's different receptor profile, and it's more addictive in its capacity, and it doesn't really have the same phenomenological aspects. I mean, some parts of it might be similar, in terms of this, sometimes people do talk about this ego loss, but people on ketamine usually describe dissociative experiences, being dissociated from themselves, whereas people on psychedelics feel more connected to themselves. And this is quite a significant difference. I think, I honestly, so if we're going to apply this question on the classical psychedelics like psilocybin, I think there is a space for this, for people to have these experiences in a controlled way for wellness. I think this is something that's already happening. If it's nicely controlled and if people are well supported, I think there is actually a benefit to this. And but of course, this is a very controversial issue when I focus now on the clinical aspect of it. So ethically, I think people can make their own decisions. People are adults, and if they want to do it, they should be able to do it in a safe and informed way. But they need to know the risks, and especially with ketamine, I think ketamine is slightly different.
Sorry to interrupt. I know we are very mindful of time. Lily, while we have you with us with your vast experience in this field, do you mind sort of sharing your personal or clinical experiences in this field, please?
Yes. So
Lily,
here in
I'm really
Cambridge.
I'm just saying I have to run. I'm really sorry. I need to go into the
Thanks,
clinic.
Murad.
It's lovely to see you all. Thanks.
Thank you. So same as Murad, here in Cambridge, we also have a small group, a Cambridge Psychedelic Research Group, that we are involved in different psychedelic clinical trials. And effectively, what is clear, and same as the different speakers mentioned, it seems that is clearly an area that it has a huge potential to develop new treatments, not only for mental health disorders, as we saw in the panel, also for other type of disorders. So definitely is something that I think that we need to try to dedicate more research to understand what is the right combination, because we still don't know. It's a great, after the first talk, I have to say I was fascinated. Yes, why to think that we always need to pair with psychotherapy? Maybe for some people will benefit is from physical therapy. And basically the question is how we can maximize that period of neuroplasticity, right? So it's really interesting. And answering also your previous conversation, I'm aware that there are some proposals, of course, pending on funding, that is true that already are thinking, can we combine the two therapies? Can we combine TMS and psychedelics for the patients that are also refractory to all those treatments? We will see. It's a really exciting moment, I have to say, for this field.
Thank you, Dr. Liliana. So can we conclude? So I request you to conclude the session, Doctor. Yeah.
Thank you very much, everyone, for coming, and thank you for this great invitation.
Thank you for the chairpersons. And moving on to the next session, we are running a little bit behind the time. I would like to request Dr. Nagarajan to join me on the table. The session is co-chaired. So Dr. Nagarajan is a consultant, senior consultant psychiatrist, and a special interest in addiction disorders, also leading the our clinic in Coimbatore. Joining him with Dr. Jaswinder Singh. Of course, the convener have to take the fraternity, and the first speaker is Professor Mark Walterberg. Can I have the slides?
They're here. Hi, Mark. Good evening. I know it's pretty late for you guys, both of you, Damidu and you. I can't see them.
Good evening, Jazz.
Hey, Mark. Good evening. Sorry for being late. We're running behind. I know it's a sleeping time for you guys. So may we have the introduction slide for Mark, please? So I had the opportunity to meet Mark. He's a wonderful person with a lot of tons of clinical experience. I think his area of interest is metabolic disorders. He's currently working as a consultant neuropsychiatrist at Royal Melbourne Hospital. He's a clinical professor and principal fellow at University of Melbourne and professor Florey Institute of Neuroscience and Mental Health. He's a visiting admitting psychiatrist across major private hospital networks. As I said, he's got tons of publications under his name. 220 plus we have got here, Mark. And you have been international conference speaker, and you have been involved in development of a cognitive assessment tool, NewCog. And obviously you've got extensive experience in other areas as well. So it's our privilege to have you here, Mark. Thank you so much for giving us your time.
Thank you, Jazz. Can you hear me and can you see my slide?
Yes, we can.
Fabulous. Okay, all right. Thank you so much for the invitation and the honor of speaking. It's fantastic to speak among so many esteemed colleagues. The talks thus far today have just been amazing. I'm going to talk about an area that I sort of fell into. Sometimes you hop on a raft in the river and you never know where the bends will take you. And it took me to becoming somewhat of a de facto expert in metabolic disease. It's a tiny, tiny field. It's like being a big fish in a very small droplet of water. Now, just to give you a sense, this is a schematic of the cell and all the different metabolic processes that occur in the cell. Just have a good look at it. We've got some MCQs at the end. I'm just kidding. It never gets old, at least for me. But you just see that there are many, many thousands of different metabolic processes. There are all sorts of different enzymes. There's a good 1,500 different metabolic disorders that have been described. And generally, they're managed by neurogenetics teams, or as they are at our hospital, by metabolic teams. Pediatric hospitals will often have kind of a large central metabolic team. And as we have at Royal Melbourne, we have an adult metabolic service that essentially covers the entire state. I'm going to talk about why psychiatric illnesses are a part of this and why I ended up seeing a lot of patients from our metabolic team. So if you think about it, neurons have just about the highest metabolic demand of almost any cell. They're acutely vulnerable to metabolic derangements. And one of the interesting things is that metabolic disorders can present initially as psychiatric disturbance. So they can come to us first. And they can look like really accurate phenocopies of major psychiatric illness. Most people know I talk a lot about NPC, which I've deliberately excluded today. That's one of many different disorders that can present initially with a schizophrenia-like psychosis. And often the way to think about this is if you have frank disruption to the CNS, you get dementia, gross motor disturbance. But if you have much more subtle disruption to very finely tuned cortico-subcortical connectivity, then you can present with the psychiatric illnesses that we work with every day. Most of these metabolic disorders are not screened neonatally. A small percentage of them will have an adult onset. Often the less fulminant presentations of common disorders will have an adult onset as opposed to a childhood or adolescent onset. And often they'll get missed by screening processes. So people will present in adulthood with a metabolic disorder without a childhood history, maybe a bit of clumsiness, a mild learning disability. And then suddenly there's something that's much more fulminant in adulthood and everyone is scratching their heads. The really interesting thing about it, though, is particularly if you're essentially treating a secondary psychiatric disorder in these disorders, unless you're wise to it, you might miss the underlying metabolic disorder, and often many of these have a very specific treatment. So as I said before, it's really the psychiatric presentations often happen before the frank neurologic and motor presentations. And the way I think about these, having worked with these disorders for about 25 years, was there are two main ways in which they can present with a psychiatric disorder. So it's really disrupted neurodevelopmental trajectories. So this becomes this. So there's a change to normal neurodevelopment. And that's often the impairment of later maturation of circuitry that modulates mood, reality testing, etc. So an example is metachromatic leukodystrophy. If you've got an adolescent or early adult form, in what I call the psychotogenic window between 15 and 30, then you've got about a 40% rate of developing a schizophrenia-like illness that can look exactly like schizophrenia until more frank neurological symptoms supervene. The other way is you can get a state-dependent impairment of otherwise intact neurotransmitter systems. So if you think about porphyria, you've got reduced GABA release, increased serotonin turnover, presents with, just about anything, but commonly anxiety, depression, etc. Or you've got one of the urea cycle disorders where you get intermittent hyperammonemia, you get an NMDA-mediated confusional psychosis or an encephalopathy. I'll talk a little bit about the urea cycle disorders in a bit. So, and when it impacts on the central nervous system stage of development, significantly affects its presentation. So when disorders begin to bite in childhood, it often presents with attentional disturbance and autism-like phenotype, intellectual disability. In adolescence or early adulthood, it's often psychosis. Can be major mood disturbance like bipolar disorder less commonly, and as we know, in mid to late adulthood, will predominantly present with a dementia-type picture. So there is this huge amount of change that occurs in adolescence and early adulthood. We know there are grey matter reductions. There's a linear increase in white matter, so you're getting macroconnectivity refinement, particularly in and out of the dorsal. There's synaptic microconnectivity refinement, beautifully shown here by Tom Insel's paper back in Nature a good 15 years ago, as it relates to schizophrenia in particular. There are references in that window, dopaminergic fibers, you get changes to noradrenergic and serotonergic receptors that are overproduced and then pruned. And you also get that in inhibitory. In some of these disorders, there are sections for specific neuronal behavioral regulation, particularly frontal subcortical or frontolimbic, fronto-association cortex. And if they affect neurotransmitter systems that play a key role in regulating mood and behavior, particularly monoaminergic systems that we've known and loved for decades, but also the glutamatergic and GABAergic systems. So why are these disorders interesting? Well, it's kind of uncharted territory. You're kind of in the tundra where no one's been before. There's often no information on psychiatric presentations in metabolic disorders. But sometimes what these rare disorders can teach us is something really important about the common disorders. And the other thing is they often have really interesting treatments, whether it's gene therapy, dietary therapies such as phenylketonuria, for example. So when should you suspect this? Well, it's like any other organic disorder. You've got comorbid cognitive or neurological signs, atypical presentations. They've got something like splenomegaly. They've got a family history, consanguinity. There's a more progressive illness. The lack of return to normal functioning. People are sensitive to psychotropics. They have treatment resistance. So I'm going to talk about a quick Cook's tour through some, and then I'm going to talk about a really interesting, recently discovered metabolic disorder that's important to you if you've ever used an SSRI in your life, which is going to be most of us. So metachromatic leukodystrophy, this is a deficiency of aryl sulfatase A. There's also a saposin B, chronic cofactor deficiency, presentation much rarer. The later onset presentation, so this can affect childhood all the way through to adulthood. You can even get middle-aged or later adulthood presentations, but it particularly affects frontotemporal white matter. Thomas Hyde and Danny Weinberger published some beautiful papers on this in the early 90s about how this was a model for schizophrenia because you're really affecting those key association fibers that mature between 15 and 25. And you get such a high rate of psychosis when it bites in that window. If it's later, it can often look just like frontotemporal dementia, and we've had a rash of patients like this over the last 10 or 15 years. But then ultimately, neurologically, chorea, seizures, dystonia. And MRI changes, you get it's often frontotemporal, can be posterior, fairly typical U fiber sparing. I'm not sure if you can see my cursor going over the screen. And unlike adrenal leukodystrophy, it also spares the splenium of the callosum, which is posterior. And here you see a range of different views of that here. So you can get quite subtle changes anteriorly. So it tends to be either symmetrically kind of antero-posterior or anterior predominant. So Tay-Sachs disease is GM2 gangliosidosis, most common in Israel among some populations. So this is a disorder of hexosaminidase A. You get ganglioside excess, particularly GM2. So GM2 and GM3, very neurotoxic in excess. So you get a classic lysosomal storage disorder, but it's also very inflammatory. And this is again a disorder where in 30 to 50% of adult onset patients, you get schizophrenia-like psychosis. Again, for many of these disorders, people might be treatment resistant and they're exquisitely sensitive to motor effects. And this is one of the two disorders where you have psychosis in gaze palsy. The gaze palsy in Tay-Sachs is often a horizontal gaze palsy, whereas in Niemann-Pick type C, it's a clear vertical saccadic gaze palsy. Here's some just I'll skip through these for the purposes of rolling along. So adrenal leukodystrophy, many people have heard of Lorenzo's oil. This is all about very long-chain fatty acids that accumulate, particularly in brain white matter. Commonly presents with adrenocortical insufficiency. There's an adult cerebral form that presents commonly psychiatrically. What's interesting about adrenal leukodystrophy, it's never really been clear to me why, but it has a more posterior presentation and tends to present more with major mood disorders, particularly bipolar disorder. There is a predominantly spinal form with much more subtle cerebral involvement called adrenomyeloneuropathy, or AMN, which is really highly associated with depression. We published a paper on this maybe about 20 years ago. But sometimes it can present in much later life with an FTD type picture. Here you see fairly more typical posterior leukodystrophy with key involvement of the splenium, which is, differentiates it from metachromatic leukodystrophy. Cerebrotendinous xanthomatosis, which is a hydroxylase deficiency. So you get accumulation of cholesterol, cholestanol. People will know about the classic juvenile cataracts, but also the deposits in tendons, particularly the Achilles and the patella tendon, the extensor tendons of the hands. And it commonly presents with psychosis and then dementia that's tricky to treat. You can treat people with quinodeoxycholic acid. It can improve their symptoms, but usually the illness continues to progress. And again, you often have an only partially responsive psychosis. So treatment resistance is the norm often in these conditions. Here you can see changes to deep cerebellar nuclei, which has been thought to potentially underpin the psychosis, and the xanthomas in an Achilles tendon here. NCL or Kuff's disease is again another interesting, it's actually quite a rare disorder. It's there are juvenile forms, but there are also adult forms involved, both recessive and dominant, typically with psychosis and major depression, often associated with progressive myoclonic epilepsy. And then patients develop dyskinesia, dementia in their fourth decade, with psychosis in a fifth to a quarter of patients. And older patients might present with an FTD-like presentation. This is the sort of thing that's often tricky to diagnose. Kuff's disease, the MRI changes are non-specific, cerebellar, callosal atrophy. Ultimately, people historically have done brain biopsy, skin or rectal biopsy, looking at skin under EM, but now that we know what the genes are, because for many years they were covert, people often just go directly to a genetic panel. The thing about Kuff's disease that's interesting is that people are exquisitely more sensitive to neuroleptics than in any other secondary psychosis, and NMS is actually quite common. There's quite a degree of involvement of the striatum. A couple of other ones, if we think about the ones that affect otherwise normally formed CNS, so porphyria, so we've got accumulation of heme precursors, porphobilinogen, and aminolevulinic acid. So you get a reduced GABA release, so it kind of tilts you towards excitotoxicity, increased serotonin turnover, leading to oxidative stress, demyelination. But in particular, you can get vasogenic edema. So how this commonly presents is with a really acute paroxysm with abdominal pain, gastrointestinal dysfunction, neurological disturbance, and also psychiatric illness that can be anywhere from anxiety to a confusional, manic-like presentation to a fairly typical psychosis. They are precipitated by porphyrinogenic medications, particularly in the olden days, barbiturates in psychiatry. There are some antidepressants that are more porphyrinogenic than others, and some antipsychotics that are as well, but often just general metabolic stress for people that are quite sensitive to this. I have a couple of patients with different porphyrias, with copper porphyria, for example, and they're often so anxious. You want to treat their anxiety, but they're so terrified about the antidepressant worsening their porphyria that you get kind of stuck in this loop and no one does anything. So with acute intermittent porphyria, you get psychiatric disturbance in about half and about 25% psychosis. But it can be diagnosed as just about anything. A common presentation is someone in an emergency department who's incredibly distressed, so acutely distressed, screaming in pain, and they're diagnosed as a somatoform disorder. They're given some opiates, they seem to get better, and they're sent home. Basically, the way you diagnose this, people know, of course, about the urine in the sunlight, so it's really about urinary aminolevulinic acid or porphobilinogen or red cell enzyme activity. And if you're thinking about a patient who's got porphyria, the safest ones, risperidone, SSRIs, and lorazepam. It's probably all you need to remember. Maple syrup urine disease, named after because the distinct smell of the odor, because of the accumulation of branched chain amino acids, particularly leucine in the central nervous system. These large amino acids can displace other amino acids. It changes the excitatory kind of inhibitory balance in the brain. And they often present with severe neonatal illness, but you can get less fulminant forms that can present in adolescence and adulthood only in stress. Like some of these disorders, the more mild the deficit, they might only come out with starvation, infection, surgery, etc. You have to give them a branched-chain amino acid restricted diet, but that in itself can produce its own difficulties when you restrict their valine, for example. So even with strict metabolic control, like some of these disorders, the grown-up adults will often have presented in childhood with attentional deficit, then depression and anxiety. It's one of these disorders where almost invariably you've got an organic form of anxiety. The urea cycle disorders is another one. I'll zip through this. The urea cycle disorders are interesting. Probably the most common that people see is ornithine transcarbamylase deficiency. I've probably got maybe half a dozen patients with OTC deficiency, and particularly in adults, if it's relatively mild, they can get, for females in particular, it's often encephalopathy or psychosis during pregnancy under that metabolic strain. In between, they often have severe and treatment-resistant anxiety or an attentional deficit type of presentation. That's probably one other thing I should mention, that for some of these disorders, for example, the leukodystrophies, even well-treated or mild patients will often have an attention deficit type presentation, often because of disruption of longer fibers that are so crucial in, that kind of frontoparietal fibers in sustained attention, and they often actually do quite well on stimulants. So hyperammonemia causes, again, alterations to excitatory and inhibitory neurotransmitter systems. And so for the X-linked types in adults, often severe in boys get a younger presentation, women can get a less severe presentation in adulthood in the setting of infection or metabolic stress. I saw a patient last week I see with OTC deficiency. She's still working as a nurse in a general practice clinic, and it's just about managing her really terribly treatment-resistant anxiety. And when they're really unwell, so they can get an acute encephalopathy, and often what you see is cytotoxic edema, particularly around, here you see the insular cortex, frontal cortex. Usually posterior cortex is pretty spared with these guys. I'll skip homocystinuria. I'll talk about phenylketonuria because this is really interesting. So for most people, their first exposure to the word phenylketonuric is on a Diet Coke or a Pepsi Max can because it contains phenylalanine, which is, NutraSweet is kind of like a hybrid of two amino acids, one of which is phenylalanine. And so phenylketonurics can't have NutraSweet because it worsens their already existing metabolic disorder, which ramps up their phenylalanine. So the hydroxylase that normally metabolizes that is what's impaired in PKU. Why is PKU important? If you're involved with a metabolic service, if a metabolic service has 200 patients, 100 of them are going to have PKU. It's a relatively common disorder. It's quite interesting because we only had dietary treatment in certain epochs of time in different countries and introduced them at different times. So you might get patients that weren't treated until they were 10 with dietary treatment and got severe mental retardation and seizures. We've got people that were started at 2 and might have presented with, say, attentional deficit and later onset of schizophrenia, or people that were started at birth and what they have is a panic disorder, which is, that's essentially what I see with these patients. But even with early treatment, you've really got to get your phenylalanine low. So commonly these patients untreated will have a level of 1,500. Most of us in the room are going to be between 20 and 80, but it's a real struggle with diet to get it below 500. But the phenotype is basically about how high or low it is. Different mutations on the hydroxylase gene will give you a different severity of clinical and biochemical phenotype. So they need a phenylalanine depleted diet, which is really tricky. And they also get large neutral amino acid supplementation. I'll tell you why that's important. Originally, when people were treated, they were thought they only needed to be treated up till the age of 12, and then you were fine because neurodevelopment was finished, right? And then it was maybe 20, maybe 25, unless you're a woman and you got pregnant, when you don't want to expose your fetus to hyperphagia, so you need to reduce your levels. But now we know it probably needs lifelong treatment. Because it doesn't just affect neurodevelopment. It was the most common cause of mental retardation prior to the gene and the treatment being discovered, or the protein and the treatment being discovered. But even with ongoing lifelong treatment, you still get a really interesting constellation of presentations. I'm going to zip along through this. So what's interesting about PKU is basically an organic anxiety disorder, an organic form of panic disorder. So many patients present with severe anxiety. So you've really got to sharpen your pencil in terms of how you treat your panic disorder. Radiologically, when people have high Phe, they often have, if you can see here on the left, you can, you can see here on the left, you can see posterior white matter changes, often about myelinic edema, but also a degree of dysmyelination. And what's really interesting is it's often reversible on good dietary control. Bring their Phe level down, changes can go. A nice paper, one of our registers some years ago about this. It's a really nice review paper. It's open access, but I'm happy to send it to anyone as well, if anyone's keen, just to really get their head around PKU. And basically, when you've got a reduction in phenylalanine dehydrogenase, basically you ramp up your Phe and you get competitive inhibition at the large neutral amino acid transporter. So what happens is you don't get much tyrosine or tryptophan into the CNS from the blood. Why is that important? Well, it depletes your monoamine. So think about what it's like if you don't have much in the way of dopamine or adrenaline or serotonin. You're probably going to get depressed, anxious, maybe a bit dysexecutive, maybe a bit apathetic or a bit grumpy. And that's basically what happens to everyone. So you get monoaminergic depletion, you get reduction in protein synthesis generally, you also get changes in cholesterol synthesis and some other neurotransmitter changes as well. I'll skip through this. Dysmyelination is actually quite important. So you get changes to areas that undergo postnatal myelination. And this is actually quite important. Even oligodendrocytes switch to a non-myelinating phenotype when you flood them with Phe. So it's, there's a lot of white matter change, which we see on imaging. So what I'm going to talk about is really anxiety disorders are actually quite elevated in PKU patients. Again, it's about your level of Phe. The higher the Phe, the higher the likelihood of significant anxiety. I've got a referral bias, but I would commonly see panic disorder, generalized anxiety disorder, occasionally specific phobias. You reduce their Phe, things get better in about 50% of them. And in about 50% of them, they don't get better enough, and you have to treat them with something like an SSRI. In terms of cognitive functioning, look, about half of people are pretty normal across most neuropsychological domains, but they have subtle difficulties. So if you think about something that's going to give you changes to white matter everywhere, it's probably, but particularly posteriorly, it's probably going to affect those systems that depend on kind of long anteroposterior communication, particularly things like working memory and to a degree processing speed, but some executive functions as well. And that's what you see in these people. When their Phe levels are high, they get significant changes in those functions. I'm going to go back. I'll show you this one. This is one of our patients. She's 34, 6 months on diet. She reduced her Phe from 814 to 239 after 6 months. And you can see the reduction in intensity in the posterior and to a degree peritrigonal white matter changes in this girl. She'd actually done really, really well. One of our star patients in terms of bringing down her Phe. There were all these adult patients who were untreated. We brought them back, lowered their Phe, imaged them. What we also did is we measured their psychiatric symptoms and also their cognitive symptoms, basically looking at the cognitive proficiency index, which is processing speed and working memory. What did we see? Basically, if you look at just the CPI, which is derived from the WAIS, they basically effectively went up from 90 to 100. If you think in terms of IQ. HAM-A and HAM-D, unblinded, went down significantly, but also so did their self-report. What we also looked at was the white matter, and if you look at both left and right, posterior regions of interest in that effectively parieto-occipital white matter, kind of normalizing it in between patients, we see a significant change that a measure called the T1 to T2 ratio, which has been used quite a bit in MS studies, basically so you can normalize T2 hyperintensities to the T1 ratio, to the T1 intensity, showed us a significant improvement over time, basically meaning, effectively the denominator is going down. So you're getting an increase. And so this is the first study that we've got from that. And also Matt Kang, one of our young consultants, has, it's in revision, the imaging data as well. The last thing I'm going to talk about, I did mention at the beginning that the interesting thing about metabolic disorders is there's always new ones discovered. And so I'm going to talk about this one. So we'll call it sertraline-induced madness. Now, MAD is not what you think. So MAD is actually multiple acyl-CoA dehydrogenase deficiency. It used to be called glutaric aciduria type 2. It's a genetic disorder, muscle weakness, rhabdomyolysis, basically because of lipid deposition. You muck up your lipid metabolism, you get elevated CK and elevated acetylcarnitines. There are groups of different acetylcarnitine species, depending on how many carbon atoms they've got in your serum. Now, classically, this is caused by a mutation in a range of electron transport flavor protein genes, including A and B, and also the dehydrogenase. But what's been known in the last couple of years is that there have been people who've presented with MAD, classic biopsy findings, but genetically completely normal, elevated acetylcarnitines, and they've almost all been on sertraline. So we know this doesn't happen for every sertraline patient, but sertraline does something interesting to oxidative phosphorylation and mitochondrial functioning. So it looks like it particularly affects ETF-DH, the dehydrogenase, and also complex 1 to a lesser degree, complex 5 in the electron transport chain. You know, there's occasional scattered reports of maybe other SSRIs doing this, but just about everyone has been on sertraline. You get an accumulation of lipids in muscle tissue, and what they get, which is interesting, is they get elevated species of acetylcarnitines in serum. They're genetically normal, but if you look at their urine organic acid, so you get a range of these raised in classic MAD, you don't see it in secondary sertraline MAD. So here's, this is a beautiful paper in Acta Neuropathologica by Hedberg-Oldfors, a large series. So this is looking at a H&E stain of muscle fibers. You see the vacuolation. When you look at this with, God, I forget what GT stands for, something trichome stain. You basically, what you're seeing is the degree of vacuolation. Those ones that are more vacuolated have a lot of mitochondrial proliferation. You see in the red staining. In this Sudan black stain, you see that there are lots of lipid droplets, so that's what's in them. If you look at this in the fiber types, you see that the vacuolation is mostly in type 1 fibers. Cyclooxygenase levels are down. The inset here, sorry, I should have said, the inset for all of these shows normals. So here you see, for example, the non-vacuolation in a healthy control, etc. And even if you look at succinic acid dehydrogenase, those levels are down as well compared to normals. So it's quite interesting. Now, the Hedberg-Oldfors study is just beautiful. They did some wonderful proteomics and basically showed that the down-regulated genes by sertraline were all about energy metabolism and oxidative phosphorylation. So sertraline in vulnerable individuals, and we just don't know who and why that is, causes this secondary mitochondrial dysfunction. So now if we think back to general psychiatric practice, when might you think of a metabolic disorder? There's a family history, particularly if it's recessive or X-linked. If there's an episodic nature of presentation, so people have got this recurrent presentation where maybe they're encephalopathic or a confusional psychosis, etc. When there are cognitive or motor signs, if there's maybe extra CNS signs as well. So visceral, something like splenomegaly, or they've got strange eye signs, they've got strange eye movements, etc., comorbid with their psychiatric illness, or features about their course that make you think of something organic. I imagine most people here will have access to a neurogenetic service or ideally an adult metabolic service to refer to. And investigation is going to be targeted. You have a chat to your colleague, what should I do? Let's get some blood, get some urine, do an MRI. Do we have to, send off white blood cells for lysosomal enzymes, etc. Frederick Siddell, many years ago, published a really nice diagnostic algorithm. I'm happy to give a PDF of this for people or to forward them the paper. So when it comes to management considerations, going back to something I said right at the beginning, which is that if you can isolate these disorders, many of them have a really specific treatment, whether that's dietary modification. For some of them, adrenal leukodystrophy, it's bone marrow transplant. A lot of our BMT patients have done fantastically well with adrenal leukodystrophy. So it's really important to nail that underlying one, use the colleagues that are available to you. And then think about, you're still going to treat them with medication, but think about what you're going to choose and think about the considerations you might have. Antipsychotics where the striatum is affected, for example. Anticholinergics where cognition's compromised. Thinking about non-porphyrinogenic medications in AIP. So again, just to give people the general context, we think about progressive alterations to neurodevelopment by a number of these disorders, particularly that affect late maturing systems in the CNS that seem to predispose people to psychiatric illness. Then there are alterations in more episodic ways to monoaminergic systems or excitatory inhibitory systems that present in other of these disorders. All of us need to have a sense about when there's a red flag or when we've got a whiff that there's something not quite right going on, and to have a sense about who we can tap on the shoulder and refer to. I think that's quite important. But judging by when I started doing metabolic disorders initially 25 years ago, and when the adult service moved to our hospital about 15 years ago, in their patient population, there's a massive psychiatric need. So if you're looking for a new conceptual diagnostic and treatment challenge, offering a session or two to an adult metabolic service, they would be desperate. As far as I could work out, for most of the last 15 years, I was the only psychiatrist in the world who was attached to an adult metabolic service. And every other service said, we would love to have access to that, but psychiatry aren't interested. So if you're interested, put your hand up. It's a really, really interesting field. And that's the end of my presentation. I hope I was able to interest some of you in this.
I take this one, you take next one. Okay. Thanks, Mark. Very fascinating talk. A lot to learn as well. And thanks for bringing up the red flags and key investigations required to diagnose these patients. It looks like MRI is the key for these kind of patients who are presenting with red flags. So I'll open the podium for any questions. Start from here. So Krish has got a question.
We've been looking after a young man, about 22, with a 2-year history of kind of a nihilistic depression, some paranoia, very severe anxiety, but also involuntary movements. And he's got these strange dyskinesias, and they are waxing and waning. He's extensively investigated. No autoimmune cause identified. We were still waiting for some genetic tests. We're still waiting for some CSF results. His DAT MRI PET indicated presynaptic dopaminergic dysfunction. And he transiently responded to levodopa, but then that dropped, and he had a relapse with acute, sort of relapse of involuntary movements and freezing. I mean, he hardly can move, becomes almost catatonic when it happens. He actually has a psychological pillow in that acute phase. Is there something metabolic in particular that strikes you that we should be searching for? Because that's not something we've really done.
Nothing that jumps out. Krish, I mean, the thing I think about with funny dyskinetic disorders is just for some reason about 10 or 20 years ago, we had a rash of career acanthocytosis, and we've looked for it often. But often they have a fairly typical presentation, which is adolescent OCD, then seizures at about 20, and then they get dyskinesia in their mid-20s. I wouldn't discount that in this person, but often there's kind of really obvious imaging findings of marked caudate atrophy, so much more than you'd get in something like Huntington's disease. Look, it's kind of, I'll be honest, it's kind of hard for me to know without examining the person and trying to get a sense. We all pattern match, don't we? And so I'm thinking, is this mostly catatonia? Are they really dyskinetic movements, or are they stereotypies? And is it all kind of broadly under that? I have seen some really fulminant autoimmune encephalitis present with rapid onset dyskinesia that looked exactly like Huntington's disease. And in 2 out of the 3 patients, we could not find an antibody, but they responded really well to treatment. Thinking, okay, so probably about the only other thing I would think about would be an adult onset neurolipofuscinosis or Kuff's disease. And really, so particularly for dyskinesia, probably really, and the best way you would test that is talk to a neurogenetics person and say, is this possible? Can we just do a genetic panel? Because with adult onset, there are like 4 or 5 different genes, or you do a skin biopsy and look at it under EM.
So we've excluded acanthocytosis, we've excluded Wilson's. We've kind of done a fairly deep trawl. So finally, we empirically gave him methylprednisolone, pulse methylprednisolone. And that just happened last week. So we have to wait and see how he responds.
Yes.
But we've sent off, tests for genetics. I'll chase the Kuffs. That's helpful. But your talk's really interesting. Thank you for pointing out all these
no, thank you.
Very difficult to think of conditions.
Everyone loves rare disorders. I just turned it into kind of a career.
It was a great and excellent presentation, sir. I think in day-to-day clinical practice, we mainly come in our country, we don't have any kind of investigations to rule out the metabolic disorders. So we mainly come across the metabolic abnormalities like hypokalemia, hyponatremia, sometimes increased urea creatinine. So what kind of investigations or invasive investigation can be done to rule out these kind of metabolic disorders? You have mentioned so many metabolic disorders: adrenoleukodystrophy, homocystinuria, phenylketonuria.
Look, there's probably no simple screen to say, I think this person may have a metabolic disorder. Let's just do all of this, unless you're going to do serum organic acids, urine organic acids, in some cases CSF organic acids. Gosh, I mean, measuring lactate, pyruvate, ammonia, etc. If you're wanting to do something kind of relatively simple, but most of the things, that's probably unlikely to have much in the way of diagnostic yield. It's still probably, calling upon someone from neurogenetics and saying, this is the phenotype, this is what we're thinking of, this is what we've been able to curate as a list of possibilities. Can you help us refine that further, or maybe expand that further and tell us what we need to do? And look, in the end, we're probably, a lot of places now are just doing exome, and pretty soon people will just be doing whole genome. Then you've got the whole issue of curation and filtering and how much more complex and problematic that is. But that's probably what many of us are going to be moving towards. But in terms of kind of basic kind of broader things, that's probably what I'd say: urine, serum, organic acids, lactate, pyruvate, etc. Sorry, I can't be more helpful.
Thank you, sir.
I think we probably will finish it here, Mark. Thank you so very much for your time. We'll let you off the hook. Have a good night's sleep, and we'll move on to our next speaker. I'll let my colleague introduce Dhamu.
From our next speaker is Dr. Damitya Ratne from Australia, and he's currently a consultant neuropsychiatrist, clinician, and okay. So currently he is affiliated to Royal Melbourne Hospital, the University of Melbourne, and experience. He is a consultant neuropsychiatrist, and he has publications around 62. And I think the session is open to Dr. Damitya Ratne from Australia. Thank you, sir.
Hello, everyone. Thank you so much. I'll start sharing my screen. I hope you can see that and hear me okay. Thank you so much for the kind invitation. It's a real honor and privilege to talk to you today, and thank you to all the organizers for this wonderful conference and some amazing talks. So it's a pleasure to talk to you today about our research study called the Markers in Neuropsychiatric Disorders study, and the possibility, what we're aiming for, a simple blood test to improve dementia diagnosis and distinction from psychiatric disorders. I'm a clinician. I work at the Neuropsychiatry Center. I've just recently completed my PhD. I've got nothing exciting to disclose. So what I'll do today is really give you a whirlwind tour of our study, our platform, and the possibility of a blood test for dementia, a blood test for Alzheimer's disease. And what I'm really most excited about is these really hot off the press findings that we're seeing in novel technology that has the possibility of global translation, not just research, but clinically. So that leads to sort of an ulterior motive, which would be really I'd love to hear from you. We love to collaborate, and sort of got a little bit of a tagline: if you've got samples and data, please get in touch. So what's the background to the MIND study? I put this figure up to demonstrate or illustrate the not uncommon diagnostic odyssey faced by so many patients that I see in my younger onset dementia service. So clinically, my work involves the diagnosis and assessment of people with cognitive and psychiatric symptoms who might have, or there's a question around a possible neurodegenerative cause. And what we know for people who are eventually diagnosed with dementia is that up to the diagnostic odyssey is not straightforward. There's a significant delay. On average, it takes 3.5+ years to get an accurate diagnosis. Up to 50% of people who are eventually diagnosed with conditions like behavioral variant frontotemporal dementia are initially misdiagnosed with a primary psychiatric condition, depression or bipolar disorder. Patients suffer multiple assessments, misdiagnosis, uncertainty, differing diagnostic opinions, increasingly invasive and costly investigations. So needless to say, all of this has significant negative impacts for patients, their families, and healthcare systems. Another way of looking at it is in looking at it this way. So this figure depicts the timelines of different changes in Alzheimer's disease, but applied to other neurodegenerative disorders like frontotemporal dementia and arguably to severe psychiatric conditions like schizophrenia and bipolar disorder. And what this illustrates is prior to basically the timelines of different changes, and prior to the onset of clinical symptoms, let alone the delayed diagnosis many years after that, there are changes occurring from a biomarker, neuroimaging, and biomarker perspective many years before that. So the great challenge is not only how do we reduce this diagnostic odyssey, reduce the delay to diagnosis, but if things are changing many years even before symptom onset, so we know that abnormal amyloid depositions occurring up to 20 years prior to the onset of clinical symptoms in Alzheimer's disease, maybe it's challenging for an anti-amyloid agent to be terribly effective 20 years down the track. So the great challenge is not only how do we reduce that odyssey, but if we really want to change the paradigm and move towards delay or even prevention of these conditions, how do we do that? And this is where we've got obsessed with the possibility of simple blood biomarkers that could be widely available. And we've been obsessed with this biomarker called NFL, or neurofilament light, and the possibility of it functioning like a CRP for the brain. A test to very quickly tell you, is something neurological going on or not? What is NFL? Very simply, it's an essential component of the neuronal cytoskeleton. It's essential for neuronal structure, transport, and growth. It's present throughout the neuron, but particularly in long axons. And very simply, anything that insults or injures the neuron results in NFL being released into cerebrospinal fluid and into blood. And what is it good for? The bars at the bottom are the number of publications, the NFL publications since the first ones in the late 90s. And you can see it's really exponential. And there's been tremendous interest, particularly in neurodegenerative disorders, and it's been shown to be elevated and a marker of diagnosis, prognosis, staging, severity, and even treatment response in a broad range of neurodegenerative conditions. Of particular interest, a number there to all of us in psychiatry and neuropsychiatry, but particularly interesting papers showing elevated levels in anti-NMDA receptor encephalitis-associated psychosis, as well as other encephalitides. So this got us interested a few years ago. Could this help us with the most common referral question and diagnostic dilemma faced by us and patients and families and clinicians? The question being, is this Alzheimer's disease or is it depression? Is this the personality and behavior change, disinhibition, apathy, etc., associated with behavioral variant frontotemporal dementia, or with a condition like bipolar disorder or the severe cognitive and other symptoms associated with schizophrenia? To give you, really, given the clinical focus of our study, I'll take you through a few vignettes. There are so many from clinic and from our research study, but I have to pick a few because we only have so much time. But here I'll talk to you about Kate. It's a 59-year-old woman who was diagnosed with early onset Alzheimer's disease in private neurology. She got severely depressed following this diagnosis, took a significant overdose, was in ICU, and was referred to us from the hospital for sort of another opinion. She was admitted to our ward where people stay up to a couple of weeks or more for multidisciplinary and multimodal diagnostic assessment. Despite all of that, really, we couldn't pick up on a lot. There were these non-specific neurological signs, some twitching. She'd held some haloperidol and typical antipsychotic exposure. Maybe it was that. Really poor effort on neuropsychology, non-specific investigations. And of note, her CSF Alzheimer's proteins were completely normal. And so to the best of our ability, we could thought, okay, well, this is not Alzheimer's disease, so we can be confident about that. She was very severely depressed and anxious. It looked like a primary psychiatric condition, this green rather than a salmon red neurodegenerative disorder. And that's what we said we should treat, but we'll follow her up. Now, we didn't have a CRP for the brain, but if we did, what could that have been like? We analyzed a CSF for Alzheimer's proteins, we stored it for research and future purpose, and we analyzed it for NFL several years later. And if we had that CRP for the brain at the time of a diagnosis, we would have seen, based on these growth charts or reference ranges that we developed, that she was almost literally off the chart. She had a sky-high NFL. So like a CRP for the brain, could this have made us step back and go, hang on a minute, maybe this isn't just depression. What else could this be? And it really predicted accurately, or predicted the kind of diagnostic category she would end up being in. And these non-specific twitches started to develop more obviously into choreiform movements, and we diagnosed her genetically with Huntington's disease. Now, this is not just academic. This has significant implications, obviously, for genetic counseling, for prognostics, for future planning, and in the era of potential disease-modifying treatments. This is important diagnoses not to get accurate and correct early. So this clinical question led to us, fortunately, getting funding to develop this platform to support broad collaborations and research. And we've been fortunate to have, there's a pretty picture illustrating a number of our national, within Australia, and international collaborators. What we've done is established a nationwide platform to recruit participants and a pipeline to collect blood samples and biosample analysis. We've recruited over 1,000 people now across Australia and are heavily involved now in the second time point. And these people have provide samples, cognitive and survey data, and there's longitudinal data linkage as well. So now I'm going to bombard you with some findings from the study, the blood test for dementia, the blood test for Alzheimer's disease. What we showed in our first studies, and many of these studies are my PhD papers, is the strong diagnostic performance of CSF NFL. What this figure, this box and scatter plot shows are individuals with an individual CSF NFL levels in a diverse range of conditions. On the left, and that bright red, are people with rapidly progressive dementias like Creutzfeldt-Jakob disease and rapid variants of Alzheimer's disease, DLB, for example. In the salmon are people with younger and older Alzheimer's disease, frontotemporal dementia, and other diverse neurodegenerative disorders. And in the green are people with primary psychiatric disorders after gold standard multidisciplinary assessments and longitudinal follow-up. Remembering these are all people who were referred to a tertiary service for assessment. Could this person have a dementia? What we see here is significantly elevated levels in neurodegenerative disorders compared to psychiatric disorders, and very strong diagnostic performance. An AUC of 1 is the perfect test that isn't meant to exist. And this is pretty close. And our research led to research tests that are routinely available now here in Australia. So that's, what the other thing that we found is that CSF-NFL performed very well across the individual diagnostic dilemmas I told you about, depression versus Alzheimer's disease, bipolar from FTD, for example. Now, that's CSF. We want to move to blood. What we found is that blood NFL was a very good diagnostic test for distinguishing behavioral variant frontotemporal dementia from primary psychiatric conditions. BVFTD is the diagnosis that's the most challenging to get right early. And again, with very strong diagnostic performance. Interestingly, we didn't see elevated levels in treatment-resistant schizophrenia. We didn't see elevated levels in first episode psychosis, ultra-high risk. We saw slightly higher levels in bipolar disorder. So starting to sort of fill in gaps in biomarkers and our understanding in different disorders that I'll come back to. We developed sophisticated reference ranges like a growth chart. You have growth charts for children's height and weight, and these are NFL levels across the lifespan that are available, and you can input. These are 2 real patients that I've put in there. This is one of our latest papers. Really, the important findings here were that we showed, surprisingly but positively, that plasma blood NFL performed just as well as CSF NFL for distinguishing neurodegenerative for primary psychiatric disorders in a real-world clinical setting, which is good, means that you can do a blood test rather than CSF. What we found is that while it was accurate across all ages, it was particularly exquisitely so accurate in younger people, which is exactly the kind of the group where the diagnostic dilemma, the overlap, the diagnostic overshadowing, the misdiagnosis, etc., is higher. So that was all the blood test for dementia. Now, I mentioned the blood test for Alzheimer's disease. I'm sure you've all heard about the great excitement about phosphorylated tau 217 in particular as a very specific test for Alzheimer's disease. And we showed that in a pretty novel finding in a younger group with a complex variety of non-Alzheimer's disease diagnosis, significantly higher levels in CSF-confirmed Alzheimer's disease, biomarker-confirmed, compared to diverse other conditions. So what this is starting to sort of lead to is the possibility of the thing we talk about so much, precision diagnostics, and the possibility of a precision diagnostic algorithm flow to improve diagnosis, potentially NFL as this initial first-tier screening test for neurodegeneration, helping reserve more specific tests like p-tau 217 for Alzheimer's disease. And we're investigating a broad range of other modalities, clinical and genomics, etc., to start to help with the more specific differentiation within broad categories. Now, one of the things we ask participants, we do health economics as a way to understand what value people place on tests so that we can help get these tests funded, the government funded. And what we found really interesting is that compared to Quanterix Simoa, which is one of the kind of current accepted gold standard analysis methods, there's about 400 Australian dollars for NFL. Participants in the study valued these tests really highly. An MRI and night and admission in hospital in Australia is about $800 to $1,000. So the way they value this is really quite significant compared to the actual cost of the test. But you remember I talked about the global implications. $400 is a huge barrier even for our research and clinically. What if it could be cheaper? What if this could be much more widely available? And this is what I'm really excited to present. These are in preparation and where we've investigated plasma NFL in acute settings using routine pathological samples that were collected and a novel technology. What we've seen is exactly the same as what we've seen using other technologies, elevated levels in dementia and delirium that I'll come back to compared to diverse psychiatric conditions. And these figures illustrate on the left just really very strong correlation with other accepted gold standard technologies and equivalent diagnostic performance. So something that's very exciting. Because this test potentially is in the, actually they told me, they'd overquoted me, it might be about $20. So that significantly changes things if we can continue with our follow-up studies to show that this works and performs well. This has global implications, which I think is where we need to go if we really want to change things at a global scale. But wait, there's more to bombard you with. We've, as part of our study, this is really a biodata bank to support these collaborations. Cassandra Wanan is an incredible researcher who's done a lot of imaging work in schizophrenia and other exciting work. And I looked at this more deeply. You might remember I said we didn't see, interestingly, elevated levels in TRS at a group level, but we saw this really interesting dynamic here where when you adjust for age in controls, there's really no impact. So it suggests that age is the thing that changes NFL levels across the lifespan in health, not anything else. In TRS, we saw this interesting slope, though. Rather than a flat line, it went up like this. Older people with TRS had high levels, which might add biomarker level weight to this accelerated aging hypothesis that has some neuroimaging evidence and other evidence. But really intriguingly, we saw low levels in younger people under the age of 36. And so maybe particularly in psychiatric disorders or other disorders where there are subtle changes and not these really acute, high levels of neurodegeneration. Actually, maybe it's not just high is bad and low is normal, but if you've got two low levels, could that be some marker of the neurodevelopmental issues associated with schizophrenia or lack of adaptivity, for example? So these are things that we're delving into deeper, really intriguing findings. Also within TRS, we saw associations with NFL and insula, with lower insular thickness associated with higher NFL levels in TRS. We've investigated NFL in a diverse range of disorders. I thought Mark was going to talk about Niemann-Pick type C, but we showed that NFL is an exquisitely good test at picking up Niemann-Pick type C and a schizophrenia-like psychosis from a primary psychiatric psychosis. What we found in this study, led by Hannah Dobson and I, is elevated levels in epilepsy compared to functional seizures. And this is a really exciting study that's in preparation, done by my colleague Matthew Kang, who's doing a PhD in biomarkers and mood disorders. And what we found in this study is really extremely elevated levels in people with delirium in hospital compared to people in hospital with dementia and people in emergency departments with psychiatric disorders. And it functioning really well at distinguishing delirium, and provides powerful biomarker evidence of just how bad this condition is in terms of the degree of neuronal injury. People with the highest levels there in delirium were also much more likely to die, sadly, during their hospital admission. What we're really delving deeper into the psychiatric disorders to understand, are there subtle changes, and we're investigating other biomarkers. So GFAP is a really interesting biomarker, glial fibrillary acidic protein. It's a marker of astrocyte activation, or more broadly, as potentially as neuroinflammation. And what we're seeing is different sort of patterns, or differential patterns of biomarkers in different disorders. So in bipolar disorder, you might remember I said we had slightly elevated NFL, so slightly elevated neuronal injury, but also elevated GFAP. So possibly getting both neuroinflammation and neuronal injury in bipolar disorder, which fits with sort of our understandings and the other non-biomarker literature that we have. But interestingly, in major depressive disorder, we see a degree of neuroinflammation. So whether these are starred in our broad syndrome-based psychiatric diagnoses, could there be differing underlying pathophysiological problem, which actually I've got a slide later I'll come back to. We're also investigating proteomics. Everyone's doing proteomics, so we thought we should do that as well. And we are finding really interesting in the TRS cohort 3 upregulated proteins that are, again, almost off the chart. Interestingly, one's associated with metabolic syndrome, which makes sense. The other two are associated with neuroplasticity and adaptation, and could be shedding light on the illness or clozapine. This is a pilot study that we're following up on. This is my latest study that is under review now. And what we found here, this is really the first of its kind in this kind of sample size of a group of patients that are almost impossible to recruit. These are people with acute psychiatric presentations, acute psychosis, acute mania, depression, adjustment disorder, suicidality, and so forth. What we saw here is significantly elevated levels after adjusting for important covariates in bipolar mania and psychosis. So starting to shed light potentially on some dynamic changes in different disorders. You might remember not elevated levels in TRS in first episode psychosis and ultra high risk. But in acute presentations, maybe you've got some degree of neuronal injury, neuronal stress, agitation, sleep changes, for example. In bipolar mania, this might be a reflection of what we know is people with episodes that result in hospital admissions. This hasn't got it. Increases potentially their risk of later life difficulties, treatment resistance, maybe dementia as well, with some recent studies. Sorry, I'm talking too fast. So I'll stop bombarding you with data, but really just to highlight that we've got some really exciting things coming up next year. Genomics in particular, we've got whole genome sequencing and polygenic risk scores in almost 1,000 people. We're looking at the performance of these tests in primary care and implementation and the health economics, as I mentioned. Okay, so that was a whirlwind. I want to come back to the clinical scenario in patients and our why. Please don't try to read all of this text. Neil and Jane are both people who are referred to us with a very similar history and diagnostic dilemma. History of schizophrenia, residual symptoms, difficult to treat, non-specific family history. Both had personality and behavior change and referred to us for, could this be something else? Both had frontotemporal atrophy and hypoperfusion or hypermetabolism. Both, after all of our assessments, we thought, gosh, we can't be sure. Yes, this could be behavioral variant frontotemporal dementia. This could be severe schizophrenia. We need time and serial assessments to be more confident, but in the meantime, optimize psychiatric treatments and we'll follow up. We didn't have CRP for the brain at the time. If we did, though, it might have helped us. Neil had a very low level. Jane had a very high level, and it predicted how things unfolded over the next few years. Neil got clozapine, optimized psychosocial treatments, got better. Fits with schizophrenia. Jane, despite all of that, got worse, ended up needing full-time care, and eventually developed motor neuron disease. Another way that this is a case that I saw in clinic that I thought, gosh, how interesting it would be. I show people scans. I go through things in detail. We give lots of education. We give feedback on the neuropsychological assessment. There's just something different about, hey, this is your lab test result. This is a number, and here is a cutoff. Elizabeth, 62-year-old, she was diagnosed with a language variant of frontotemporal dementia. She had 2 assessments. She was referred to us for another assessment. The thing that I was most struck by was the completely normal imaging, Alzheimer's proteins, and the variability of her symptoms. And I thought, oh gosh, could we actually be dealing with a functional neurological disorder here? And here I'm the 3rd person or 4th person, I think, I was seeing. Her CRP for the brain was completely within normal limits, and it really predicted what we did or eventually diagnosed her with. Sorry, give me a second. Try not to cough my lung out on a live streaming. So her level was completely normal, and interestingly, she had it really had got invested in this diagnosis of dementia. She'd sort of come to terms with it, had made financial decisions, and this is where being able to talk to her about this test, yes, it's a research test, but look where your level is compared to where you'd expect, actually helped in a therapeutic sense of what we eventually, and her acceptance of a functional neurological disorder. And her eventual, last meeting started to talk about potentially some of the trauma and other early life experiences that she didn't talk about previously that helped pave the way to psychological therapy as well as speech therapy, for example, for her functional neurological disorder. And last case is Greg. He's one of the first patients I saw when I started as a registrar on the neuropsychiatry service. 50-year-old who'd seen about 6 different specialists, neurologists, psychiatrists, rehab physicians, old age psychiatrists, with a history of anxiety, stroke-like episodes, falls, tremor, and a variety of diagnoses, TIAs, migraines, essential tremor, anxiety. When he came to our ward, it was pretty clear that he had a number of neurological signs. He had elevated CSF protein, and new flare lesions, extensive investigations. We didn't have the CRP for the brain at the time, but before that, we thought, okay, this looks like something, this probably isn't anxiety, it's probably something else. And his level is one of the highest levels we've ever seen. Again, almost literally off the chart. And it predicted what we eventually diagnosed him with central nervous system vasculitis. He had an incredible response to immunosuppression. We still see him in clinic, but he still has residual symptoms. He still has some neurological signs, some cognitive impairment. So even though this was clinically a successful case, he still had undiagnosed symptoms and probably vasculitis untreated for almost 24 months. So if we had this level before, could have very quickly dismissed anxiety as a differential, could it have led to sharper view or repeat assessments and earlier treatment and an even better impact. So I hope I've given you a flavor of the possibility of NFL as a diagnostic test, the CRP for the brain, especially in younger people, the promise of precision diagnostics, the excitement and the promise of this blood test for Alzheimer's disease, the novel technology that we're developing, and the promise of global clinical translation. And please do keep mind in mind. And if you'd love to collaborate, if you've got samples of data or ideas, please do get in touch. Too many people to thank. It's a huge study with national and international collaborators. The principal investigator is Professor Dennis Velakoulis, is also my PhD supervisor, all of the team at Neuropsychiatry, all of our wonderful collaborators across the world, our funders, especially philanthropic, but most importantly, all of our participants and patients and their families for being so gratefully and generously donating their time and effort. Again, all the wonderful collaborators. Love to take questions now or get in touch. Would love to hear from you. And I'll just close with this. I'll leave this up as another powerful reminder of the diagnostic odyssey faced by so many people and the possibility to really change the paradigm with these kinds of tests. Thank you so much for your time. Thank you again for the opportunity.
Thank you, sir. That was a wonderful presentation. And I have my question. And as we all know that Alzheimer's dementia is the most common dementia we would be encouraging. And to rule out Alzheimer's dementia, we will be doing a lot of investigations, starting from nutritional deficiencies, anemia, and any space conditioning, temporal lobe hemorrhage, any plasma phosphorylated tau protein 217 which can diagnose Alzheimer's dementia in early stages. Whether that one is a specific test, or is there any other specific blood test available for diagnosing Alzheimer's dementia?
Thank you. Excellent question. There's it seems like every month or so there's a new p-tau on the block. There's 205. I think people are excited about. So the very short answer to your question is p-tau 217 seems to be a very accurate test specific for Alzheimer's disease. Interestingly, it's also helpful, as you'd expect, in identifying Alzheimer's disease co-pathology. Now, of course, while it's very strong, it's not 100% accurate. So there are some big studies that collaborators, for example, in Sweden have looked at using the utility of two cutoffs. So a cutoff optimized for sensitivity and specificity, for example, and then what to do with the intermediate levels is ongoing work here. But at the moment, p-tau 217 is really the strongest performing. It outperforms p-tau 181, which is what we used to use and still use in CSF, for example. It outperforms GFAP, etc.
Thank you.
Up to you. While Krish is getting the mic for his question, Damu, very fascinating studies, and I've been kind of looking forward to when these tests will be readily available in Australia. I've got quite a few patients who are on the borderline of what's going on. So just to get it right, so what we're saying is NFL, p-tau 217, the plasma biomarkers are as good as CSF biomarkers. Is that correct, right? Yeah.
That's right, yeah.
I don't know if it's very clear amongst my neurology colleagues, because I think I had a discussion and they were saying, oh, there's no point doing biological biomarkers, the plasma biomarkers, because CSF are more sensitive and specific. But I think I'm getting it right that it's as good as they're both the same.
Thanks, Jazz. Look, I'm glad you asked that question. Really good point. And I didn't have time to talk about this in detail, and that's a really interesting thing. I have this discussion with our neurology colleagues as well. I was really surprised by my study's findings of the diagnostic equivalence. I really thought that CSF NFL would have the edge. Now, this is all what I was presenting is at group levels. I'm sure you all noticed there's variability, there's overlap, etc. And so what we're focusing on now is understanding where plasma NFL and CSF NFL gets it wrong. Where does CSF NFL get it right, and where does plasma get it wrong? They're really important. I demonstrated that algorithm. There are really important things to consider in that algorithm. So the need for implementation. If you've got renal impairment, for example, then that influences your plasma. It results in falsely or related to reduced clearance of these plasma biomarkers. So for example, in that instance, if someone has severe renal impairment or renal failure, you'd go straight to CSF-NFL, which is less influenced by that. So far, I can say that it seems like there would be situations where CSF-NFL would fit into that algorithm, where that's our sort of current work. Possibly where it could fit in is if you do your plasma NFL, but you still have a very strong suspicion or your pretest probability is high, you've got other indicators, then you would do CSF-NFL. Whether that has an edge, has slightly different timelines. These are still things that we're trying to answer. What we're also trying to see is where a combination, for example, could improve utility and combination biomarkers, particularly for FTD. So I wouldn't say it's as simple as what the neurologist is saying. It really depends on clinical scenario and things, especially in younger people in psychiatric settings without renal impairment, without recent head injury and so forth. It looks like plasma is just as good as CSF-NFL.
So I presume you would be recommending both of these tests, especially in someone, an elderly presenting with delirium on the background of mild cognitive impairment. I presume you'd be recommending both.
Thanks, Jez. Yeah, look, I need to be careful because we're still in the research setting, looking at implementation, still need to figure out for the implementation side of things. But based on, as you saw with our delirium findings, really extremely high levels. So what we're delving into deeper now are the specific subtypes of causes of delirium, the hypoactive versus the hyperactive, for example. Could this help with even prognostication, early identification, treatment response as well? We're actually going to analyze p-tau 217 to help with, again, that question that we face clinically, isn't it? Is this delirium because of an underlying vulnerability like dementia or not? And interestingly, within those groups, there's a group that we were confident about delirium plus dementia. The people with delirium without clinical dementia actually had even higher levels, which is very interesting. And so, you know, Matt's one of his hypotheses is actually, okay, if you remove dementia as a vulnerability, you need an insult that is so high because you've got a higher resilience that results in even greater neuronal injury. Interesting. But watch this space is probably the correct answer I should be giving, Jez. This is a rapidly developing field.
AI will help us as well at some point. Thanks, David. I think we might have to finish it here. I don't see if I got any more questions, but thank you so very much, both of you, for finding time and doing it at this time of the day. Thank you.
Thank you so much. Enjoy the rest of your conference.
So we thank all the speakers for joining us online, for presenting virtually and sharing their insights. We look forward to hosting you in person at a future event. So as we are running 30 minutes behind schedule, we shall move on to the next session. Before we do, please help yourself to the refreshments available outside and return to your seats. We will resume the program. Thank you for your understanding and cooperation. Is there a laptop that will be available to me to yeah, it's just about the next slide.
Yeah, I think you only get a pointer with that thing.
Oh, brilliant. That's all that I want to say.
The next one or?
No, the one after that, but you know,
I'm
guessing it has to be like this.
Oh, okay. Cool.
I mean,
Yes, I am. We do, yes. So another couple of hours. Because I was telling, made it a bit shorter. Okay, let's have.
Yes, because the longer you stay, the worst thing is children's education. So once they start with education there, they find it so difficult to go anywhere. So also son who's in 30, right? Your son's 30, yeah, I'm 30. You don't understand. So just before we got into, just before we got into one of the top primary schools. Wow. And so the governments and the governments want it very much. They should be different. To one specific so, but then we will to Mysore. You told me no, I could think this was bad. Even as a house guest, the pair of this was incredible. Like that, sure. அவங்ககிட்ட கொடுத்துருங்க
Good evening, everyone. So the next session focused on the autism spectrum disorder. We have two very eminent speakers, and I think it is the first time when we are looking for having a father and a daughter duo enlightening us with on the ASD. To chair the sessions, we have Dr. Praveen Kumar. He's that I will, yeah. And to join from the Buddhi Clinic, Dr. Praveen, and from Buddhi Clinic, we have Dr. Priyanka. Dr. Priyanka is doing her fellowship in neuropsychiatry here at Buddhi Clinic after finishing her MD in psychiatry. Can I have slides for Professor Tanya Dev, Dr. Tanya Dev?
Hello, do you want me to share my screen? Would that be?
Can I also have pin the videos? Yeah.
Hello, can you hear me?
Evening. Yes, good evening, everyone. I would like to introduce Dr. Tanya Dev. She has trained as an academic clinical fellow at the Institute of Psychiatry, Psychology and Neuroscience at Maudsley Hospital and Imperial College London. Runs a specialist clinic for diagnosing autism spectrum disorder in adults. Lies in psychiatry with a special interest in psychological care of cancer patients. We welcome you, ma'am.
Thank you very much for that. And thank you very much for having me. Can you all hear me?
Yes, we do.
Oh, great. So I will start by sharing my screen now. And please just let me know if you can see that.
Yes, yes.
Okay. Thank you very much for having me here today. So today I'm going to do a whistle-stop tour of diagnosing autism in adults. What I'll try and do today, because there's so many options for diagnostic tools, assessments across the world, I'll just try and streamline a few of the things that I found most useful, that you might find most useful when yourselves are seeing patients with autism. And then Professor Deb will go on to talk about the psychopharmacology after my introduction on the diagnosis. So autism spectrum disorder, ASD, as we know, highly strong genetic component. I'll come to some of the more worldwide statistics later, but it's worth noting that actually there is an increased prevalence, 3 to 6% in preterm infants, so there's an association there. There is an association with the comorbidity with ADHD, and that's interesting in itself because, in fact, until recently, we weren't able to diagnose both ASD and ADHD together. So now the figures show 28 to 44% comorbidity. A high comorbidity of anxiety of depression as well, anything ranging between 10 to 54%. And then other comorbidities to just be aware of. One big one is obsessive compulsive disorder, OCD. So always want to screen for as well when we are diagnosing autism. And I'll come on to this maybe slightly later, but misdiagnosis in adults, there's a big overlap with the symptoms of personality disorder, particularly in the ICD-11, and how some of the features of autism can also present. So something to be mindful of. So the World Health Organization statistics on it. So it's approximately 1% prevalence at the moment. The key thinking now is that, in fact, autism can be diagnosed much later. And we are seeing many people come forward as adults, questioning and looking for a diagnosis. However, there should be some characteristics or traits that you're aware of or that was seen in childhood, and that comes into the diagnosis, as I will talk about later. The abilities and needs of people vary according to external demand, and at different time points in their life, people's support needs can evolve and change. That's not to say the diagnosis goes away, but the support needs can change. There are evidence-based psychological interventions. They can improve communication, social skills, and actually have a really positive impact. There are community and societal levels of support needed, particularly in schools all the way through to the workplace. And the difference there, nearly a double diagnosis in males compared to females, and particular reasons for that. One genetic, but another around masking and whether women are able to mask better in society, and therefore autism isn't picked up until much later on in women particularly. So just a quick overview of what the differences are, which you're probably already very aware of. The big ones are differences in the way autistic people process social information. Now, this leads to a difference in social communication and interaction. The flexibility of the thought and the social imagination. So you'll have children perhaps who can play a structured team game absolutely fine, such as a football or a game with rules. But then if it becomes a more fluid and free-for game, where actually the rules keep changing and it's different every day, you might find that child has a bit more trouble with that game. Then you come on to the criterion B, the repetitive interests or activities, and the intense interests. And what I mean by intense interests, which can be a real source of strength, in fact, for autistic people, is interests that they spend significant amounts of time either engaging in or significant amounts of time thinking about as well. And that would count as part of an intense interest, even if they're not engaging in it, if they're thinking about it, talking about it, researching it, for instance, that still counts as time spent on that interest. Repetitive behaviors, so stimming comes into this, repetitive movements, particularly with hands. You might observe people rocking back and forwards. And repetitive phrases that they might use or repetitive foods that they might eat. And then a difference in the way an autistic person processes sensory information. So you'll find they might be hyper or hyposensitive to light, sound, temperature, pressure, touch, texture. Has a profound impact on multiple areas of people's lives, of people's quality of lives, right through from education, from the early school years going on. Often people have extensive academic ability, but struggle to meet their potential because of difficulties coping with the social aspect of education, and also because of sensory overwhelm, and the multiple other differences highlighted before. People have a reduced social repertoire because social interaction is so difficult for them. Social integration then becomes more difficult and becomes tiring, and their social repertoire is reduced as a result. As a result, it's going to affect their self-esteem and their confidence, and you unfortunately then get a follow-on of comorbid mental illness, particularly anxiety and depression. And I've met multiple autistic people who will come in and actually tell me that they've felt anxious or sad as long as they can remember, and they talk about self-harm as a child due to this anxiety, and a really ongoing, lasting impact on mental illness as well. And then family and relationships. So it affects relationships with their family, with their friendships throughout their life, and of course their career as well, because they struggle with social interaction in the workplace, or sensory overwhelm in the workplace, or a sense of justice, or needing to follow rules, and so on. So the diagnosis, I've just put a bit of an overview here. The diagnosis approach has actually changed significantly over the last few years, particularly as we now use DSM-5. And I use that as the current main tool. There's different gold screening, obviously diagnostic tools that we can use, but I always think if in doubt, go back to DSM-5, go to the criteria, do they meet it, And if you're not sure, you can ask further questions. You can ask for a family member to come and interview them, and so on. So I've just talked about screening a little bit. So we use the MChat, that's for children, a very easy parent screening tool, and a high sensitivity on it. So it opens the gateway to further assessment if people are worried. And then in adults, the main one, at least in the UK, I often see used or we use is the AQ10 or the AQ50. Now, one word of caution I would say with the AQ10 or AQ50 is if someone has a comorbid ADHD, it reduces the sensitivity of the autism spectrum quotient, because often actually their ADHD traits or symptoms are fighting a bit against the ASD side, and then the answers they give on the AQ50 is more reflective of their ADHD and doesn't the scoring doesn't quite come across as you would expect. So the screening is very helpful, but really you need that full diagnostic assessment. And there's different guidelines and there's different tools that can be used, but the general, at least in the UK, the NICE guidelines, the gold standard, suggests that there should be a consensus between the MDT. So if in doubt, you have more than one person do the assessment, have more than one person present from different MDT backgrounds, and to use both an ADIR and an ADOS if you can. And that's a sort of gold standard, having both of those tools and doing it in the MDT framework if you can. I've just put here the screening tools just so people can see them if they hadn't seen them before. And if you look here on the AQ10, so it's for the person to self-fill themselves, talking about some sensory bits, talking about some concentration task shifting, and talking about recognizing of others' emotions, others' intentions, and their own emotions as well. And the scoring goes across, as you can see, definitely agree to definitely disagree. So I've come now to the DSM-5 criteria, again, just to make sure everyone is familiar with this. And I think what I'll do here is I've listed it out here that may not be possible for everyone to see, but instead I think I'll just jump ahead to criterion A and we can go through criterion A and B. Criterion A, so you need A1, A2, and A3 to all be present as part of the diagnosis. So criterion A1 are your differences in your social emotional reciprocity. And your examples are here. So someone might have trouble initiating conversation that's not around their special interest, difficulty maintaining conversation. Lots and lots of people say to me they have to script ahead of time. They might look at messages that the person has sent them and then think, right, what can I talk about related to these previous messages that I've sent this person? Let me think of some sentences in my head and then go to the social event with this person. So a lot of people will socialize using this. Criterion A2, differences in non-verbal communicative behaviors. And this can be anything through to the body language, to facial expressions, not liking eye contact, and autistic people can often describe having to maintain eye contact as almost feeling like physical pain to them. Difficulty changing the expression in their voice. And often difficulty also knowing what they're feeling, what their own emotions are. And autistic people will often struggle to recognize and express their own emotions, which can lead to overwhelms and meltdowns, as we know. And then criterion A3, so differences in developing, maintaining, and understanding relationships. And the bit I think to highlight is often there's a difficulty or a difference in maintaining that relationship. So autistic people can start a friendship often through a shared interest, but then a conflict might happen, and it's that difficulty of how to maintain it and why is it that the maintaining isn't happening that often you will see for an autistic person over the lifetime. And then I'll come on to criterion B. So you need 2 of these categories in order to meet diagnosis. So any 2 of your repetitive movements, the inflexibility, the rigidity of thinking. So routines or sameness or pattern of behavior, that's sameness need to be there, and security in routine. Autistic people often need routine and structure to feel safe, and real difficulty with unexpected changes. Now, in a child, that might lead to a meltdown. In an adult, that might lead to also a meltdown that presents in a different way, such as they shut down or they withdraw or can't engage in the change. And then the intense interest that we talked about, which can absolutely serve to self-soothe. And then the difference in reactivity to the sensory input. And often you'll see evidence of that in front of you because the person may bring sensory objects with them that they use to self-soothe whilst you're talking to them. So that's some good examples of things you can visually see as well. And then criterion CDRE. So this, you just have to make sure that there's some traits or something that are present in the early developmental period. Now, to bear in mind that people may have masked them early on, or that the traits may not become visible until the demand outweighs the person's ability to mask, such as when they start secondary school or when they start work. But if you get the correct history and speak to family members, there will be something that you would be able to pull out and note, even in those early developmental years. And criterion D, it's got to cause significant impairment in social, occupational, or other important areas of functioning, and that will also include mental well-being, mental health, physical health, and emotional health. And as we know, of course, it's not better explained by ID or global developmental delay. I just very quickly have brought up ICD-11 here. Just to give the overview, I prefer DSM-5. It's much more specific. I find you can go through the criteria one by one, whereas ICD-11, it's all sort of put into one paragraph here. But that's just so everyone can see it and everyone is aware that that is also there and available to use if they want to. So in terms of diagnostic tools, there's 3 instruments with the most strong supportive evidence base: your ADOS, your ADIR, and the Childhood Autism Rating Scale, which I won't talk so much about because that's more for observation in childhood. The Autism Diagnostic Interview Revised, the ADIR, developed by the Michael Rutter's team in the late 80s now, I think, and good sensitivity and specificity actually for it. So the ADIR, for anyone who doesn't know, it's a semi-structured interview, and it's with a caregiver or a parent of the person or a family member. And really detailed questions it goes through on their social interactions, their sensory difficulties, their developmental history. Ideally, you want to be using this for a child or person who's at least 5 years old or above, because there's a lot of sections in the ADIR that specifically asks about what were they like before age 5 and what were they like at age 5 onwards. So ideally, you want to wait till then to use it. And the nice thing about the ADIR is quite nicely matches up with the DSM. So it's very helpful to use if you're picking one that you have to use. Obviously, ADIR, ADOS, all of them require separate training for everyone to do, around 3 days or so, and then to start sort of observing and diagnosing cases. And then the ADOS. Now, the ADOS is a directly observed and also standardized and semi-structured, but a directly observed diagnostic tool that people use. And there's different modules to it. So according to the person's age or verbal age or how much they're able to verbalize, you choose that module. There's a set of tasks that you watch the person do, and the scoring happens accordingly. Now, this is extensively validated, very sensitive, very specific. Some of the limitations of it is it is a single setting observation. So obviously, if the person is able to mask, to give an example, for instance, people have said to me, as a child, they were doing the ADOS, they were told to make an imaginative play, an imaginative story. They did this beautifully and therefore scored low on that section of the ADOS. However, what they said was, in fact, they just watched a TV program and copied the game and the imaginary game that they'd seen on that TV program and reproduced it beautifully in the ADOS. So you can get situations like that, which is why that full developmental history and interview and diagnostic criteria are so important. And you do, of course, need training requirements. So again, you've got a resource potential issue for these where you've got to have enough assessors who are qualified in being delivered in these instruments. Do complement each other. ADOS and ADIR are really nice to use together. And giving a really good overview of what's happening for the person. And just a quick note on CARS, it's quick and you can use it in varied settings, but it doesn't have that full developmental history that you will get with the ADIR. And I've talked a bit about both of these, and that a gold standard would include both. Psychometric properties are here, just for interest. So your ADIR, actually the test sensitivity is a bit lower of that, and your ADOS sensitivity is a bit higher. The specificity is 75% for your ADOS and 68%, again, slightly lower for your ADIR. Now, I just wanted to bring this up in case there are some who haven't heard of it. This is a newer screening tool for adults with ASD. And, I'm noting that we don't, in fact, use the word Asperger's anymore particularly, but this is what this was named, shortened to RADS-R. Now, the authors who did this did an internal validation in 2011. When they did it, they got 100% specificity. The study they used had about 65 participants, so it was quite a small study. But for theirs, that's the number they got. How the RADS works is, I've just put it up here to show. It's a questionnaire that the person fills in themselves, but in the presence of a clinician. So if there's any questions they don't understand, they can ask the clinician how to answer it, what it might mean, and so on. So as you can see, there's some social communication questions in there. There's some empathy and emotional quotient questions in there. Questions about interests. This is just a snapshot of it. There's far more items on it. So that can be a useful screening tool for adults and an alternative option to the AQ50. There are other systems in use. So there's the adults Asperger's, again, use of the word Asperger's assessment. It's a whole diagnostic system made by the same authors as the AQ and the empathy quotient, which is the EQ. And that includes, again, an observational semi-structured interview plus the AQ and EQ together. And I've just put a snapshot of the EQ here for anyone to see who's not familiar with it. And again, that looks at people's empathy quotient. Do they enjoy caring for most people? Do they prefer animals to humans? And how are friendships and relationships for them? Now, this is something I probably use quite a lot in practice. And again, perhaps more relevant to the UK, but it's the Royal College of Psychiatrists diagnostic interview. And it basically goes through your DSM-5 and gives examples and prompts and questions that you can ask for each section. So here's your nonverbal, here's your looking for repetitive movements, how they're appearing. Here's how the speech is. There are some very nice questions in there which you can use, such as what does a friend mean to you, or how would you describe depression? And it's really useful and interesting to hear how an autistic person might define that and what it means to them. So that's actually a freely accessible, very useful tool that people can also use to supplement the diagnostic process. And just to remember always the contextual, the operational, the interactional factors for any clinical guidelines. Are they masking? What's the social context? how is the family member interacting with the practitioner who's doing that, and is that having an effect? And what diagnostic tools are you using, and what exactly constitutes diagnosis? So always to just keep those social factors in mind when you are doing the assessment. Now, I'm just touching on this. I spoke briefly about ADHD, and in fact, more and more research coming out saying that it's more common than we previously thought to potentially have both diagnoses of ADHD and autism, or traits of ADHD in someone with autism, or vice versa. So often it can be useful to do a screening for ADHD if you are doing an assessment for autism as well. And then I brought this up, personality disorder, because actually in my liaison psychiatry role, I see a lot of this. I see a lot of people come in with a diagnosis of personality disorder where they're self-harming and impulsive and unable to regulate, very dysregulated. And in fact, when you start to reformulate and reassess, it turns out that in fact, the correct diagnosis would make more sense to be a diagnosis of autism rather than personality disorder, which is a completely different approach and treatment that you'd be looking at in that situation. So just something I wanted to bring an awareness of here for people to think about, and do have a look at the criteria for personality disorders and autism, and you'll be able to see the overlaps and how that could easily come up as a overlapping diagnosis. And I just wanted to make sure that we're not forgetting about any of the medical investigations. I've pulled this from the Maudsley Hospital National Guidelines, which is an institute in South London, Institute of Psychiatry. So always looking at the genetic factors, any metabolic and blood monitoring that we need to do. Cardiac reviews, particularly for the ADHD medications, and any of the genetic microdeletions that we're looking for, and any neurological supports that we may need from our neurology colleagues as well. And then finally, some recommendations. So always an MDT approach. There's different pharmacology in different countries, but certainly Professor Deb will come to that, I'm sure. In the US, risperidone and aripiprazole are actually licensed. In the UK, it's more a recommendation for treating an associated comorbidity, such as ADHD, such as OCD, and offering that to the person. There has been an RCT of modified CBT, and I mean neurodiverse aware CBT, for treatment specifically of anxiety and OCD in adults with autism, and it worked quite well. It was a good treatment response and maintenance. And then there's been a trial of cognitive enhancement therapy, which it's essentially a bit like one way to describe it is structured sessions of there's some computer-based sessions, and also imagining in group work social settings for people and how they would react, and how to navigate social situations. And you find over time, actually, there's some good improvement in social outcomes for autistic people, which is fantastic, because often that's a real source of distress for people in that situation. So that was my very, very quick overview of a bit of diagnosis of autism in adults. And I think the next speaker is ready to move on to his section.
But can I just quickly check, Tanya? Tanya has some urgent childcare duty, responsibility, so she may have to move on. So do you want to take questions on your session now?
Yes, absolutely. If there's any questions, we can certainly do that now.
Can I ask a question? I mean, in the adults, we used to say that if you want to make a diagnosis in adults, you have to go back to the childhood and make sure that the symptoms were present and in childhood. But it's not always easy to get a childhood history. What's the position now, and how do you tackle that in your clinic?
You still need to, if you go to the DSM-5, it does say that some traits or something need to have been present in childhood. How you verify that can be difficult. Obviously, most cases, vast majority of cases, we will have information from the person's parent or family member or a sibling who are able to give us very helpful information, or school reports which show some clear evidence of traits. Just very occasionally, you have people who cannot produce that evidence, and you're then relying on their self-report of childhood traits. But often you will find in these people, actually, the autism is really visible to you in terms of perhaps the repetitive movements or the way they speak or the facial expression. So usually you're able to get enough information to make the diagnosis.
Thank you.
Yeah. I think
Hi, I've got a question. I'm Hetal from Liverpool. Your views on DISCO assessment, because when I did my training at the National Autism Center around DISCO training, they were quite clear that because ADIR and ADOS have low specificity and sensitivity, it's not considered as a diagnostic tool. DISCO actually has more evidence as a diagnostic tool.
So I think you'll find there's definitely conflict between the two. There's sort of two camps, isn't there? There's one who made the ADR side. There's another camp who made the DISCO. There's other tools coming in all the time. There's Scan3 and so on that are being processed at the moment. So I think you will find that different groups do have different opinions on what's the most helpful tool to use. I suppose I've given my own personal views and the NICE clinical guidelines. So that's the UK National Institute Clinical Excellence guidelines at the moment, which state the gold standard as a combination of ADIR and ADOS2, if you can, in an MDT setting. I mean, by all means, of course, ever in doubt, you could use different tools. And if there's a question on the diagnosis, you could always approach a different MDT and use the DISCO as well. But I suppose that's my observations on what I've found useful to use in a practical setting.
Yeah, I remember very well the rivalry between Lorna Wing's camp and versus Rutter's camp. But DISCO, I think, approaches it in a slightly different way. This is based on Lorna Wing's original concept of triad and etc. And as you said, maybe ADIR is more close to DSM, etc. But ADIR, any of these, you need training. So maybe you use your clinical judgment. Yeah, sorry, I'm talking too much. Let others ask questions.
Thank you. It was a very excellent talk. My question is, what is the prevalence of like comorbid intellectual disability in adults? Because in children, when we talk about autism, mainly more than 30 to 50% of children have comorbid ID. And how does that influence also about while you are diagnosing autism in adults?
I may have to defer to Professor Deb for the prevalence of ID in adults, if he knows, as to how it affects when you're diagnosing. If there is a clear diagnosis there, that's very helpful, firstly, because then you can just separate out what's meeting the DSM criteria versus what actually has their ID assessment shown is affecting what you're seeing. What's more difficult is when they haven't had an ID diagnosis. Let's say it's a mild or just not been picked up or whatever it is. And actually, in that situation, you might have to go back, or I find I have to go back and say, please, you need to go and get this assessment done first. Come back so we can separate out, because obviously that criterion E, isn't it, is saying if global developmental delay or ID is present, and you think it might be attributed to that, you can't diagnose ASD.
Thanks, Tanya. I've got a few quick questions. Number one is, are you aware of any screening tools in other languages, like in Hindi, to assess people for autism in India? Or
No,
for that matter, in India? Any other languages?
That's a really good question. I'd be really curious to hear if anyone has come across anything that they've found useful and that anything that could be shared.
Not I'm aware of. Are you?
In children, it is there, but not in I'm not sure about adults.
Not in adults, yeah.
So DSM-5 is very clear about making a diagnosis using clinical judgment and interviewing patient and the carer. You don't have to really rely on DISCO and other tools. How do you get on with identifying the level of disability? But that's the area where I really struggle, especially between level 1 and level 2. Not many people like to have level 1 because then they don't get the benefits.
Yes.
So how do you get around that?
Level 2, exactly. That's a very good question. I try to break down the daily living activities section and exactly how much support are they needing with that. If they need support, who is it from? And the other thing that makes it really difficult is that the support level can change according to where the person is in their life. So someone in a very stable relationship, for instance, might need a certain level of support. Now, suddenly they have children and the support needs suddenly massively increase. So absolutely, the difficulties between level 1 and 2. I find level 1 is more common. If it's level 2, I find they're often unable to leave the house because they're so at that level where they're unable to manage even going to the shop, going to the supermarket, buying themselves food. Or they're often unable to cook their own food without support, or the basic hygiene levels. If they're struggling to shower daily and that sensory input is so high they need support with that, then I'm thinking that's more towards a level 2. So I think my threshold for a level 2 is probably quite high, actually. But you're absolutely right. People will come in and will say, you have to be aware that people do want supports with benefits and so on, or whatever it is, and always to keep that in mind.
I sometimes use Huda's disability questionnaire, life skill profile, and VACE impairment rating scales. They can add on at times. Thanks, Tanya. Very informative.
Thank you very much. Thank you for having me.
When you say that is a diagnosis of autism in adults, is it that more high functioning that is level, or even other types also more prevalent among adults?
So I am glad you mentioned the word high functioning. I could talk about high functioning for a long time and that term and what it means. But the level of prevalence, I would say, is more prominent. And if by high functioning, do you mean people who have navigated the education system and are in careers and relationships and so on? Then yes, a lot more of that category, if you like, of people, that prevalence is increasing. High functioning itself is a term that, again, I try to be a bit wary with because a lot of people will say, well, I'm described as high functioning, I'm doing a job and so on, but the effort and the absolute sort of time and that is taken to be able to maintain this is huge. So then perhaps they're not functioning in the way they should be. But yes, I think was a short answer to your question.
Maybe high functioning might get missed during the childhood diagnosis.
Yeah.
That can also be
very much so.
Thank you very much, ma'am. Sir, we have a request from you. Can we play your recording here?
Yeah. I was just going to say that in the beginning that it's like the TV program where in the cooking program, they say, I prepared something for you earlier. So this is something I prepared for you earlier. So you can play it. Yeah. Thank you.
Thank you, sir.
Hi, everybody. I would like to start by thanking Jazz for inviting me to present this webinar, and Jazz, Vivek, and Krish's colleagues in Chennai for putting together such an excellent program. I'm going to close the video box because this is obstructing my screen, but of course you could still listen to my presentation. Today, I'm going to present the findings from 3 of our recent publications on systematic reviews and meta-analysis of RCTs on psychotropic medications for autistic individuals. One thing is that in the UK, apparently people with autism would prefer to be called autistic people. Therefore, I'm going to use that term. But I appreciate that people in other parts of the world may choose to be called differently. I'm going to start with a slide that I'm not going to present. Why? Because I want to highlight the fact that many pharmacological and non-pharmacological interventions have been trialed in autistic individuals with varying degrees of success. This is not an exhaustive list, but it gives you an idea about the variety of novel and established pharmacological interventions that have been tried for autism. But today, I won't go into them. Instead, I will present data on 3 classes of psychotropics, namely antipsychotics, antidepressants and anti-anxiety medications, and mood stabilizers, primarily anti-epileptic medications, yes. I'll present data from RCTs only, as it would be a waste of time to go into details about hundreds of case studies. On this slide, I have summarized the main characteristics of the RCTs on 3 different classes of psychotropics. So to start with, there are 21 RCTs on antipsychotics involving 1,482 autistic participants. There are 13 RCTs involving antidepressants and anti-anxiety medications that included 958 autistic participants and 8 involving mood stabilizers, primarily antiepileptics, including a total of 380 autistic participants. And as most RCTs are on antipsychotics, I will spend most of my time discussing antipsychotics, and we'll go into other psychotropics if time allows. So I'm going to summarize the data in my presentation today from this 2023 systematic review and meta-analysis that we published in the journal Psychological Medicine. So I'll start with antipsychotic RCTs, as I said. We extracted data from 21 primary RCTs on antipsychotics and an additional 18 studies that originated from these RCTs. Most RCTs, as you would expect, are on risperidone, followed by aripiprazole, 14 and 5 respectively. There is one very small RCT on olanzapine with only 9 participants and only one RCT on lurasidone that recruited a reasonable number of participants, 150, but I think it's still likely to be underpowered. We also reviewed 5 RCTs on haloperidol, but didn't analyze their data because they were all crossover trial, and none of them actually presented separate data for the first phase of the study, which was our inclusion criterion for the crossover trials. So the rest of the studies are parallel design. First thing to say is that most RCTs included autistic children and very rarely adults, and predominantly male participants. Some studies explicitly included autistic individuals with intellectual disabilities. Most antipsychotics were used at a similar dose to what is recommended for treating severe mental illness, except risperidone, which was used at a dose of 0.25 to 2.5 milligram maximum daily dose, which is a much lower dose than recommended for the treatment of psychosis and bipolar disorder. Why? I'm not sure, but I know that there is a prevailing belief among the clinicians, at least in the UK, that at a lower dose, risperidone treats autistic anxiety. Although I don't think there is any RCT-based evidence to support this notion, and neither the risperidone is licensed for this indication. I will return to the details of RCTs on risperidone in the subsequent slides, but for now, let's concentrate on the other antipsychotics on this slide. So we'll start with aripiprazole. There are 5 RCTs on aripiprazole, but 2 of the largest ones were conducted by the pharmaceutical company that produces aripiprazole. Therefore, in my opinion, there's more independent research is needed to provide any conclusive evidence of aripiprazole's efficacy. However, 4 of the 5 RCTs showed a significant improvement in the aripiprazole-treated group compared with placebo on the outcome measures used. And I will return to the outcome measures later. The single-center olanzapine study is so small that it is not worth talking about, at least in my opinion. So I'll move on to lurasidone. There's one multi-center study that used 2 different doses of lurasidone at 20 and 60 milligram daily among 150 autistic children. To start with, there was no statistically significant intergroup difference in the primary outcome measure, which was the aberrant behavior checklist irritability subscale, ABCI. However, that said, there was another outcome measure that was used in the study, clinical global impression scale, CGI, and the score of which showed a significant improvement in only one group that used 20 milligram dose, but not in the group that used 60 milligram lurasidone dose. Now let's go back to risperidone. There were 7 placebo-controlled RCTs on risperidone involving autistic children, and all showed a statistically significant improvement in the intervention group compared to the placebo in at least some of the outcome measures. There were 2 RCTs involving what I call risperidone plus. In one RCT, a risperidone-only group was compared with a group that received risperidone plus parent training, and another group received a behavioral intervention in the form of virtual reality in addition to risperidone. And as you'd expect, both studies showed that the combination is better than the medication treatment alone. There were 5 other what are known as non-inferiority RCTs in which risperidone was compared head-to-head with another medication. 2 of them compared risperidone with aripiprazole, and in one of those studies, risperidone was superior to aripiprazole. But in another one, there was no intergroup difference, but both groups showed post-intervention improvement. In one study, risperidone was superior to haloperidol, and in another divalproex sodium, but not to memantine in the third study. But these are all small studies and are therefore prone to type 2 errors. Before I give you more data on the RCTs, let me talk about an important issue. As you know, the primary concern of using antipsychotics, particularly in the long term, is about their adverse effects. And the well-known adverse effects are sedation, weight gain, raised prolactin level, glucose intolerance, and cardiometabolic symptoms like metabolic syndrome, as well as cholinergic burden and extrapyramidal symptoms, etc. And they have the potential to impact the patient's quality of life and in many cases reduce their life expectancy and cause early deaths. Although extrapyramidal symptoms are usually associated or known to be associated with primarily older antipsychotics like haloperidol and chlorpromazine, but they may still be seen in patients treated with the newer antipsychotics like risperidone and quetiapine, olanzapine, etc. So one thing that really bothers me is that, at least in the UK, our own study and other audits of clinical practice showed that there is a lack of monitoring for these adverse effects. So when it comes to individual patients, we have to weigh up the risks against the benefits very carefully and discuss them frankly with the patients and their caregivers and reach a consensus on the treatment and a clear follow-up and monitoring pathway from the very outset. Now, this, of course, is common sense, but as you know, common sense often is not that common. Now, coming back to the RCT-based data, or outcome data, most individual RCTs are small and therefore underpowered, making it difficult to draw any definitive conclusions from their findings. So there is one statistical approach to address this problem, which is known as a meta-analysis, in which we pool data from several small studies and analyze the combined data because it increases the power of the study. However, you can only pool data from different studies if they use the same outcome measures. The finding of the meta-analysis are presented in a figure like this called a forest plot. And this particular slide shows the outcome of antipsychotic RCTs based on ABCI score. Those who are not familiar with the forest plots, I will give you a quick guided tour. If we pool data from an outcome measure that provides continuous data, in this case, the ABCI score, we work out what is called the standardized mean difference, or SMD, instead of mean and standard deviation, for each study, which is represented by these lines. The red dot in the middle is the mean, actually in this case, SMD, and the width of the line represents the 95% confidence interval. And the wider this line, the smaller the sample size. So if you look at the aripiprazole studies, NCT 004 has a very wide horizontal line. Why? Because it recruited only 13 participants. In contrast, if you look at Marcus et al.'s study, this has a very narrow line because it included 280 participants. So the combined mean and standard deviation, in this case SMD and 95% confidence interval from all 5 aripiprazole studies are represented by this little diamond shape or rhomboid shape. And you can see the diamond is very narrow because it contains data from a large number of participants. For SMDs, the middle line passes to 0. And if the horizontal line representing the standard deviation crosses the middle line at 0, this indicates that the study is not statistically significant. There's no statistically significant intergroup difference in this study. However, if the diamond falls on either side of the line, that represents a statistically significant intergroup difference. If the diamond falls on the left-hand side of the 0 bar, that means the intervention is significantly better than the placebo. On the other hand, if it falls on the right-hand side of the bar, this and does not cross the middle line, the bar, that indicates that the placebo is significantly better. The diamond at the bottom of the forest plot represents combined data from all 10 antipsychotic RCTs that used ABCI as the common measure. One other thing worth emphasizing in a forest plot is the degree of heterogeneity among studies, which is rather statistical than a clinical concept. So according to the Cochrane Handbook, heterogeneity over 50% is considered significant or high. And in this forest plot, you see the heterogeneity is over 50%. Thus, we'd call it significant. As shown by the diamonds, both the aripiprazole and the risperidone studies showed a statistically significant improvement when you combine data for each of these medications in the ABCI scores compared with the placebo group. However, the lurasidone study, as you can see, was not statistically significant because the rhomboid actually crossed the middle line. The overall pooled data from all 10 antipsychotic RCTs showed a statistically significant improvement in post-intervention ABCI score compared with placebo, with a relatively large effect size of -6.45. And we see similar findings this time using CGI-I scores rather than the ABCI score. CGI-I was developed in the USA and is widely used in psychiatric research as an outcome measure. However, for CGI-I, you will see on this slide, heterogeneity was high at 75%. And the effect size was smaller at 0.84% compared with that of the ABCI score I've just shown you in the previous slide. And the same with CY box score, which stands for Children Yale Brown Obsessive Compulsive Scale. Now, when it comes to adverse effects, the vertical bar goes through 1 rather than 0, as we saw in case of SMD for the ABCI score. Why? Because in this case, the data are not continuous, they're dichotomous. So adverse effect is either present or absent. So they're represented by odds ratio or OR rather than SMD, as was the case for ABCI. The pooled data from 8 studies of antipsychotics show a significantly higher odds ratio of 2.25 in the intervention group. This means that participants in the intervention group are 2.25 times more likely to experience adverse effects than those in the placebo group. And the heterogeneity in this case is less than 50%, so therefore could be counted as not significant. The odds for increased appetite are 4.15, and for weight gain is 3.9, and for sedation is 6.66. Another thing we do in a systematic review is assess the quality of the evidence presented in each RCT. And one standard method is to use the Cochrane risk of bias instrument, which assesses bias across 7 domains. So the green blobs indicate no bias in the study in that particular domain. Red indicates a definite bias, and yellow indicates an uncertain bias. And as you can see from the summary side table, most studies had either a definite or potential bias in one or more domains. Two other things we assess in meta-analysis are publication bias using a funnel plot like this, and the level of certainty, whether it's high or moderate or low, using GRADE criteria, which has 5 domains. But I don't have time to go into them. Instead, I would show you this slide because I think this is clinically important. I'm using this is the finding, kind of summary findings from most of the studies. And I'm using this as a kind of a prototype for summary findings from most of the RCTs, antipsychotic RCTs. Because I wanted you to take home some important messages from this slide. The blue line represents the scores for the primary outcome measure in the study for the risperidone treated group. So blue line is for risperidone, remember, and gray line is for the placebo group. And the lower the group, so the lower the line goes, the better the improvement. And I want to draw your attention to 3 things in this slide. First, you'll notice there is a very sharp drop in the score within the first few weeks. And this is what you see in clinical practice. However, I would also like to point out that this sharp drop affected both arms, which indicates a very large placebo effect. So you have to keep that in mind. And the second thing to note is that after the first few weeks, the improvement in both groups tend to plateau. And this is what I call the danger zone, when clinicians keep increasing the dose of the medication or add another psychotropic. However, it's worth noting that the difference between the intervention and placebo arms remains statistically significant, not only during the first few weeks when there's a sharp improvement, but also at 6 weeks of follow-up. I'm going to skip the following few slides on the meta-analysis of antidepressant, anti-anxiety, and mood stabilizer medications, as there is nothing really to write home about them, as basically they're small studies showing non-conclusive evidence. Instead, I would like to spend a bit of time discussing the meaning of the findings from the RCTs and also the meta-analysis. The first thing to say is that different studies use different outcome measures, making it difficult to interpret data and also combine the data for a combined analysis. What about the outcome measures themselves? I said I'll come back to this. Let's start with ABCI, developed by an American psychologist, Professor Michael Amen, who conducted many of these RCTs himself. ABCI is widely used in psychopharmacological RCTs involving people with neurodevelopmental disorders, particularly in the USA. However, the elephant in the room is that ABCI has 15 items within this irritability subsection that are, in my opinion, clinically very varied and may not necessarily be directly related to irritability, such as, just to give you some examples of items in that subscale: crying, depressed mood, quickly changing mood, seeking attention, self-injury, aggression, etc. So although people, when they look at the findings of these studies, they say, well, risperidone showed an improvement in irritability in autistic children. But is that so? Because the point I'm making is that it is difficult to know which of these behaviors or items showed an improvement when the ABC score improved. Similarly, CY box is designed to assess obsessive compulsive symptoms, not autistic core symptoms, such as restrictive repetitive behavior. Yet this scale has been used as a proxy measure for autistic core symptoms. However, it's worth remembering that many autistic people tell us that they don't want an intervention to improve their autistic core symptoms, unless, of course, it does improve their quality of life. No study has assessed the effect of psychotropic medications on autistic people's mental health, for which these medications have been licensed. A notable exception is the Strata study, which has just been completed by my colleague, Professor Dheeraj Rai from the University of Bristol, UK, who showed that among 318 autistic adults, and this time we're talking about adults rather than children, a varying dose of 25 to 200 milligram daily of sertraline improved anxiety symptoms significantly at 16 weeks follow-up when compared with the placebo group. However, the effect size was small at 0.196, but there was no significant intergroup difference in the adverse effects profile. Similarly, there's very little reporting in these RCTs on the effect of these psychotropic medications on improving the participants' quality of life, which should be the ultimate aim of any intervention. Most RCTs are from the USA and were supported by pharmaceutical companies. Most RCTs did not present data on metabolic syndrome. Most RCTs are add-on studies. So we don't know whether the concomitant pharmacological and non-pharmacological interventions caused any confounding. Although one may argue that in a fully powered RCT, those confounders would have been balanced out in between the two arms. But the studies I presented, most studies were underpowered. So I always wondered whether it would have been always better if there were a non-pharmacological intervention arm in these RCTs over and above the medicine arm and the placebo arm. However, having said that, there are practical difficulties of having the third arm. The number of participants will go up, and recruitment is a major problem in this particular field. Most RCTs don't provide data on concomitant mental illness. Despite the well-known association between mental illness and challenging behavior, or behaviors that challenge, or behaviors of concern, whatever you want to call them. And often the psychotropic medications are licensed for these interventions, and most of the RCTs targeted challenging behavior as their primary outcome. And we don't know the effect of concomitant neurodevelopmental disorders like intellectual disabilities and ADHD, as they are not described in most studies. There are no separate data presented on the groups, those who had autism and ADHD or autism and intellectual disabilities, despite the fact that these are common co-occurrences or comorbidities of autism. Similarly, most RCTs reported the short-term effects of these medications, yet in practice, they're often used long-term. Having said that, there are a few RCTs that continued with the antipsychotic treatment for many weeks and months in an open-label fashion after completing the RCT trial. And most showed the initial improvement was sustained in most participants in the long run, and adverse effects were by and large tolerable. Yet none of these long-term studies are RCTs, therefore making it difficult to draw any definitive conclusion about the long-term effects of these interventions and their adverse effects. Last but not least is the issue of optimum dosing. Did the studies use the correct dose? If the dose is too low, the intervention may be ineffective. Similarly, if the dose is too high, the intervention is likely to cause adverse effects, masking any apparent improvement. Although you may argue that most of the RCTs on risperidone, which showed improvement, must have used the correct dose. So, to summarize, there is a moderate quality evidence that risperidone at a low dose, 0.25 to 2.5 milligrams daily, significantly improves autistic-associated behaviors in children, particularly related to irritability or possibly related to irritability compared with placebo. There is some early evidence, not as strong as risperidone, that aripiprazole significantly improves some associated behaviors in autistic children. However, as the pharmaceutical company conducted the 2 primary studies on aripiprazole, I will argue that more independent research is needed before a definitive conclusion can be drawn. But having said that, based on these findings, in the USA, the Food and Drug Administration Agency, FDA, has already approved the use of risperidone in a small dose and aripiprazole for treating irritability in autistic children. But no such recommendation exists in the UK from NICE, which stands for the National Institute for Health and Care Excellence. There is clear evidence of potential harm from these medications, so you have to very carefully weigh up the benefits against the risks in each case. There is no evidence on these medications' efficacy on autistic core symptoms, and nor is there any evidence on adults. There is no evidence either supporting or refuting their use among autistic people for any other antipsychotics other than risperidone and aripiprazole, and for that matter, any other psychotropic medication classes such as antidepressants, anti-anxiety, and mood stabilizers. Before I leave, I would like to leave this slide on the screen for a couple of minutes to complement Tanya's presentation. This is an ASD online module we developed as part of the Spectrum staff training program. We believe this is an excellent resource, but you would expect me to say so because we developed this module. So if you don't want to take my word for it, please check it out yourself. And if you have any problems accessing the module, please email me. Thank you for listening.
Thank you, Professor, for the wonderful talk. And you took all the time to pre-record the talk and send so that everything goes smooth. Just because due to the paucity of time, Prof, we will share your email address to all the participants if they have any questions to both of you and Dr. Tanya, and they will reach out to you directly. Thank you, and thank you for all the help while spreading the word about the program. I saw the extensive list of professors and professionals you have shared. So thank you once again for the help, sir.
Thank you.
Thank you.
Hope it goes well.
Thank you, sir. It was very excellent. Detailed.
Before we close the session, I would like to present Dr. Praveen for a small token of our appreciation.
I'll take a photo.
No, is there?
Just photo is.
You want one?
Yeah, you can take that over.
He want to show to his family, na?
Yes. Yeah, ready, sir?
So moving on to the last session, brain and behavior interface. Well, it is one of the topics and the speakers when we looked at, and I think I haven't came across such an interesting session. We are talking about the criminal justice system and neuropsychiatry. We are talking about the risky behaviors. We are talking about the neuromodulation in neoplastic diseases, vestibular cochlear. So this symposium is not what you find very easily in across the globe. So for chairing, I have with me Professor Samir Praraj, Professor of Psychiatry at KMC, Kasturba Medical College, Manipal University. He's a very experience over 20 years, 300 plus publication, very eminent figure. Also currently the honorary secretary in the Neuromodulation Society India. Welcome you, sir. And to join Professor Samir Praraj, I have with me Dr. Ashutosh Singh, a senior consultant psychiatrist from the central India who traveled all the way, and also our lead psychiatrist in Buddhi Clinic, Indore. Welcome you, sir. Please stay.
Okay. 100% fine. Yeah.
Okay, so we will have Dr. Professor Umar to go first.
Hello, Professor Praharaj and Kirk. Is it possible for me to go before Dr. Kirk?
Yeah, good evening. Yes, please. So, anyone wants to introduce or there, or should I read out?
Okay, please do.
Yeah. So, let me introduce Professor Uma Rao. She's Professor of Psychiatry and Human Behavior, Pediatrics and Psychological Sciences, University of California, USA. She has more than 35 years of experience, more than 150 publications, and awards and recognitions to her credit. I think the topic is very interesting. So neural markers associated with prevention program for risky behaviors among adolescents. Without wasting time, maybe I would request Madam to start her presentation.
Thank you very much for the kind introduction, Dr. Prasad. Let me share the slides. Can everybody see? Hello, can everybody see the slides?
we can.
Yes.
Oh,
yes.
thank you very much. Okay. What I'm going to be doing in the next half hour is actually describe a little bit of background about developmental changes in reward-seeking behavior in adolescents and maturational brain changes that accompany these behavioral processes. Then I will describe briefly a study that we have conducted looking at neural circuitry changes associated with the prevention program for risky behaviors in at-risk youth, and very briefly then describe some clinical implications for these findings. So from an evolutionary sense, actually, adolescence increase from a safe, certain thing during the childhood to exploring new things and gaining autonomy. And from an evolutionary perspective, this actually ensures survival of the species, where adolescents then go, like in the animal kingdom and the aboriginals, people would actually, as soon as you attain puberty, would go out, seek new resources, sexual partners from their families of origin. And so this is helpful. But in our society, right, adolescence is very prolonged. First of all, puberty is much earlier than before because of better nutrition and other factors. And individuals like teens are even like dependent on parents until even up to age 25, 26. So there is sort of an imbalance between like what happens from a biological sense or social contextual sense from before to now. And here is a slide actually showing from an empirical study looking at self-reported ratings of teens for reward-seeking behavior. During adolescence, what happens is from early adolescence, there is an increase in reward-seeking behavior. So there is increased motivation to seek out rewards and also increased arousal in response to rewards. And then slowly it comes down. And these behavioral changes are also accompanied by brain maturational changes. So in the healthy brain, the reward or motivational processes are governed by a number of cortical and subcortical structures. And here I'm going to be specifically focusing on the striatum, ventral striatum, which is involved in integrating cognition, motor control, and motivation of reward processes. And for these reward processes, there is also higher up centers such as the prefrontal cortex, which is involved in higher cognitive functions, which balances the affective, impulsive choices that are associated with the subcortical structures to long-term future-oriented goals as the age progresses. So here the signaling, the darker line shows more maturity and or greater signaling compared to the lightest areas. So in children, when you look at the functional connectivity or the connection or between the prefrontal cortex and striatum, there is first of all low signaling in both the striatum and prefrontal cortex, and the circuitry from both sides, from the striatum to the prefrontal cortex and from the prefrontal cortex to the striatum, is not mature yet. And what happens during adolescence is there is increased signaling in the striatum, and the connection from the striatum to the prefrontal cortex is mature, showed here by a solid line. But the connection from the prefrontal cortex to the striatum is not mature yet. And then by the time you reach adulthood, there is a connection, functional connectivity from both sides is matured, but the signaling from the prefrontal cortex is much more stronger than it was during the adolescent period. So these developmental changes can lead to sort of a temporal dissociation between the motivated behaviors and higher cognitive functions. So this is like primarily pubertal dependent, which is like increased reward sensitivity and sensation seeking compared to the cognitive control or self-regulation from the higher centers. However, this imbalance doesn't have to happen in all contexts. And there are some contextual factors such as particularly peer influences that happen during this period that can sort of influence how these two regions interact. For example, some investigators actually develop some behavioral tasks to measure this. So in this task, this is a stoplight task where a driver is actually simulated driving, where the teens are asked to drive across these intersections. And at each intersection, there is a stop or a go signal. And when there is a stop signal, there are choices. You can wait, as normal, mature adults do, or you can go against the stoplight. And if you're lucky, you could be successful and without delay pass through, or you could land up with a crash. Okay? So this game was actually then administered to a group of adolescents who were 14 to 18 years old, and a group of like young or emerging adults between 19 to 22 years old, and then little more mature adults between 24 to 29 years old. And they were asked to do this task when they were alone, which is showing in blue, or they were told, like they had a peer to bring with them. The peer was in the next room. So they were told that their peer is watching this, what they're doing. So what happens is the risky decisions when they're asked to make a when there is a stop sign, whether they're deciding to stop or go for the stop signal. And then what on the right side is the number of crashes that have happened if they have gone for the stop signal. They did not stop for the stop signal. What you see is in these three groups, when they were alone, the blue side, adolescents actually seem to have pretty reasonable decision. They're not actually speeding during the stop sign. They have stopped. Okay, but when they were told that a peer is watching, see the number, they take much more risky decision compared to the other two groups. And when they have not stopped, they've had more crashes compared to when they were alone, and also compared to their older peers. Again, suggesting how important these peer influences are when they are in the context of like risky decision making issues like taking drugs or alcohol or risky sexual behavior or risky driving. Although all adolescents may be experimenting with drugs and alcohol, in our society, particularly in the United States, African Americans and other minority groups as well experience discrimination, and so there are more social or legal consequences for them. So they could get suspended from school if they're caught with drugs, or they could be sent to detention centers, or if they're speed driving, they could again be given a ticket or sent to, again, more serious legal consequences such as detention centers, etc. And there also blacks have higher rates of HIV and sexually transmitted infections. For example, there are 12%, like blacks represent about 12% of the US population, but they experience about 50% of the HIV risk or AIDS that they have. And they also have more serious sexually transmitted diseases. I'm not going to go into the details, but because of these, both in terms of discriminatory experiences that they experience, and also because of the higher risk for these disorders when they engage in risky behaviors, we were interested in actually developing a prevention program for these African American at-risk youth. So we developed a program, my colleague actually from that. And so I'm just going to go into the study design. What we did is we recruited teens, and at baseline, they completed a number of scales, including risky behaviors. And they had a functional magnetic resonance scan, both resting state and looking at a specific task where they had to make a decision at baseline. Then for 6 weeks, they were randomized either to this PASS program or a waitlist condition. And then after 6 weeks, they had a repeated scan again. Then at 3 months, we again looked at social adjustment in a variety of things, including risky behaviors at 3 months. So in addition to the resting state scan, they participated in a task called as Wheel of Fortune. This is again a very popular game in the United States. And they were given a variety of choices, like different contexts of like what the probability of rewards was. And they could either bet or pass based on how risky those decisions or how big the reward was. Okay? And this the curriculum for this PASS program included, in the first session, separately both the parents and teens at separate sessions for 45 minutes. And then in the next 45 minutes, they had like a conjoined session together. And these are the highlights of the program. They for parents, it was parents being supportive to their children and establishing specific rules for the, and also sort of contingencies for teenagers, and protecting teens against risky behaviors. And for the teens, the sessions included some things like how to establish future goals and having future orientation as opposed to immediate temptations or rewards, and resisting peer pressure. Oh, I'm sorry. And also how to deal with temptations. And then in the conjoined session, establishing specific family values and how both parents and teams should follow those values, and how, again, caregivers and youth together work towards setting up goals in how to protect the youth. For example, even though we can tell teens using drugs are bad, engaging risky sexual behaviors are bad, teens really know that. But in the context of these, say that they go through a social situation and they're offered drugs or alcohol, it's not going to be easy for them to resist that temptation. So parents and teens establish a rule. Say, for example, if they did drink, they establish a rule that they're not going to drive in their friend's drunken friend's car. Instead, they'll call the parent. That time, parent actually is not going to discipline the child in any way, but gets the child because it's important to have the child be safe. So those are the kinds of values or rules that we help them establish during this family session. Okay? So we had 11 to 14-year-old African Americans who were a mean age of 12 and a half years. They had no history of any medical or psychiatric disorder. So actually we had 128 families, but at the time of processing the data, we processed the data for 118 families. 69 of them were in PASS and 49 in waitlist condition. And at baseline, there were no differences at all in any socio-demographic factors or behavioral outcome measures at baseline. And after the intervention, what we looked at is the red is the PASS group, the blue is the waitlist group. This is like 3 months. 3 months after finishing the PASS program or the waitlist, the intervention targeted behaviors. This is a composite index, including how to set goals, how to maintain those goals, how to resist peer pressure, and also negative attitudes toward drugs or alcohol or risky sexual behavior in general. And what you see is, compared to the pre-intervention, at post-intervention or 3 months after the intervention, the adolescents who were randomized to the PASS program had increases in the targeted behaviors that we were focusing on for the PASS program. Whereas for the waitlist condition, there was a slight downward trend actually for them. So there was a significant difference between them at post-intervention. Then what happened is, compared to those who were randomized to the PASS group, the waitlist group actually at post-intervention showed more pessimistic attitude towards the future. As I explained earlier, that this is a high-risk group and they're also significant, discrimination, etc. And this sort of increases as they have more social relationships outside of the family. And so what you see, even within a 3-month period, compared to their baseline, these people were more pessimistic, whereas the PASS group had actually maintained their optimism for the future. And we also looked at behavioral ratings, both from the parent and the child, looking at executive function. There is a scale called BRIEF, Behavioral Rating Inventory for Executive Function, which looks at 3 major scales: behavior regulation, emotional regulation, and cognitive regulation. Here the slide here shows for emotional regulation index. What we found is that here the higher scores are worse functioning. So the waitlist group had worse functioning at post-intervention, that is 3 months after the intervention, compared to the PASS, which maintained their executive function. And we found the same thing in a couple of subscales of the behavioral regulation index, although we did not notice any change in the cognitive regulation index. within this short period. And then we looked at the functional connectivity. Here what the data show is the functional connectivity between the ventral striatum that I showed earlier in this developmental period, what happens, and the prefrontal cortex. This is from pre to post intervention compared to the waitlist condition. Immediately after, remember I mentioned that we have a scan prior to the intervention and immediately post intervention. So compared to the pre-intervention, the PASS group showed higher function connectivity between the ventral striatum and the prefrontal cortex. Here it is the superior frontal cortex and showing the caudate region. And here it is the putamen, another component of the ventral striatum, with some components of the inferior frontal gyrus. And both of these are involved in different cognitive functions, the prefrontal cortex. So the PASS intervention improved functional connectivity compared to the pre-intervention and also compared to the waitlist group. And what we then did is, taking the information we got, the functional connectivity in the PASS group that was at first intervention, and we wanted to see if there was a correlation with the behavioral outcomes we observed 3 months later. And what you can see is the individuals or the youth who had higher functional connectivity between the striatum and the prefrontal cortex showed better or improved intervention targeted behavior. And they also had negative correlation with behavioral as well as emotional regulation index. Remember I mentioned that higher scores are worse functioning for this emotional regulation index and behavioral regulation index. So higher functional connectivity was associated with negative correlation means better behavioral and emotional regulation. And also higher functional connectivity was associated with higher intervention targeted behaviors such as having negative attitudes towards drugs or alcohol or risky sexual behaviors and having higher resistance to peer pressure, etc. Just to summarize the findings, the PASS intervention improved intervention targeted behaviors and also protected against pessimism and emotional and behavioral dysregulation in the youth who were vulnerable for these risky behaviors. And the PASS intervention also improved the frontostriatal functional connectivity in these youth. And the PASS-induced intervention changes in the frontostriatal functional connectivity was associated with improvement in intervention targeted behavior and emotional and behavior regulation. So what does this mean? What are the implications? So one thing that seems is, even though peers are important during this adolescent period, I think parents and say teachers still have a significant influence on them. So we need to have continued parental monitoring, and that's one of the things we teach in the PASS program. With graduated autonomy. We have to give them autonomy, but it should be graduated. And also teaching the youth who have poor self-efficacy, right, to resist bad peer influences. So I'm going to give you a couple of examples of how graduated autonomy is important. So here is a study showing car crashes in adolescent drivers soon after they have gotten driving license. In the United States, you can get a driving license at the age of 16, and then it is like initially supervised, then unsupervised. Then they can go to school, but not other places, etc. So there is a graduated way in different places. So this is females and this is males showing like the number of miles driven by these teens and the number of crashes per 10,000 miles driven. What you can see is the crashes are really high in the beginning, but once they start, as you know, driving is like a skill. The more you practice, the more skilled you are.
So if the parents are still available to supervise them, and then at least for the first 1,000 miles, and then once they gain better skills in driving, then have them drive by themselves. So this is one example, and I'm showing you another example. Remember the stop signal task that I showed earlier? The same task was actually administered to a different set of adolescents in a different study. So here the adolescents did this study alone or in the presence of a mother in the next room. And what you can see is the number of risky decisions they made. That is, like when they were asked to actually stop, they went ahead. So when they were alone, they made more risky choices compared to when the mother was present. And then they completed this task also in the MR scanner. And what you see here is the functional connectivity between the ventral striatum. Here it shows ventral-lateral prefrontal cortex, which is involved in cognitive control and self-monitoring. And what you see is when they made safe decisions, actually, the youth who made this in the presence of the mother, they had better functional connectivity between the ventral striatum and lateral prefrontal cortex compared to when they were alone. When they were alone, they did not have, the functional connectivity was not good. But in the presence of the mother, they had a better functional connectivity. Again, suggesting how, again, even though peer influences seem to be playing a prominent role, having adult supervision is really important during this time period. And I want to thank you all for your attention. And I want to take a moment to acknowledge my research staff who were directly involved in this particular study, although there are others who helped them. My collaborators, I think I mentioned Velma McBride Murray, who is at Vanderbilt University now. Then he was a postdoc, Andrea Boscuti, and here my other colleague, Dr. Vanna. And I want to thank for the support. This particular study was funded by the National Institute of Drug Abuse, which is a part of the National Institutes of Health. And again, we recruit teams cross studies. So I also wanted to acknowledge the National Institute of Mental Health, the National Institute of Mental Health, Minority Health and Discrimination, Diversity, and National Heart, Lung and Blood Institute, where I received funding from. Thank you again for your attention, and if there is time to take questions, I will take. Otherwise, I thank everybody.
Thank you, Professor Uma. I think that was very interesting presentation. So
I'm going to stop sharing the slides.
Yes, brain correlates of the intervention for the risky behaviors, and very interesting. Can we take questions, or are we?
I can take questions if there is time, but I wanted to make sure I'm not infringing on other people's time.
Yes, yes.
Okay.
I think there are no questions.
So thank you once again.
Thank you very much, and I'm sorry I can't attend the other session.
Okay, so let me introduce the next speaker, Dr. Zarina. She's a consultant neuropsychiatrist, Forensic Brain Injury Service, Lancashire and South Cumbria NHS Foundation Trust. And she specializes specifically in forensic brain injury service within the mental health network. And the topic is also very interesting. So brain injury behind bars, so how to recognize, assess, and the different treatment pathways. So may I request Dr. Zarina to start presentation, please.
That's me. I'm just about know how to use a microphone. Well, thank you very much, and good morning, good afternoon, and good evening to all the attendees. It's been absolutely fabulous, and thank you so much, Jazz, for inviting me, Vivek, and Krish, and all of the organising committee as well. What a fantastic 2 days of neuropsychiatry. Hopefully everyone can hear me. Hopefully everyone can understand my accent. It's not an English accent, it's an Irish accent. And it becomes even more Irish whenever I'm a little bit nervous. So apologies and bear with. It's really humbling to be here and to be in this fabulous city of Chennai. My first ever time in India, and I'm very, very impressed and very full in my stomach as well. So without further ado, we're going to spend just a few minutes this afternoon talking about brain injury in the criminal justice system. And yeah, I can't work the eye. Oh, there we go. Here, I'll go back now. I put this slide up. Everybody in this room and online knows about the brain and loves the brain, but I'm constantly surprised by how few people, how few professionals in the health and justice service actually know anything at all about the brain, and even less so members of the public and the patients that we look after as well, and the prisoners. And I do think that it is our responsibility as neuropsychiatrists to spread the word about the brain and to take every opportunity to teach people about this wonderful organ, because we all have one. I think we do anyway. And members of the public know a lot about their heart and heart health. And I think if more people knew about the brain and how important a structure it is, they might take a little bit more care of it. We also know that brain injury is incredibly common, so a prevalence estimate of about 8.5%, and it's costly as well, and that's important whenever it comes to things like getting support for people in the criminal justice system, whenever we're having to lobby for funding for services. So at the minute it costs approximately 1% of the British economy to fund services for brain injury. And we know that there's a link between brain injury and offending, and having a head injury increases the risk of offending by about 50%. And there's, in very simplistic terms, there's a couple of reasons for that. One is the location of the brain injury. So we know the frontal lobes are the most commonly injured parts of the brain, followed by the temporal lobes. And we know that frontal lobe injury can lead to executive functioning difficulties. So issues with controlling impulses, aggressive behaviours, insight, awareness of risk, etc. And also another bit of the brain that's commonly injured during hypoxic brain injuries is the limbic system. So the part of our brain that's responsible for regulation of emotions, urges, impulses and drives. And quite frequently we have injury both of the frontal lobes and a secondary hypoxic brain injury, where you have that perfect storm of dysregulation. But we also know that there's shared demographics between people who are likely to get a brain injury and those who are likely to commit offences. And those are those demographics around low socioeconomic status, low educational attainment, mental illness and substance use. And substance use is more prevalent in people who have brain injury, and it can lead to an increase in that impulsivity and risk-taking behaviours. Now, in my service, I look after 33 men who have acquired brain injuries and who have been in contact with the criminal justice system and committed very serious offences. And almost all of them have had more than one traumatic brain injury, and the effects of that brain injury are cumulative. So what do we know about the offending population? Well, there have been lots of studies done and lots of different outcomes of prevalence ranging from 4 to 100%. And that's because there have been different ways of collecting data, and the data has often been difficult to actually obtain because it's a justice system. And there have been self-reports of brain injury, reviews of medical information, and there was really a lack of cohesion in screening or even the definition of what a brain injury was. But 2023, there was a really very large meta-analysis of brain injury in prisons, and it's come up with this statistic of about 46% for moderate or severe traumatic brain injury. So I roughly go with an estimate of 40% of prisoners would have traumatic brain injury, and that's probably an underestimation, to be fair. But until we have a better way of collecting data, I think that's one that we've been using, certainly in conversations with the government. And that compares to an 8.5% in the general population. And there are more female offenders with brain injury than male. And importantly as well, more than 2/3 of prisoners suffered their traumatic brain injury prior to their first offence. So whenever we were hearing from Uma earlier on about looking at prevention and risky behaviours, we've got the opportunity really to see whether or not we could screen those who may be more likely to offend following the brain injury, and to follow them up and perhaps look at interventional strategies. People with a brain injury offend at a much earlier age, by about 8 years, and that's really important because we know that offending is common in the early 20s, and you take away 8 years from that and you have offending really right in the middle of your prime schooling years. So these are young people who are missing their schooling due to offending behaviours. Drug use is prevalent, as I said before, but people with a brain injury commit more violent crimes, and that's certainly in my population where, you know, commonly the crimes are attempted murder, murder, serious sexual offences, 7 times more likely to have comorbid mental illness, and recidivism is massive in this population. I looked after the UK's most prolific serial offender. They were low-level offences, but there were over 300 offences that this man had committed. He had a brain injury at the age of 18. Nobody thought to ask him about the brain injury, so nobody put any interventions in place. That's quite an extreme case, but more commonly, usually it's about 5 times or more that people have committed offences before even their head injury is recognised as a contributor. Sorry, there's a slight pause as I'm trying to, there we go. We've known about this for a very long time. In fact, the very first case of not guilty by reason of insanity was an attempted assassination on King George III back in 1800. And that was by James Hadfield, and he had a traumatic brain injury. And excuse the language, certainly not language we would use these days, but a brain damaged and deluded former soldier. And you know, we now all know about insanity as a defence. And then we have more notorious offenders. Right in the middle there is Fred West, who you may have heard of. So he was a prolific serial killer who was known in England. And Fred had his first head injury with a road traffic accident, and following that he became a sex offender, and then he had a second traumatic brain injury, and after that he became a violent offender, really very notorious. And in fact, you know, if you read about his story, he actually probably became quite vulnerable to exploitation and coercion by his wife Rose, because it was the pair of them who killed a number of children and hid their bodies in the basement of their house. And then we have Ronnie and Reg Cray, the Cray twins that you may have heard of before if you haven't looked them up. Again, notorious gangsters in London in the 60s who were really untouchable. The police couldn't touch them. They were really sort of ruled most of the East End of London. And Ronnie enjoyed the boxing, and his brother actually knocked him out, and he had a traumatic brain injury. And Ronnie brought down the Crays because he became impulsive following the brain injury, went into a London pub and shot somebody in broad daylight and was arrested. And then the police were on to them, and that was the fall of the Crays. And then on the left, you might recognise this chap. Now, not a criminal because he was a monarch, and monarchs are above the law, right? Not anymore, it seems. So Henry VIII, and he was described as a generous and good king. He then had an accident, fell off his horse and got a traumatic brain injury, and after that he became greedy, he became cruel and vicious, and his turnover of wives increased. But it's not just men who have traumatic brain injuries. Women also, I'll just go back a slide. Either go too slow or go too fast here. So women also have traumatic brain injuries, and the rate of traumatic brain injury in women is increasing. You're having a talk tomorrow about brain injury in adults, and I'm hoping that there will be some time of that devoted to women, because we've seen really a very significant increase in traumatic brain injury in women, nearly a 30% increase over a 15-year period. And there are lots of different causes for that. Some of them are positive. We're living longer, we're driving more, we're going out, socialising more, playing more sports, etc. But also some really negative social elements. We're drinking more as women, and alcohol has a greater effect on our brains than it does on men, even though we don't drink more than men. but also this very important issue at the very bottom, which is often not talked about, but being talked about more, is about brain injury as a result of intimate partner violence or domestic violence. And that's been the subject of a report that I would encourage everyone to have a look at called Too Many to Count. I'll just go back a slide. Apologies about that. And brain injury in women is important because, like men, women who have found and have a brain injury are more likely to commit violent offences. They're more likely to be victims of exploitation and intimate partner violence, as I said before, more likely to have comorbid mental illness, so can be prolific self-harmers in prison with suicide attempts, etc. And they often face different barriers to receiving care than men do, unfortunately. They're less likely to be investigated for the brain injury. They're less likely to receive any help at all. And in fact, at the minute in the UK, there are no specific services for women who have a traumatic brain injury who come in contact with the criminal justice system, none whatsoever. And with criminality, there's been a large study undertaken by Tom Macmillan in Scottish prisons, and he found that 73% of the women in the Scottish prisons had a history of traumatic brain injury. Many of them didn't actually know that they'd had a traumatic brain injury because they called it by different names. A knock to the head, knocked unconscious, punched around the head, strangled. So it's important whenever we're using language and asking people about their traumatic brain injury. And just very briefly, just drawing your attention to non-fatal strangulation as a potential cause for repeated hypoxic brain injuries. And the cumulative effect of that over time, we don't know exactly, but I think we could all surmise that there would be, for sure, issues with the limbic system and with pathways around emotional regulation. We also know that brain injury is linked with suicide. So in the general population, there's a 2 to 3 times increased risk of suicide following a brain injury. It's lifelong and particularly affects adolescents, but even more so in the prison population. So at the minute in UK prisons, there's 4 times the risk of suicide than the general population. And I'm just skipping on because we don't have much time. And there's been a study completed in HMPs, that's a prison, which is called HMP Park in Wales, and it showed that with historic brain injury, there was a 3.3 increased odds of suicidality. Now, whenever I was growing up in psychiatry, I was always told that one of the leading things that increased your risk of suicide was substance use. But look at that, 1.9 increased odds, increased odds with substance use suicidality and 3.3 with historic brain injury. That's really very significant, and again, another opportunity for intervention. So what do we do then? So we know it's common, we know that it's associated with violent crimes, recidivism with really high social load. So what do we do about it? And really what we have done is, as a group, the Acquired Brain Injury Justice Network, you see it up there on the left-hand side, we've looked at how we can, first of all, identify people who have a brain injury in prisons. So the first thing you do is ask about it. So we've managed over the past 5 years to ensure that on reception to prison that there are 3 questions relating to traumatic brain injury that should be asked of every single person who comes in through the door of a prison in England. And then that person is signposted to neurodiversity service managers or to a health professional if there isn't a neurodiversity service manager, who can then ask more in-depth questions. And the BUSY is the most commonly used screening questionnaire that's used, that can be administered by anybody, whether or not they have any training in brain injury. And recently, BrainKind have launched an updated Busy, which is specifically for women and asks questions specifically about domestic violence and non-fatal strangulation. But I don't know about you, but nothing ever beats taking a really good history. And I think we can overcomplicate things sometimes, but this gets the conversation going if you have a screening tool and if you're not feeling confident about the right questions to ask. This is the example of the Busy. And then the next thing we want to do is to understand the brain injury. And we all know that a person isn't their offence. The person isn't their brain injury. The person is the sum of all of their parts. And I think that's something I've been hearing more about the Booty Centre today, that holistic approach to care. It's good old-fashioned formulation. It's looking at someone's cognitive, emotional, behavioural, physical, social, spiritual needs, and how they've got to that point where they've become aggressive or violent and committed an offence. And if you don't understand that, then any treatment interventions that you have are going to fail. So I think I've clicked on a little bit too fast again. My apologies for this. So, you know, you'll all recognise the biopsychosocial formulation. So if you develop a really sophisticated cognitive behavioural plan around someone, but they don't have anywhere safe to live, or they are in pain, then that plan is going to fail. So having that holistic understanding of that person and their context is really important. And that helps us then to adapt any interventions. So if you've committed a sexual offence in a UK prison, you will have to complete a sex offender treatment programme. If you have a brain injury, that becomes very difficult for you. You have to remember to attend your sessions. You have to work in a group. You have to retain the information that you've been learning. You have to go away and do your homework. You have to then reflect on how your learning applies to you and be able to use that and adapt and change your behaviours and demonstrate that. Now, if you've got problems with your memory, with your planning and your processing, with your insight and awareness, and you don't do very well in groups because your attention and concentration isn't very good, then you are going to fail at that programme. So that's why it's so important to be identifying people with head injuries and being able to then put very simple adaptations in place. Now, for some people, an adaptation alone, a sort of simple adaptation, isn't quite enough. There is training available at the minute in the UK for all criminal justice staff. It's called Ask, Understand, Adapt. That's been the titles of my past few slides, and that's available free of charge online. And there's also an organisation called Headway who provide in-person training, and my service also provide that. Every prisoner in England is eligible to have a Headway identification card that they can carry with them in prison, that they can show on the wing to a prison officer if they're struggling or need any additional support. And they also have a link worker service, which is in about 15 prisons now in the UK, where someone will work with an individual who's been identified in prisons having a brain injury, support them through their journey there, and help them with identifying what strategies they will need in the community to successfully relocate there. I'm going to move on quickly just for the sake of time and just talk a little bit about those who really can't manage in the prison setting with those interventions, and who may or may not have comorbid mental illness. And we've been able as an organisation to work with the Sentencing Council to ensure that we don't just have mental disorders and sentencing guidelines, we also have developmental disorders and neurological impairments. And that's really important because that means that there is a means now to transfer somebody from prison into a hospital setting to receive an assessment and treatment. And in the UK, we use the Mental Health Act to do that. These are the I won't go through these, it would take a week, and it's changing anyway soon. But these are the sections that we can use and are available to the court in order for somebody to be transferred to receive assessment or treatment at various stages in their journey along the criminal justice system, from point of arrest right through to into their sentence. And I often get told by my psychiatric colleagues, and Dr. Mehta will have experienced this as well, but brain injury isn't a mental illness. Well, no, brain injury isn't a mental illness, but brain injury can present as a mental disorder. And these are the mental disorders in the ICD-10 that are most commonly used in our setting, and organic personality disorder is probably top of the list there. And I don't need to tell anybody in this room about organic personality disorder. And I think there was a poster boy for ADHD earlier on, wasn't there? So I think this is our poster boy, isn't it? With organic personality disorders, Phineas Gage. So a little bit about our network, just for the final few moments. We have 3 secure hospitals in the United Kingdom who look after people who have brain injury, who've been committed serious offences. My service is the one on the right there, is Lancashire and South Cumbria Trust, and we're the only NHS service. The other 2, so it's National Health Service, the other 2 are in the independent sector, they're private hospitals. And we've got a total of 80 beds. This is a map of the UK and Ireland. If only I knew how to use the pointer. I'm from that little bit over there on the left at the top. This is where the secure hospitals are. I think my geography is roughly right in England. So 80 beds for the prison population at the minute in England is 108,000. So not very many beds, and they're in very limited parts of the UK. So if you imagine, if you come from maybe Cornwall, which is at the very left-hand lower bit of England, and the only bed available to you was in Preston, which is where I work, that's 200 odd miles away from your family. And we all know the importance of having family contact and context whenever you're rehabilitating from a brain injury. It's less than ideal. So this is my hospital. In that picture, it looks sunny. I can reassure you, Lancashire, it is rarely sunny, but it is beautiful. But that's my hospital and that's my service. I'm really proud to be the only NHS service of its kind and flying the flag for people with brain injury. And this is the model of care that we use, and you'll all be familiar with this, a model of cognitive rehabilitation. You'll see there medication does not feature. It certainly does feature on our wards whenever we're treating comorbid mental illness. But we try to have a total environmental approach to supporting people with a brain injury. And I don't know if anyone recognises the game on the right. If you were brought up in the 70s, you'll know this game was brought out usually at Christmas times to create a good argument between siblings, and it's called Kerplunk. And it's an analogy that's stolen from a colleague of mine. So essentially, it's where you put lots of little sticks in, and the aim is to hold up all of the marbles to keep everything in place. And so it means that even if you removed a single stick or 2 or 3 sticks, hopefully the marble should still stay in place. And that's really what rehabilitation does for somebody who has got complex needs. You're looking at all of the ways, all of the strategies that you can either empower them with education, with the psychological interventions, with learning compensatory strategies, or adaptations that are made to their environment to help them to exist in an optimal way and achieve their goals. So just finally then, I just wanted to talk about the UK Acquired Brain Injury Forum ABI Justice Network, a bit of a mouthful, but not as much as it was previously. It used to be called Kujabig, which was not very good to say. So we have the ABI Justice Network now. So we've been around since 2011, and we're a parliamentary lobbying group made up of really a diverse number of people. I think there's only a few of us are clinicians. We've got strategists, people from the Ministry of Justice, police, etc., who are in that group. And what we do is that we look at the full pathway of somebody from prevention strategies right through to rehabilitation, and see where we need to lobby the government to look at how to support people better. We've achieved quite a lot in our time. So We've got Joint Criminal Justice Inspectorate's reports and Neurodiversity and Action Plan. We've been able to achieve that. We've got neurodiversity support managers who previously were just there to support people with autism, but we rode on the coattails of that, and now they have received training in brain injury and will also support people with brain injury in prisons. We have trained the Reconnect service, so the service that follow people through their journey in prison who have complex needs and help them to settle back in the community again. And we've provided them, because this will not be unfamiliar, but brain injury had been excluded from that service. It now is included. We've made sure that the needs of women, specifically in the criminal justice system, are being tended to, with most of the brain injury link workers at the present time who are in female prisons. And also we're looking at recognition of mental health and suicidality, and we've been able to lobby for funding for further research on that, and looking at that integration, as we all are, with mental health. I'm not going to go through the case study because we don't have time, but I love Dolly Parton. Who doesn't love Dolly Parton? And she's really a genius and really sums it up. But you'll never do a whole lot unless you're brave enough to try. Working in the criminal justice system is difficult. It's challenging. There's not much reward, really. Apart from whenever you see the journey that your patients go on, from having no hope, from being told that they're useless, they're worthless, they'll never come to anything, in and out of prisons, never having worked a day in their life, seeing whenever they make something with their own hands and they want to do that as a job whenever they leave, their epilepsy's under control, their mental illness, they're not self-harming anymore, and you know that they're not going to be back in prison again. That's where the reward comes from, but you got to be brave. So thank you very much, everyone, for listening.
It was a very interesting and inspiring talk. Like, as you say, that it is not very easy to work in the justice system, yet alone looking after the the patients with a traumatic brain injury. Just one quickly, when we say that there are 70% of the people do get their TBI before their first offense, and during their incarceration, and the prevalence of concussion. So how do you distinguish, after their incarceration, that is it the concussion or the TBI, and what the different services they will you should do?
It's really difficult, and actually the biggest difficulty we have is the lack of self-reporting. So a lot of the prisoners don't realise they've had a head injury, and a number of head injuries through violent assaults, for example, or through ligaturing, etc. as well. So it is really difficult. I think with that it sort of comes down to their function. So how are they functioning, and is that giving us more of an indication of the type of needs that they might have? Which is why sometimes I know we're sort of forced into saying, is it a mild, moderate or severe traumatic brain injury, which is important for prognosis, but actually somebody's functioning could be really very impaired after a mild traumatic brain injury, and that's probably more what we look at. And then it's important to think about recovery and rehabilitation potential as well. And we think that's really important, particularly if we're thinking about, do we support somebody in a prison setting, or do they need more intensive rehabilitation in a hospital setting too? So I'm not sure if I answered your question, but yeah, it can be challenging.
One quick one from me, Zarina. It's a fascinating job you're doing. I think you've been very modest in telling about brain injury and management. It's just the tip of the iceberg, I guess. There lies a lot of things beneath it. The personality vulnerabilities, the traumas, the substance use disorders. But one thing which has intrigued me a lot is the ADHD and the brain injury. And it's quite fascinating not to see the medication in your holistic treatment. So how do you, because if it's a concussion, mild TBI, and if you're not missing on ADHD, then obviously there's a recurrence of that is very high. So how do you deal with that?
Yep. So I've not mentioned medication, mainly for the sake of time and to keep the presentation focused. But yes, we see ADHD extremely commonly, and undiagnosed or misdiagnosed ADHD. So these are kids who have really had the worst of upbringings, who've slipped through the net on every level, and have just been labelled as being problematic. You know, I don't know if it's the same in the rest of the world, but certainly in the UK, if you come from a middle or higher income family, you're more likely to receive that diagnosis of ADHD because you can access it privately. So they slip through the net, and then they come to our service, and it is like, you know, broad daylight that they have that diagnosis. We do the assessment, we start the treatment, and it's like a light switch. And for many of those people, actually, then they wouldn't have been able to access the rehabilitation strategies unless they had the treatment for their ADHD. Similarly, psychosis. Lots of people coming through with psychotic illnesses and with comorbid autistic spectrum conditions as well. So that's why we have neuropsychiatry as well as neuropsychology, so as we can do that holistic assessment.
Beautiful, thank you.
I had a question. Hey, can you hear me? That was such a beautiful talk. Thank you. Something you bring up, I think, is kind of like an empathy deficiency, right? I think that a lot of these kids are labeled as problematic kids and people who are doing, you know, they're just bad folks or whatever. And then you also simultaneously bring up Phineas Gage, and, you know, is there, in your estimation, I guess one is, how do you tackle like an endemic of empathy deficiency? And then I think a corollary to that is there a role for basic neuropsychology education, to your earlier point? Maybe if folks kind of understand that damage to the material brain causes things which look like a moral problem, then maybe that's a way of engendering empathy, or is that like not a strategy that you think would be effective, or what?
I think you almost answered the question I was asking. I think you're absolutely right that, you know, these are people who are so marginalised, aren't they? And I think uniquely as psychiatrists, we get to look after the whole person and understand context. I don't want to label surgeons, but as opposed to a surgeon who's faced with an organ that is damaged and they repair the organ and they go on their way. We can't do that, can we, as psychiatrists? So I think we do have a role and a social role. And I think education about the brain needs to start at an earlier stage in schools. You know, not just to be restricted to biology, GCSE or A level, and that better understanding, I think, will help. But I think also the role of adverse childhood experiences as well on brain development, and how I think we often neglect that whenever we're taking a psychiatric history. We don't think to ask about that and the impact that has on brain development and then on the development of that person's empathy. So I'm not sure if I've answered the question, but I think for me it's just about whenever we see a marginalised, you know, section or group of people, we need to think why, and to be the ones who are kind of there trying to improve the empathy.
Can I have the introduction, please?
We welcome Professor Michael Kaplan joining us from US Online. He is currently is at a Khan School of Medicine at Mount Sinai, and he is a rheumatologist and a clinical educator. Welcome, sir.
Hello. All right, let me try and share my screen here. 1 second. All right, can you guys see this? Thumbs up. All right.
Yeah, we can.
Mike, perfect. Mike Kaplan, Mount Sinai Rheumatology. What a pleasure it is to be here, and thank you guys so much for having me. Again, Dr. Kirk, thank you for the beautiful talk. It's a tough act to follow. Okay, neuromod and nosoplastic disease. This is a huge topic, and it's one that I lack the expertise and time to do comprehensively. But what I'm going to do on behalf of my mentor, colleague, and friend, Trung No, and myself is basically explore a little bit about a neuromod technique called vestibulocortical stimulation, which is quite literally pouring water in people's ears, and kind of figure out like what that has to do with pain. We don't have a ton of time, so I want to dive in and be respectful. I think I'm one of the later talks. These are my disclosures. I am an author for some of the up-to-date content on fibromyalgia, and clearly I speak for myself and no one else. And I'm also a consultant for a few groups, none of which has any relevance to today, other than Tonix, which is the pharma company which came out with the new fibromyalgia medication. The biggest disclosure, I think, is just like I'm a rheumatologist. So like, why is there a rheumatologist at your meeting, right? And so that kind of like brings us to like a little bit of the roadmap, right? So I want to share a little bit about my story, help you figure out like how I wound up here. And then I wanted, before we get into cold water, talk a bit about transcranial and vagal nerve with full understanding that folks on this line are more expert than me at them, just as a way of comparing vestibulocortical stimulation to them. What is it? Why? What's the deal with water in the ears? How is it discovered? Diagnostic versus therapeutic? And is there a role for this in nociplastic disease? And so for me, when I was in high school, I was wrestling with a buddy and I fractured tib-fib and I developed complex regional pain. And it was a fully encompassing, isolating, total and complete miserable experience. Maybe common sense posing as insight, but I mean, wow. That, you know, sparked from there this long-standing interest in pain and consciousness. Consciousness still is the most interesting problem in all of medicine, the mechanism by which the brain, a blob of meat in the cranium, generates the subjective experience of being alive, the misery of suffering, the taste of cheesecake, the ecstasy of orgasm. The means by which this happens and the language of physiology, in my opinion, remains more interesting than all of the cytokines combined. And perhaps I'm speaking to some neuro folks who might not disagree. But anyway, I'm preoccupied with this. And when I started this interest, it was kind of juxtaposed with the vulnerability of being a patient. And so I went to med school to be a neurologist, like Oliver Sacks. Specifically, I was going to be Oliver Sacks, which did not happen, Oliver Sacks. But I did end up naming my son Oliver, who's right here on the little bus. Okay, so before I went to med school, though, I studied neuro in college, and I came across some Ramachandran. And he had published a case series at the time on thalamic pain syndrome, which sounded a lot like mine. He said it was among the most spectacular, distressing, and intractable pain syndromes. And there was a case report of 2 people. He poured water in their ears, literally, and they got better. And I just remember thinking, wow, that's something. Okay, so fast forward to medical school when there was a case that changed my life. There was a young girl, she came in with pharyngitis and fevers, and it was diagnosed as strep. It was treated appropriately, and then she developed this awful pain syndrome with headaches and diffuse abdominal pain, full body pains, kind of with this like right-sided predominance, fatigue and functional incapacity. She was a dancer and like a very affable, popular girl, and now she was kind of confined to the dark in a wheelchair. It was a very dramatic case. Extensive diagnostics were unrevealing. I was a med student on pediatrics at the time when she came in with a diagnosis of PANDAS, a pediatric autoimmune neurologic disease associated with strep. And she was treated with multimodal therapy and was still fairly miserable. And so on exam, again, she's withdrawn and laying still in the dark. She has this diffuse body pain syndrome with a right-sided predominance of kind of allodynia. And so the question I had was, this looks a lot like thalamic pain, diffuse body pain with unilateral predominance. Is there a role for vestibulocortical stimulation? And so the family and the medical team, everyone was kind of exhausted. And right before she went home, we got consent and they let us try. And so that's what we did. We poured cold water into her left ear for 15 seconds, and it was prematurely terminated secondary to her, you know, she was screaming and crying. And surprisingly, was kind of bicycle kicking both of her legs. This was the first time she had moved her legs like this in months. And then 5 minutes later, there was objective improvement in the allodynia, range of motion at all of the large, medium, and small joints. So her mother said she went home, and on the way home, she fell asleep and awoke a new child. with resolution not only of pain, but of all the avoidance behaviors and things like that. So she came back 1 week later and now was walking. And then again, we did bilateral vestibulocortical stimulation at the time. And there was again mild incremental improvement. And then over time with multimodal therapy, including psycho and physical therapy, she made a complete recovery. And over 10 years later, I checked in with her mother and she's a healthy, well-adjusted teenager studying art with no pain. And so that case for me is just kind of like when everything changed. And so we're going to come back to water in a bit. The question is like, is that a fluke? Is this placebo? Or is this consistent with kind of an interdisciplinary body of data which suggests there may be something here? Hard left turn to fibromyalgia, which I see all the time in rheumatology clinic. 3% of the general population, 25 to 40% of people with inflammatory disease, we see it all the time. Diffuse pain associated with fatigue, unwellness, poor sleep, etc. It's the flagship nosoplastic pain disorder. So nosoplastic disease, just to be clear, a word, a concept defined by the IASP, the International Association for the Study of Pain in 2017, to distinguish it from nociceptive, the classic anterolateral, spinothalamic tract, step on a nail, I have pain. Distinguish it from neuropathic pain, injury to a nerve. Nosoplastic is this kind of central sensitization hyperamplification problem, right? Which is, of course, not a diagnosis of exclusion, is often superimposed with other peripheral drivers of pain. It's associated with the chronic overlapping pain conditions, which is down here. This is not a Kaplan thing. The NIH recognizes 10 overlapping chronic conditions, which are thought to have a primarily nosoplastic driver. The only one missing from here is chronic low back pain. Okay. Medications for fibro are insufficient, which actually, again, maybe common sense posing as insight to people on this call, but in my land, in rheumatology, if you guys present with a symmetric small joint polyarthritis or a big red knee, I have a magic med called prednisone. It's actually magic, penicillin adjacent. And then, of course, Humira and everything downstream. In 2025, if you present to my clinic with nosoplastic pain, I do not have a magic bullet. And so the standard of care is really a multimodal approach. And the question is neuromod an evolving mode? I think so. And so we'll talk quickly about transcranial and vagal nerve before we get to cold water. Also, being mindful that there's much more, right? There's transcranial direct current stimulation, transcranial alternating current stimulation, transcranial random noise stimulation, TENS, pulse electromagnetic field therapy, which my colleagues in ortho use for bone stimulation, and much more. I bring up this list of stuff because what we're trying to do is use non-pharmacologic, invasive or non-invasive neuromodulation techniques to improve human life. That's just what we're doing. And so before we get to cold water, I want to just kind of go through a few of the ones with a bit more robust backgrounds. So no question about it, transcranial magnetic stimulation has the most data in terms of a non-invasive neuromod technique to support fibromyalgia, use in fibromyalgia. So it is not FDA approved or cleared for fibro, although it is, as many of you know, for depression, OCD, some kinds of headaches, even 2020, I think there's a smoking cessation. So it's used in other neuropsychiatric disease, and yet for fibro, it seems to work. There's over 20 randomized controlled trials, generally small, though consistent findings, which is that applying a magnetic coil, generally a stimulatory stimulus to primary motor cortex on the left or dorsolateral prefrontal cortex on the left, seems to help human beings with fibro feel better. Less pain, less anxiety, pain intensity, improved functioning. There's some variability in protocols. There's an inhibitory frequency given sometimes to the right frequency. Rapid response. The mechanism of action not yet fully understood. I read all kinds of things. I read about improving descending pain inhibition. I read about modulation of our favorite neuroamines, monoamines rather, dopamine, norepinephrine, serotonin, etc. I read about close kind of synchronization of primary motor cortex with somatosensory cortex and modulation of thalamic firing. I think it's anyone's game. It's not yet fully understood, and yet empirically it works. And so I thought this was kind of funny. There's like over 20 RCTs which suggest efficacy, and then the European expert group gave it a level B with probable efficacy. Okay, And then there was a large RCT done this year that was in the news. This was it was a large multi-center international RCT, I think rooted in Brazil, including folks in Japan and France and maybe elsewhere. 101 women were randomized between the coil, which was primary motor, versus sham. Folks got better. Their primary outcome was percentage of folks who got better over 50% in 8 weeks. There was a whole protocol. The protocol, by the way, including induction and maintenance. Induction is daily magnet versus maintenance with weekly. It ends up getting expensive. We have a magnet at Sinai. I think for a similar protocol, it's several $1,000s out of pocket. So beyond the magnet, something which is really having its time in the limelight is vagal nerve stimulation. Again, there's several neuropsychiatric indications, and most recently it's approved for rheumatoid. So this year at our national conference in rheumatology, which is the American College of Rheumatology, talk was a buzz about neuromodulation. It was very interesting. And it was because of the new indication for the left cervical vagal nerve implant for moderate to severe RA. So what about in fibro, which is the flagship nociplastic pain disease? There's a few proof of concept pilots. There's one going back with my colleague Ben Nadelson in 2011 and his colleagues, which looked at 14 folks who had an implantable vagal nerve stimulator. It seemed to work, although it's preliminary pilot uncontrolled. And then there's 2 pilots from Italy in 2025 looking at transauricular vagal nerve stimulation. The first here seemed to help pain, and the second one, interestingly, demonstrated improvement actually in autonomic function, at least per the COMPASS, which is a subjective report thereof. And so, again, the implantable versus the transcutaneous auricular, there's multiple branches of the vagus nerve which innervate the ear. You stimulate the tragus, you stimulate the concha, there's an earpiece, there's an electrode. There's a bunch of, this is like its own universe. And particularly in the rheum world, there's a lot of exciting things about like what's called like the neuroimmune reflex. And so I think a vagal nerve talk is its own talk. So those are kind of like where the buzz is. And I'm more interested in this kind of cold water thing because of my experience and then everything I've learned since then. So briefly, and I want to be mindful of everyone's time. I think it's late over there. Robert Barany is considered the father of the caloric test. Basically, he was working at University of Vienna at the time, and he was basically irrigating ear wax out with water. And it was known that particularly when patients are supine, you pour cold water in their ear, they have this kind of vigorous nystagmus with nausea, vomiting, etc. And he was perhaps the first responsible, or at least he's given credit for the discovery of asymmetric nystagmus being a way to diagnose peripheral disorders of dizziness by bedside. He ended up winning the Nobel Prize in 1914. There's a great article I put down here by Robert Ballo at UCLA. It talks about how the Nobel Prize was won in 1914, but this was when World War I started. This was in Vienna, and right around Archduke Ferdinand. He actually got swept up into the war, was a prisoner of war, and actually accepted the Nobel Prize in 1916 when he got out. It's a very interesting history, so if anyone's interested in it. Robert Barany would have multiple strokes in later years of his life, and he had devastating thalamic pain. If only he knew, of course, that his own procedure might have helped him. A few caveats before we proceed. There's multiple ways to stimulate the vestibular system, including using temperate air, different temperature air, different temperature water, and then galvanic is using an electrode on the mastoid. And there's slightly different mechanisms, but today what we're talking about is water, because this is almost all of the data is in water caloric stimulation. And then just in terms of like acronyms, so there's caloric vestibular stimulation, there's vestibular caloric stimulation, there's vestibulocortical stimulation. It's confusing and contentious what to use, but just VCS is literally pouring water in the ears. So that's where it comes from a diagnostic perspective. We could use cold water to diagnose peripheral disorders of dizziness, and this is indeed what we're taught in med school. But can it do stuff? Can it actually serve as a therapeutic form of neuromod? Well, in 1940, there was a case report of someone with a huge right frontal lobe tumor, seen here, with left hemineglect. And sure enough, left ear cold water, pouring it in the ear, kind of restored a left hemineglect with improvement of being able to read on the left. And then likewise in the 80s, there's another case report of left-sided hemineglect. And so we have these 2 case reports which suggest that pouring left ear cold water vestibular caloric stimulation. So this is well before neuromod. And the idea was that The rapid side, when you pour it in cold water, the rapid side is opposite, and then the slow side is ipsilateral. The idea is that when there's a slow side, there's something called past pointing, and then there's also kind of like a general preference towards that side. So the idea was that maybe we could bias attention towards it using that. And they had no idea they were also engaging in neuromodulation, but that's what happened. So in hemi-neglect that started, there's 2 case reports, and then finally there's a case series of 18 people, again, trying to use vestibular physiology to retrain hemi-neglect, trying to harness what happens with the slow phase of nystagmus, thought to just drag people's attention into that space. And so left-sided hemi-neglect, right side brain lesion, so left ear cold or right ear warm, and then 17 out of 18 people had improvement in hemi-neglect. So the origins of this as a therapeutic modality just go back to hemi-neglect and attention. So this is a paper from Trung. This is from 2007 and still, in my opinion, is the best review paper on the topic, which reviews the multimodal cross-faculty effects and basically talks about the changes that happen in memory, attention, cognition, perception, and more. In figure A, this is what it looks like. There's a human who comes in and they lay down, you put a pillow under their head, roughly angle it 30 degrees to the horizontal. What happens is the lateral semicircular canal inside, it actually is positioned in such a way that when the ear, when the head is 30% to the incline, it basically is fully vertical. And then you pour in cold water, which changes the density of the endolymph in the lateral semicircular canal, creates convection currents, blah, blah, blah. Basically, it's just stimulating the ear through cold water, which changes, like I just mentioned. And then you have bilateral hemispheric stimulation with predominantly contralateral activation of multiple areas in the PIVC, parietal insular vestibular cortex, and multiple areas associated with pain, including ACC and insula and TPA and stuff like that. So that's what it looks like, is in figure A. In B, again, this is hemi-neglect. You pour cold water in and you rescue the left side of space. And specifically, it's lateralized, so it's left ear. C is phantom limb, which we'll talk about in a minute. Unusually, as we all know, amputees will sometimes have pain in a phantom limb, or they'll have a deformed phantom limb. And pouring cold water in people's ears somehow rescues the sensation of a normal phantom. And then D is some of the work that Trung did a while ago, looking at the frequency with which people attend to either horizontal or visual lines as a function of having water in their ears. Yeah, we'll get into some of this stuff in a minute in terms of pain. It's also being investigated for migraine and Parkinson's. There's some mechanistic work about how this could work for pain. Here's an imaging study which shows increased opioid receptor binding with vestibular cortical stimulation. I think what's happening from a mechanistic standpoint is that we're kind of flooding we're flooding an area which is robbed of afferent input, right? So some of the data here is with thalamic pain, which of course all the afferent information beyond olfaction takes a pit stop at the thalamic. Also, transverse myelitis. I think when there's a sudden decrease in afferent information coming in, the downstream areas have a problem. I think vestibular cortical stimulation is just a rapid way of kind of getting them going again, which is just a crude mechanistic model that we don't have time to talk about. Some data about cold water and what it does. So it modulates body scheme and pain. And again, phantom limb is probably the best example of this. 31 amputees were grouped into no phantom, or a deformed phantom, or pain. And then when you pour water into the ears, unusual things happen. Folks with no prior phantom, 94% of them, had a new normal phantom. And it lasted a few minutes to hours. The deformed or painful phantom group, 100% of them had a normal phantom with no pain. So the idea is that pouring cold water may trigger reconstitution of global body schema. This is an interesting case report, and it's basically there's hemispheric lateralization of function of a lot of things. Whether or not there's lateralization of mood, it's kind of a complicated idea, but generally speaking, I think that we think of irrigating kind of the right hemisphere with kind of like the more avoidant, depressed phenotype, and the left with being more stimulatory. And so this was a case of really severe bipolar. So a 29-year-old woman with really bad mania, and it was refractory to everything. And so cold water into the left ear, which is right hemisphere predominantly, and it seemed to help her mania, right? So the right hemispheric activation seemed to kind of calm things down. This is the Young Mania Rating Scale, which I learned about. It's just a composite score for the intensity of mania, and you see it lasted here a day or so, and then it got better. And again, it improved when we did it again. So just a case report. And then, of course, it modulates pain. So there's a bunch of different case reports, which again show transverse myelitis, thalamic pain. I was thinking about, as a rheumatology fellow all these years later, I was thinking about that initial case report, right? So she had no identifiable structural lesion. It was not thalamic pain. And so that just looks like diffuse body pain. And that's what we call fibro. There are striking similarities to that in some of the overlapping chronic conditions, including chronic fatigue. And so we do a bad job of treating this. And so my question is there a role for vestibular calorics in fibro? And so I reached out to Trung in December 2020, and what I thought would just kind of be like a brief conversation turned into a long-term collaboration, and I'm grateful. And so this was our first pilot, and what we did was we had 21 people with refractory fibro from our rheumatology clinic, and we poured cold water into their right ear once. And at 5 minutes, there was a remarkable drop in pain per minute. And at 30 minutes, it persisted. At 24 hours and 1 week, it persisted. And this is interesting. This over here, the orange figure. So this is a subjective well-being scale. It just says, hey, on a scale of 0 to 10, 0 is terrible, 10 is great. How do you feel? Cold water in the ear is a notoriously uncomfortable procedure. There's also a kind of implicit understanding that it's like torture, and it's in part because it's done in addition for bedside diagnostics for dizziness. It's also used to confirm brain death in the ICU. So folks are like, how could you do this? And so interestingly, at 30 minutes, even though the procedure itself is uncomfortable, people felt better, not only in terms of pain, but overall well-being. This is just a graph showing, so the 0 to 6 days on the left, this is just an average summation of daily entries into a pain diary. And then after cold water across our group, it goes down. Being mindful of the fact that this is kind of a mean across people for whom it worked beautifully, and for some folks it didn't touch at all, right? This is just an uncontrolled preliminary pilot. And then here we have the tolerability data. So most people found it uncomfortable or painful, and there was some headache and nausea. The mean intensity was moderate, and if you look at the bottom, would you repeat this if it reduced your pain for over a week? Most folks said that they would, about 90%. And so folks, the tolerability specifically for folks in a chronic pain cohort is notable. Folks did quite well. Another interesting finding that we found, which wasn't included outside of a sentence, was that there seemed to be suggestion of improvement in fatigue. And that was with incomplete PRO data. And so we did another follow-up study, one to confirm what we found, because it's weird, right? And the other is to kind of more comprehensively evaluate the secondary outcomes. We also wanted to do this in the ME/CFS population, in the chronic fatigue population without pain. And what I was hoping for was kind of like my pediatric case. I was hoping that neurostim via right ear cold water calorics would kind of resurrect them. That's not what we found. But quickly, this was our follow-up pilot. Again, the folks who had pain felt less pain quickly. So we looked at 30 minutes. And again, it helped some people a lot. It helped some people not a lot. This is the average. One way of helping to make sense of that noise is looking at the percentage of people who got better, 30%, 50%. So 30 minutes after cold water, about 20% of people had a 50% pain reduction. And these are small numbers. So, and then 24 hours, closer to 40% of people had a 50% pain reduction. So it seems, again, to be helpful with pain. It also is down here with pain intensity, pain interference. It seems to be doing something. Okay. And then again, folks got better. This is data from the COMPASS. The COMPASS is again a patient-reported outcome which looks at autonomic distress, symptoms secondary to autonomic distress. And we see here that autonomic symptoms were improved really out to 4 weeks in the chronic fatigue data, and in fibro it was out to a week or so. Importantly, it did not, resurrect them from their severe fatigue. Their post-exertional malaise was kind of unchanged. But the COMPASS autonomic data is intriguing. It's interesting. And then again, the safety and tolerability was, again, it was just found. So while discomfort and pain is fairly common, it's of a moderate intensity of around 5. Vertigo is universal. I don't know why it's not 100. Whoever didn't report vertigo was lying, or we just didn't do it correctly. But by definition, it stimulates the vestibulo-ocular reflex, and everyone gets vertigo. And then headache, nausea, it's all mild and moderate. Then again, if it reduced your pain in half for a week, then the vast majority of people do it. So this was presented recently at at a conference in Austin, Texas, where we show that it's found to be safe and well tolerated in the large majority. And the common misconception that this is too uncomfortable is just not true, at least in my experience. I've also, of course, done it personally many times, and it's uncomfortable, and it's okay. So this is the sham controlled trial we have coming up. This is all preliminary data I mentioned, and so we really want to test it against a placebo, which is cold water in the right ear versus body temperature water, which should do everything except stimulate everything we mentioned before. And we're going to look at pain, and we're going to look at patient-reported outcomes, and I think what we're going to find is consistent with the other data from the interdisciplinary groups, which is that this probably does something for some people. And so I hope neuromod, generally speaking, will become part of the standard of care. For right now, there's obvious barriers, including finance and access for the magnet. Vagal nerve stuff is still going on. And, we need a bunch more data. There's also, particularly in my world and room, there's an appropriate and intuitive skepticism of neuromodulation. We're much more couched in pharmacologic biologics, although they've just failed so spectacularly in the world of nociplastic disease. I do hope neuromod will come to augment what we already have. Also, combination therapy, as we understand the different mechanisms of action, maybe there's a role for using multiple. So induction versus maintenance. If I'm treating a patient with vasculitis, we might use IV cyclophosphamide and oral azathioprine or something else later. Likewise, maybe there's a role for induction with magnet, maintenance with vagal, or induction with cold water and maintenance. So who knows? It might also be driven by comorbidities, inflammatory arthritis with vagal nerve, maybe. Access is huge. I just wanted to flag this, and then I will stop talking. The access is a huge issue here. So cold water is implementable around the world tomorrow. It just requires a syringe and water. So that's something really enticing about this. And so yeah, I'm grateful to be part of several interdisciplinary teams here at Sinai with our Long COVID Center, with our neurology colleagues. I'm really grateful for them and my division for helping to facilitate this. And then I have partners over the country, all over the world. Again, we just presented this at the American College of Rheumatology, and there's several folks in other institutions who expressed interest. And hopefully, maybe just by talking about it here, there will be a person or two who may be interested in collaborating moving forward in our collective efforts to kind of figure this out, to refine the effect, optimize the protocol, and get this on the menu of potential options, which seem legit, and to help folks who are suffering from nociplastic disease. So that's it. Fibro is common and challenging. It requires multimodal therapy that frankly do not exist in many healthcare systems, including my own. Neuromod's an evolving novel modality. Transcranial by far has the best evidence. Vagal nerve's having a moment, which I don't mean in a disparaging way. It's just an exciting thing which is coming about. And cold water is where my heart is for the reasons we discussed. I think it has remarkable potential. I just think it needs a ton more data. The world first RCT in this is coming. And I'm really grateful for all of you and for my division and for folks at Sinai here and abroad. And there's a bunch of references. This is Oliver and his sister Phoebe hanging out in a rock in Central Park. And thank you guys so much for your time. I'm happy to take questions if we have time.
Thanks, Mike. We're mindful of the time as well. We are well past the time for closure, but very fascinating work, especially for these population who struggle a lot. As you rightly said, there's no real intervention for fibromyalgia or CFS. I think the thing for me is both of these are chronic conditions, and your intervention to me seems to be like something they have to have regularly. Is that correct? And if that is the case, do we have looked at the long-term side effects of this treatment? And number two is you also looked at the fatigue, but what about the other components of CFS and fibromyalgia, especially the cognition, which seems to be pretty big in this population as well? Are you going to look into that as well? So the two questions are the long
questions. Yeah, great questions. With regards to the repeated serial irrigation and the potential downstream effects, the procedure's been used in routine bedside diagnostics since 1906. And there's not been a report that I'm aware of that there's any problems with it from the ENT or neurology worlds when someone's gotten it, you know. But it hasn't been formally investigated, no. And so it needs to be. And then will it be over time? Absolutely. And so that's something that we need to look into. And then the second question was about cognition and cognitive fog. That is a great point. No, and I hope to pick this up from some of the PROs that we're using this time. Although the trial is really like 4 weeks long, because as you know, it's really hard to run a clinical trial. So I'm going to look for a signal of efficacy, but you know, maybe sometime down the line there will be some like 6-month follow-up or something. But all great questions. And thanks. Yeah.
Thank you for sharing the personal story. Thanks, Mike.
Thanks, Mike. Yeah, just have one question for you. It's a very nice presentation. How long the effect seems to last in these interventions?
Yeah, so in the first pilot, we found it lasted up to a week. In the second pilot, we asked folks, how often would you want this if we offered it to you? And almost everyone, the vast majority of people, over 80%, said every 2 weeks. So it's probably going to be a week or every 2 weeks. You know, this is I use Enbrel every week. I use Benlysta every week to treat RA and lupus respectively. So this is just, you know, part of chronic disease management.
Savira to felicitate our speaker, Dr. Zarina Kirk, in a traditional way. So Savira is our head of HR and operations. So HR is the justice system. I think that's the wrap. Thank you, Professor, for joining us. We'll be closing the session.
Yeah, thank you.
And thank you everyone who is online for joining us. Thanks. 15 dots. See you at the dinner.